station, which was upstairs yesterday. We brought it down here today. And the toilets are on the left as you leave this hall. And then we have booths as you go along the way, yeah? And we have, in case of need for ambulances, there are medical emergencies. We have ambulances, and we have people. Lucia, are you here? Lucia or ZP? In case of emergency, they're the person to talk to, or anybody from the ambulance. They are around, but not necessarily in this hall. Anyway, yeah, that's it.
So for those of you online, please do remember to put questions on the platform. There will be someone in the room here that will be able to ask the question for you. And a reminder to everyone that there is poster voting through the app and the online platform, so please vote for posters. There will be prizes at the end of today. And again, we have a tight schedule, so please try and come back on time from breaks, and speakers try and stick to time. All right, now let's get underway with the day. So, to start with this morning, we have an online presentation. So it's a spotlight on mental health in children. So child survivors of conflict and recovery in mental health and psychosocial support. So we have Mariana Duarte, who is a clinical psychologist and one of the mental health advisors for OCP. And we also have Dayad Al-Menizal, who is the mental health activity manager at the OCP project, Reconstructive Surgery Project in Amman, Jordan. So they will be joining us virtually. Dayad, are you ready?
Yeah, hello.
Good, take it away.
Yeah. Hello, thank you. Hello, everyone. My name is Dayad Al-Menizal. I'm the mental health activity manager at Reconstructive Surgery Hospital, Jordan Project. And I'm here today to share real life stories about child survivors of conflict and recovery in mental health. I'm here today to share the hidden impacts that conflict have on children, what helped them to feel hopeful even when their memories are filled with pain and sadness. So Reconstructive Surgery Hospital for War Wounded started on 2006 as a response of Iraqi conflict. Then it's expanded to Yemenis, Syrians, and Palestinians. The project offers orthopedic, maxillofacial, and plastic surgery, as well as physiotherapy and mental health and psychosocial support and care for the patient. From 2006 to this year, we had 7,000 admissions, of which 20% were pediatric. Absolutely, conflict has major and far-reaching impact on families and community, especially when it comes to children's health and development. Conflict sure have an impact on children's rights. It's impacted education system. Many children in our project shared that they spent many years in hospitals or seeking treatment rather than attending school. It's also impacted their safety and protection. Children reported that they're exposed to violence and abuse. It's also impacted their health. I remember some children, they shared that they did a surgery without anesthesia. And all of these have an impact on their psychological well-being. And this drawing, it's a child express how she feels when she received a call from MSF that she will be admitted here to our project and receive treatment. mental health unit or mental health department here in RSH providing a specialized mental health care for both patients and their caretaker to reduce the risk factors, strengthen protective factors, improve their well-being and mental health well-being, and reduce anxiety and negative effect of stress. In addition to that, to help them to cope with their injuries and their medical situation. Our data showed that trauma-related and depression are the most common syndrome among our pediatrics. So in this picture, it shows how a 5-year-old expressed his PTSD symptoms during a play therapy session. And the other one shows how a 14-year-old child expressed her nightmares and how she feels before sleeping. In addition to other mental health issues or symptoms that we are seeing here in our project, such as stress reaction, PTSD, sleep problems, non-organic enuresis, separation anxiety disorder, and other anxiety disorder. And this is what we expect when we start receiving patients from Gaza, special children. So the multidisciplinary mental health team and the combination of our department help to improve physical, mental, and social well-being for children, and they promote resilience and self-help by allowing children to express their traumatic experience in safe environment and engaging them in our social activities. So assessment, in addition to our standardized assessment tools, we also give them space to their fears, so drawing and drawing. As you can see, art or play can help children express feelings that are difficult to express through words. So many stories we received through art. We also provide specialized psychological support, individual or group therapy for a pediatric. And I like to share with you this drawing. This child, she believed that psychotherapy brought back to her missing pieces in her heart. So this is how they feel after the psychotherapy session. Also, peer counseling by motivate our patient, sharing the experience, empower them, and help them to cope more with their pain and their injuries. That's why peer counseling is part of our care and mental health care that we are providing to the patients. Also, we are supporting caretaker to increase more the positive parenting strategies, decrease their skills, and to help them how they can manage and how they can support also patients with disabilities or with injuries. It's important to provide children with routine and activities that help them to adjust to situation and to help them to return to normal life as soon as they can of life, and give them the space to play and to learn. And now I want to introduce Ahmed, our hero. Hello, Ahmed. كيفك؟ تمام. Ahmed, he will talk more about his experience in this project and
son expérience dans ce projet.
So to save the time, we already answered what he will share in English. Yes, Ahmed.
Hello, good morning. My name is Ahmed Bashir. I am from Yemen. I am 17. عندما كان عمري 4 سنوات تصوبت بسبب الحريق بالأسيد. كان أكبر تأثير في حياتي. فقدت طفولتي وحياتي. مضيت باحثا عن فرصة علاج. كان العلاج تكلفته عالية. عندما تعرفت على منظمة أطباء بلا حدود وبدأت رحلتي في منظمة أطباء بلا حدود صار عمري 8 سنوات، وبدأت حياتي تنقلب رأسا على عقب بسبب الحروبات والنزاعات لحياتي الاجتماعية. كان تفكيري عن دراستي السابقة مليئة بالتنمر والضرب والإهمال. أول ما دخلت منظمة أطباء بلا حدود كان أعتقد أن الأمور معقدة ورحلتي مليئة بالعمليات والألم مثل باقي المستشفيات. كان دائما شعوري قلق وخوف محيط حتى بي. عرفت إن في مدرسة في مستشفى، فكرت راح أمر بنفس الشعور ونفس الوجع ونفس كل شيء في بلدي بالتنمر، لكن الوضع كان مختلف تماما. كانت المدرسة رائعة جدا. كانت تراعي صحة الأطفال ونفسية الأطفال. تعلمت الكثير، الكتابة والقراءة والحساب وقليلا من الإنجليزي. تواجدها الحلول. أذكر عندما نجحت بكيت من كثر الفرح. كوني بتابع منظمة أطباء بلا حدود من فترة طويلة وعوام، تعلمت من قسم الصحة النفسية الكثير من الأشياء. تعلمت الدعم، تعلمت أواجه الحياة وخرجت من سور المستشفى، وتعلمت الثقة بنفسي وجميع الأشياء. الحمد لله. سبب الأمور الوقت بالعمر. المراهقة زادت رغبتي في التعلم الكثير والتعلم حتى أن أنجح ويكون لدي مستقبل جميل. من ضمن هذه الأشياء تعلمت مثل الالتحاق بالتدريب المهني والنشاط والفنون والمشاركة في الأنشطة.
So our project, it's more than a project. It's a provide a real support to children and their caretaker. And we hope نتمنى أحمد بالمستقبل نشوفك دائما بصحة كويسة. We hope a good mental health and medical also a treatment for أحمد. شكرا كثير أحمد. Thank you all.
Are forcibly displaced. Good morning. It is an honor to be opening this panel today. I would like to turn our attention to this crucial topic, MHPSS, Mental Health Psychosocial Services for Children Survivors of Conflict and Recovery. We live in a time of multiple humanitarian emergencies where, according to UNHCR, more than 100 million people globally are forcibly displaced. Around 41% of them are under the age of 18, forced to leave their homes in extremely difficult conditions without access to even the most basic essentials for day-to-day living. Having already faced stressful events, in moments of crisis and emergency, it's often the most vulnerable among us who suffer the most. Among them, our children bear the weight of uncertainty, fear, and trauma. Added to this challenge, the conditions in which many people in conflict areas live on a daily basis are the incessant sound of explosions, constant uncertainty about personal safety, and the frequent loss of loved ones, leaving deep emotional scars. When conflict strikes, the immediate focus often revolves around physical safety and basic needs. However, we must not overlook the invisible wounds that trauma inflicts upon young groups. The emotional scars can endure far beyond the visible destruction, hindering the long-term well-being and development of our children. Most mental health conditions arise early in life, with 50% arising before the age of 14. Additionally, millions of children and young people experience psychological distress, which can be caused when they are exposed to poverty, violence, disease, or humanitarian crises. This can cause significant impairments to their functioning and hinder healthy development, putting children at risk of more severe conditions in the long term. Although all children naturally demonstrate resilience in the face of distress, their developmental stage, source of support, and access to basic needs can influence their ability to successfully cope with adversity. A key factor in their resilience is adequate social and emotional support and responsive care from a caregiving figure. MHPSS initiatives aim to restore a sense of normalcy, rebuild resilience, and empower children to navigate the challenges they face. By prioritizing mental health and psychosocial support for our children today, we invest in a generation capable of overcoming adversity and building a more resilient society tomorrow. Mental health is an essential component of human well-being, and yet it is often relegated to the background in conflict situations. Resources are scarce, healthcare facilities are overwhelmed, and stigma around mental illness prevent many from seeking help. Access to mental health care is recognized as a fundamental human right. Emergencies should not impede children's right to receive appropriate support. It is therefore imperative that we do more to ensure that mental health services are accessible and culturally sensitive in humanitarian context. MSF has focused on integrating MHPSS for children into emergency response in different types of activities. These include malnutrition programs, surgical projects, SGBV and violence, migration, and others. MSF intersectionally has also prioritized to provide mental health specialized care because of the very limited resource in the humanitarian context. The psychosocial support is better covered by other actors. However, MHPSS also requires collaboration among various sectors, including health, social and protection services, education, and community organizations. This interdisciplinary approach ensures a comprehensive and coordinated response to mental health and psychosocial needs. Mental health for children, survivors of violence, is a matter of humanitarian urgency that requires our immediate attention and sustainable action. I'm looking forward to hearing today's speaker. Thank you.
Thank you, Mariana and Diane. So now we're going to have a quiet moment of reflection. We've just heard about the mental health effects on children in conflict. And so now we're going to take a moment to just reflect on what is happening around the world and its impact on children. Okay. I'll now ask Raed to come to the stage. We now have a PED talk by Dr. Raed Hijazine, who is one of our doctors at the same project as Diad, who you heard from before, which he will tell us more about the project as well as a success story of one of their patients. Welcome.
Good morning, everyone. Imagine a symphony of expertise, where each instrument represents a different discipline, coming together in a perfect harmony to orchestrate the healing journey of a patient. Today, I invite you on a journey where our surgeons, nurses, physiotherapists, psychologists, and other professionals collaborated like members of a finely tuned orchestra. We'll explore the transformative power of this collaborative approach through the lens of a young boy whose life was forever altered by a tragic event. Ladies and gentlemen, welcome to the stage where healthcare becomes a symphony of healing. Our protagonist, whom I refer to as A, is a 12-year-old boy presented with multiple debilitating and disfiguring scars on his face, arms, forearms, and hands. His injuries dated back to February 2021, where he was in a car when a nearby gas container exploded, leaving him with severe burn injuries. Because of his injuries, A struggled to grip a pen or to write effectively, therefore hindering his educational journey, causing frustration, frequent school absences, and social isolation. When A arrived at our hospital in October 2022, he was not just a patient with physical scars, but also emotional wounds. His journey toward healing was daunting, marked by numerous surgeries and the arduous task of rebuilding both his body and his soul. Knowing so, our multidisciplinary team, similar to a symphony orchestra, assembled with precision and purpose to address every facet of A's condition. Each member brought a unique set of skills and expertise, ensuring that no aspects of A's care was overlooked. The multidisciplinary team included members of the following departments: mental health, nursing, surgical, physiotherapy, including 3D and occupational therapy. In the next few slides, we'll explore each department's contributions to A's journey of healing, starting with the healing melodies of mental health support. A's emotional turmoil was palpable upon arrival: poor social interaction, low self-esteem, and a negative body image that haunted him. His father, too, was grappling with stress, witnessing his son suffering. But our clinical psychologists and peer counselors stepped in as the soothing notes of guidance and reassurance. Through tailored sessions, A learned how to navigate life's challenges, from managing emotions to fostering relationships, paving the way for resilience and self-reliance. Next is the nursing cadence of compassionate care. As the symphony of healing, in the symphony of healing, the nursing team provided the steady beat of compassionate care, from assisting with activities of daily living to addressing A's low body weight. They were the unwavering support system that sustained A through his darkest moments. With tailored nutritional plans and tender care, they nurtured his body back to health, ensuring every note of his recovery rang clear. Followed by the surgical notes in A's symphony of recovery. A's journey toward healing unfolded like a symphony, with each surgical intervention composing a vital note in his recovery melody. During his 8-month stay in our hospital, and with the precision and skills of our surgical team, A underwent 7 surgeries, through which scar tissue was released, healthy skin was grafted, and keloids were addressed, crafting a new composition of hope and renewal for A's future. Next is the rhythm of physical rehabilitation. A's physical limitation posed a significant barrier to his daily life. Limited range of motion, muscle weakness, and dependency on others for basic activities weighed heavily on him. But through the orchestrated efforts of our physiotherapist and occupational therapist, in addition to continuous support and follow-up from the pediatric and pain nurse, each surgery became a stepping stone toward independence. With targeted interventions and functional exercises, A reclaimed control over his body, regaining mobility and confidence. And last but not the least, the innovative harmony of 3D physiotherapy. As the symphony reached its climax, our 3D physiotherapy team employed their innovative techniques. Through customized splints and TFOs, they meticulously fine-tuned A's rehabilitation, working in harmony with the broader team to shape his scars, prevent complications, and to ensure the best outcomes. Finally, here are the results. A now exhibits greater control over his body and hands. Next, please. And with his newfound dexterity, he returned to school. His confidence was radiating as he wrote his thoughts on the whiteboard for everyone to see. In closing, A's journey exemplifies the symphony of healing, a masterpiece woven from the threads of collaboration, innovation, and compassion. Each member of our multidisciplinary team played a crucial role, contributing their expertise to compose a narrative of triumph over adversity. As we reflect on A's journey, let us remember that in healthcare, as in music, true beauty emerges not from the individual notes, but from the harmonious interplay of every instrument in this orchestra. Together, we can create melodies of hope, resilience, and healing that resonates far beyond the confines of our hospital walls. And thank you.
Thank you, Raid. I think that was an amazing case to present, showing us what true holistic care can look like. And yeah, thank you for that. We're going to move now to an oral presentation section. It's a bit of a mixed session. We'll have some child protection as well as some HIV. The moderator of the session will be Chris Mambula, so I'd invite him to the stage, as well as with our two in-person presenters, Umu Diallo and Lazaro Fidel. If you can come to the stage as well. So Dr. Chris Mambula has a very long history in MSF. He's a doctor with a master's in public health and is working as the cell manager in OCP and is responsible for Kenya, Uganda, Malawi and DRC. As well, in that program has quite a few HIV projects in his portfolio, which is why he's a great person to moderate this session. So enjoy.
Thank you very much, Nicola. Hello, everyone. So today's session that I'll be moderating is oral presentations on safeguarding and child protection and pediatric HIV. So we have three persons presenting. I believe that one person is presenting online, and we have two persons here with me up front here. So the first individual who's presenting is called Sonia Meiros. Just a second here. So Sonia is an accomplished researcher and humanitarian professional, presently serving at UNICEF after having a diverse pathway, including amongst other things, working with MSF, UN Women. She does have a PhD and has consistently demonstrated a strong commitment to improve the lives of those facing violence and suffering through her research and development of innovative methodologies. Her scholarly achievements are complemented by substantial field experience, enabling her to effectively implement monitoring and evaluation and engaging communities, promoting health, and applying these principles of humanitarianism and anthropology. Sonia's approach is fundamentally people-centered, prioritizing survivor-centric methods in varied global settings. So she will be presenting Empowering Transformation. Empowering Transformation, Harnessing Child and Health Narratives to Propel Meaningful and Sustainable Health and Well-Being in Lesotho. Sonia, if you are with us, welcome, and please carry on with your presentation.
Sonia, could you just hold on a second? We've lost audio. Can you just hold on a second and start from the beginning again when we get audio? Okay, try again. Still not. Hold on a second. Okay, try again. Can you try again? Can you hear me, Sonia? You can hear me, we still can't hear you. Okay, try again.
Hello?
Yes, we have you. Okay, fire away.
Great. Thank you so much.
Thanks.
So let's restart. Good morning, everybody. Thank you so much for the opportunity to be here today with you to share this short paper. And I was saying thank you so much for MSF for the amazing work that you do in so many difficult contexts in the world. And I miss working with you. Despite being very happy in UNICEF as well. And apologies for not being there today. It was really not possible, but hopefully in the next event I could maybe be in face-to-face. So starting, this is a work that was developed by UNICEF Lesotho in collaboration with Lesotho Red Cross Society. And this is anchored in the work that we are doing with the aim of supporting children in the country. So a very brief summary of Lesotho. Lesotho is a high altitude and landlocked country. Its geographic location, full surrounded by South Africa, obviously has a massive influence in economy and the social landscape as well. There is a high vulnerability to economic shocks. The economy is susceptible to external shocks, obviously a COVID-19 pandemic, but also other shocks like the war in Ukraine have had a very massive impact on Lesotho's economy, which was already very dependent. One of its dependencies is on agriculture. It's important to notice that 75% of the population still relies on agriculture for their livelihood and making them vulnerable to climate shocks and also to environmental stresses. And there is a very high level of poverty and inequality. Almost half of the population lives below the poverty line, with children and youth being the most affected by deprivation and the lack of social services. This project was developed in core 4 districts, and the lowlands, mountains, the foothills, and the river valley Senku, and those were chosen particularly because they represent different challenges and difficulties that the population in Lesotho is struggling with. There is suboptimal sanitation infrastructures, there is high rates of transmission of communicable disease, there is limited opportunities for development, the vulnerability to climate change that I already spoke about, the issue of child labor, particularly women doing household chores and men youth being involved in pastor activities, the herd boys, they are called here. And also there is some family displacement due to flooding. The methodology that we used was mainly participatory in nature. We selected, as I said, the districts for 4 ecological zones to ensure that we included children that are facing different layers of challenges. We chose boys and girls aged from 6 to 19, including specific groups that face higher levels of poverty and vulnerability, namely school-aged children and out-of-school-aged children, hurt children, children with disabilities, and also young people and members of minority groups. And this is particularly important in my perspective, because many times we don't target children with disabilities and children from minority groups when we think about doing research with children and youth. And here we purposefully chose those children as the priority groups, so we ensure that their voices are actually heard and their voices are acted upon. This is a qualitative study, but if you see the number of people that participated, it's really high. And I think that this is also a very good example that we can actually have good qualitative research that includes a higher number of participants. In this case, 200 children participated in the study. We use the participatory rural appraisal tools for data collection, and this included social and resource maps, institutional maps, Venn diagrams, body maps, cause and effect analysis, peer classification, daily time use analysis, and focus group discussions. All those had to be tailored to ensure that children with different disabilities were able to fully participate in the study. We ask, obviously, ethical approval from the competent authorities. The informed consent of parents was always a must, and also the assent of the children. All information was kept confidential and anonymous, and for qualitative data analysis, we use thematic analysis. As key findings of the study, it's important to notice that most children, they described a multi-layered set of challenges, which include WASH, education, nutrition and health, and protection. And here, I think this is important, especially because it alerts us to how relevant and how neat it is to have comprehensive approaches which actually target more than one or more than two specific support services. Regarding WASH, the issue was access to water. Access to clean water and drinkable water was a second layer of discussion. And also the children, they described the difficulty in accessing those, namely in regard to the risk of...
Recording in progress.
Oh, okay, sorry. The risk of gender-based violence in the path towards getting the water and coming back from the water places. There was also a problem in winter times. Lesotho is in Africa, but because of the high altitude, it's very cold during winter, and many children, they struggle with going walking to the water places because it was too cold for them. There is also the issue of nutrition and health. Lesotho struggles with the problem of malnutrition, stunting, but also the problem of obesity in very young ages. Anemia is also one of the things that is commonly mentioned. So children, they describe the difficulties in having access to quality food. Some of them described that they had to eat food that was not really in good shape anymore because they didn't have access to other food. Meat and fish are not always accessible. Some of them, they eat porridge with oils. And in the case of babies, there was the description of some siblings that described that the babies, they were not drinking milk. And before the age of 3 months, they were already given artificial refrigerants, namely orange soda. Regarding education, the access to education is a possibility. However, the quality of the education services lacks the minimum standards. Many described that the teachers during winter times, they are not always there. Others describe that the school has no access to the necessary educational tools. And here I'm speaking about basic things like pencils, notebooks, this kind of basic materials, but also they describe difficulties in ensuring that children with disabilities could actually access school. They don't have ramps, they don't have the support devices that could allow for these children to access the gate of the school, but also inside the school, they described several layers of difficulties. There is no adaptation for children that are blind or deaf, children with learning disorders, they don't have the necessary support. So these children, usually they drop out very early. In regards to child protection, 3 core things emerged. The first one was child marriage. Some children, they described that the older siblings, they were married at very early age because the family could no longer support them. Another key issue is gender-based violence and sexual violence, even inside the communities. And in regards to male children and male boys, youth, the description is linked to physical violence. The level of physical violence to boys is really high in the country. A few quotes from the study. Lesotho is embattled by a gamut of socioeconomic challenges. Infrastructural limitations, particularly in rural areas, are a significant hurdle, stemming the delivery of essential services and exacerbating the vulnerabilities of the remote communities. And here, in regard to the previous quote, it is important to notice that the children also described the hours that take them to get to a near hospital. One of the things that for them was massively concerning was when they are sick of severe diseases like pulmonary diseases and they cannot access the hospital for several hours, or when the mothers are pregnant and they cannot access the facilities on time. Another relevant quote is, girls have borne the brunt of increased domestic burdens, facing elevated risks of gender-based violence and encountering significant obstacles in accessing education and pursuing their life goals. This is really one of the things that we are targeting the most, not only the issue of domestic burden, but particularly the opportunities for girls to access high-quality education. As I said, in Lesotho, the percentage of children that go to school is very high. It's close to 95%, but the issue is the quality of the education that is given is not as good as it should be. To give you an example, many children, both girls and boys, at 6th grade, they are not able to read and write basic texts, and they are not able to do basic sum or subtraction, addition and subtraction counts. Boys, especially those in traditional roles like the herd boys, have also confronted unique challenges such as economic instability, heightened isolation, and disruption to their educational journeys. And here I would like to make a link to the previous communications. It is a key and very, very fundamental right to have access to mental health support. And the herd boys, they really described us how isolation was a toll in their well-being. They are isolated for several days at a time because they go with the sheep for the mountains, and this makes them feel very lonely. And the coping mechanisms that they use, they are not always positive coping mechanisms, and also the family does not always understand how being alone at a very early age, and we are speaking about children with 5, 6, 7 years old, how this can be very damaging to their mental well-being. In regards to children with disability, the issue is really strong. Parents often have a difficult time accepting a child with disabilities, given the stigmatization of having a child with disabilities. Those children with disabilities are often hidden and locked inside the house while parents go on with their lives. This is a direct quote from the study. It is so sad that we have had incidents of children who were literally fight to come out of the households where they are not loved and cared for. They, the parents, are happier when their children are away from them and they care less about their safety and well-being. It is heartbreaking to see children with wheelchairs struggling to move around because the roads to and from school are not accommodating. As key conclusions and recommendations from the study, the first conclusion is children's resilience, adaptation, and optimism in face of adversity are remarkable. It's very interesting to notice that despite the challenges and despite the difficult narratives of survival, both boys and girls, their perspective is of optimism, is that we can change their life and that possibilities for a better future are possible. And I think that we as adults may sometimes learn from them in regard to how they see the challenges and how they perceive the world with a brighter perspective. They also reported experiences that are crucial to shaping effective and empowering interventions. The fact that they actually speak about their difficulties in an integrated way, I think this is a very important lesson to us all. We need to think of interventions also in an integrated way and not only as silos of different layers of intervention. And also the experiences they share with us of positive growth from very short interventions. To give you an example, how they describe us that the fact that milk was given to the community, so the newborns, they could actually be well fed, or that in the community there was one of the families that had access to a water supply system, even a very rudimental one, or when they described us that a project, a very short one, 6 months, gave seeds for them to be able to plant the banana gardens. And the implications they described from these limited interventions, namely, my family could eat for this period because we have access to food. I didn't need to go so many times to the mountains. And because we had access to food, we could go to school. And because I have access to water, I could actually go to school on time instead of going and fetch the water before I go to school. So sometimes small interventions can really make a massive difference. Significant challenges in education, nutrition, and access to basic services are obviously very high. And this is linked to inadequate and insufficient infrastructure, but also to the issue of coordination between the different possibilities and the different services. There is an urgent need for a holistic and inclusive strategy that reflects also the children's voices and needs. The children, especially the youth, they clearly told us that usually they are not asked, their opinions are not heard, and they value very much the effort that is being done in understanding their needs, their perspectives, their priorities, and that we make a serious effort to include those when we think of programming and when we think of policy making. As recommendations, 3 key recommendations. Policy making using child-friendly tools and methods is a must. We need to include the children and the youth voices in our policy making efforts, and we need to ensure that the feedback systems, they actually work, so children can voice out their perspectives. Allocate resources and training to support child-led initiatives, enhancing their active participation in advocacy for change. This is very interesting as well. Most of the people that were interviewed, they were very keen into having their voice heard directly. They wanted to shape Lesotho's future. They were very concerned about children not being heard, and they even give us interesting examples of how they would like to do that. Last but not least, increased focus on children's rights, education, and avenues of participation should be available, namely through awareness-raising campaigns and also through curriculum integration. Thank you so much for your time.
Thank you very much, Sonia, for your presentation. Please kindly stay online, as we will have the questions at the end of this presentation by the other 2 presenters. So I will now introduce Dr. Umu Hawa Diallo. For the English-speaking individuals who are either following online or in the room, please kindly, if you don't understand French, kindly pick up the microphones, the devices for translation, and so that you can follow this presentation. Alors, donc, juste...
Oh, yes. Oh, I want to introduce Dr. Omo. She's a pneumologist. She deals with the University Abdel Nasser in Conakry, Guinea, with more than 10 years experience in clinical studies and lungs. She has served as a nurse, as a doctor, and also she's a nurse. She's done a lot of research in tuberculosis and HIV. She has done major contributions in improvement of life in HIV and tuberculosis. She's also a manager on prevention from mother to child and on anything that has to do with active NGO in Guinea. She has written and published more than 30 scientific articles, and she has presented more than 40 papers at the national and international levels in many conferences. And today she's sharing on prevention, HIV prevention from mother to child. Of course, a work that she did in the year 2022 in Guinea. Dr. Wu, yours is the floor. Oh, thank you very much. Great is my joy to be here with all of you. I am very happy to be here and to share. I want to share on the project HIV and especially the how to avoid transmission mother to child.
Donc l'épidémie de VIH est déclarée en Guinée par l'ONU-SIDA et MSF a décidé la même année de soumettre auprès des autorités nationales pour la riposte. Et en 2011, au regard des besoins, il a introduit dans son projet ce volet. Dont je vais vous présenter les résultats pour dégager les défis, les faiblesses et les points forts, mais aussi élaborer des recommandations pour améliorer l'intervention de MSF et
feed the discussions in order to have programmative approaches.
Le projet VIH-PMS
MSF HIV project represented here in the map because it is around, goes about the health matters in Guinea. And here in this map, what you see are different realities according to different kinds of treatments. This evaluation has used a mixed methodology, quantitative and qualitative, that allowed us to gather data, primary and secondary data. Primary data was collected during individual sessions on people that are taken care of and also the beneficiaries of the project. And the secondary data were collected from documents that were done for the project, and also database from the project were analyzed. And the first limit that we faced is lack of data during 2011-2015, because in the implementation of the project, during the implementation of the project one, there was lack of database, and so with time there were indicators that were added, and so up to the year 2015 it was a bit hard to use this data because there were a lot of gaps. The results that we have been able to produce in terms of of objectives, the implementation of PTME and MSF is a direct product of the work done in the national level, because about 20% of women that were affected of HIV were able to have retroviral drugs, and so the participation of MSF brought around about rather the improvement, and so there is a problem in buying the medicines in Guinea. Of course, we have always problem of stock out, which is always a problem in taking care of the patients, especially in prevention, mother to child. Now, this has also brought a good collaboration between MSF and other partners that are fighting HIV in Guinea. And this project has also allowed us to have capacity building among many NGOs. And so the project was assessed, especially during the prenatal care. And so what you see, the tests here has really increased between 2016 and 2022. It is the same for ARVs. About 97% of women who were found to have, who were tested and were positive of HIV positive, were able to get this treatment. There is also a problem during when one is giving birth, and so there is a test kit that was put in place by the project, and that allowed us to cover the various gaps that were there. People are suggested to have HIV tests, and if they are found to be positive, directly they begin to take ARVs. And a test also is done during a time that a mother is breastfeeding. The result is not really positive. You understand, because there are no postnatal care. After a woman gives birth, there are no meetings, there are no postnatal care, and so many children are exposed to HIV in Guinea. And so taking care of so many children are exposed to HIV contraction. Though there is a lot of work that MSF has done, so far the level of HIV testing and counseling is very low, and so we are sharing so sometimes it is hard. People always find excuses for why not to come for postnatal care, and in that case we need to find ways and strategies to improve systems in how people will have more counseling and testing. Despite the many challenges on testing, we have found some very positive impacts on the implementation of PTMA and MSF, with 36% emission, and the 2021 rather, it reached 12%. So we are somehow moving forth. Now, this assessment also helped us to find a level of transmission rate from 2.5 2015 and 12% by 2019. There were some indicators that we were able to see in terms of retention and medicine stock out. There is also matters to do with the family planning. We have also found some serious problems that has to do with data, the accuracy of data. In terms of efficiency, there is a high level of dependence of a PTME project vis-a-vis HIV, though they were not shared with the consultants. We know that there were many informations that were shared on these product from 12 to 7%, though we have not reached our target. There was also improvement on the quality of treatment and care, thanks to the availability of certain training and tools. And the capacity building has really helped in improvement of care of people living with HIV and AIDS in the country. But now we are asking ourselves questions, because now there are no NGOs that are intervening on that aspect, being able to fill the gap, and so many questions are unanswered so far, and so there is need to have a clear plan of transfer before handing over this project to the national sites. If not, we will lose all that we have done so far. We should also say that the assessment to conclude, we should say that the assessment has helped to identify major strengths and weaknesses, and so we have seen the increase of our cover and quality of treatment and care. So there is need to develop strategies in order to have women tested, especially in the communities, and this remains a strategy that needs to be created in order to improve reduction of mother-to-child transmission. There is also need to have a follow-up because we have seen there is a great problem in terms of data exactitude. And so the major limit is data. And with this, we thank you all. I'm sorry for technology was not good with me. Oh, thank you very much, Dr. Umo. For those who got questions, kindly feel free to write your questions, and then at the end we shall ask them.
I will present our last presenter before we pass to the questions. And so I'm introducing Dr. Lázaro Fidel Nyakayo, who has been working with MSF Spain, and he is a study coordinator and focal point for antibiotic stewardship since 2021. He's also the focal point medical doctor for TB and HIV and hepatitis B virus, and in fact, he has many different things he's following. So TB, HIV, HPV, which is hepatitis B, Kala-Azar, in Waushuluk, Abrok, and Malakal, and these are in South Sudan. And he's as a medical doctor, he has been supervising clinical officers, working together with them in the management and follow-up of patients in the general outpatient department, the emergency room, and the wards. Today, Dr. Lázaro is going to be presenting for us expert ultra in stools and urine for the diagnosis of TB in children living with HIV. This is the MSF experience in Guinea-Bissau and South Sudan. Please.
Good morning. On behalf of my colleague in Barcelona and South Sudan and Guinea-Bissau, I'm here to share with you how a study that was done in South Sudan, Malakal, and Guinea-Bissau. Our study is on gene expert ultra in stool and urine for diagnosed TB in children of HIV in Guinea-Bissau and South Sudan. TB is still the challenges in the clinical field. Over half of childhood with tuberculosis is underdiagnosed. And also, access to the culture is another issue. In December 2010, WHO recommend using of expert ultra as a first tool to diagnose TB in children. But confirmation of microbiologically is still low, less than 30%. Our study aimed to determine the use of expert ultra in stool and urine to diagnose TB in children with HIV. This study was done in Momento Hospital in Guinea-Bissau and Malakal Hospital in South Sudan. And we have two hospitals in Malakal, one in town and others in POC, protection side of civilian. We do collect 3 samples. One sample from respiratory sample or extrapulmonary sample, and another sample from urine, one sample, and one sample from stool. Then we do analyze it with expert ultra. We do categorize the patients into confirmed TB, and when we say confirmed TB, we mean when the microbiologically is confirmed in one of the samples. Unconfirmed TB, when the diagnosis was being based on the clinical assessment following the algorithm. Unlikely TB, when the patient was respond to the others diagnosed treatment. Here our results, we found that 61% in Bissau, they have HIV. And we found 75% among all those who have HIV, there's severe acute malnutrition. And among of 61 in Guinea-Bissau, we found them 55% they had TB. As I mentioned that in Guinea-Bissau, we had 57 patients, and in Malakal were 36 patients. We found 75 of them, they have severe acute malnutrition. And 77% were being on ART treatment. In our study, we found 22% were confirmed TB. Among of those 22%, we found 10% was confirming pulmonary samples. Here, when we are going to look for the comparison between the gene expert ultra in stool and gene expert ultra in urine, we found that the positivity of the stool were, as you see, if you go and see it here, the positivity of the stool and sensitivity of the stool were 78.5%, comparing to the urine were 30%. And no patient were positive in the stool or urine and negative with gold standard. Gold standard, that was respiratory sample or extrapulmonary TB sample. In conclusion, expert ultra in the stool showed the higher sensitivity and specificity in HIV-infected children, where we're comparing to the gold standard, which might support its use as a tool to screen test. Sensitivity of urine was low, but more research is needed to determine the clinical indication. At the end, I want to thank the patients and the family, those made the study possible, and I want to thank our team in the field, and our thanks also going to MOH in both countries, South Sudan and Guinea-Bissau. Thank you all.
Thank you very much, Dr. Lazaro. So, well, these are the three presentations, and we will open up for questions. Prior to posing or asking the participants here with me in the conference center to ask questions, no questions online. Okay, so we can feel free to start asking questions in the hall here, please. Someone back there, please go ahead. And please introduce yourself, just your name, and please direct it at one of the three. So either at Sonia, Dr. Umu, or at Dr. Lazaro. Thank you.
Okay, good morning. My name is Olumide. I'm a pediatrician. My question is to the last presenter regarding the gold standard, like you said, it's using respiratory. So, and your sample size was from 6 months to 15 months. So how did you get the respiratory sample for those children that cannot cough out sputum, especially those less than maybe 5 years? That's my question. Thank you.
Thank you for the question. I'll repeat it because he didn't get it completely. So essentially the question was if your the inclusion was children, I believe it was 6 to 15 months. So how was it possible to get respiratory samples, which was what you considered to be the gold standard in your study?
Thank you for the question. The gold standard that I mean is the respiratory sample and extra pulmonary TB sample. That one was the tool that was been validated by WHO before to be used as a first tool to diagnose TB in children. Respiratory sample is either to be sputum or gastric aspiration or nasopharyngeal aspiration. That tool was being actually evaluated by WHO to be used as the first tool to diagnose TB in children. What we are doing now, we are comparing our results with that the gold standard one that was being evaluated, because we are using the urine and stool that was not evaluated. Then we can come up how the sensitivity it was.
I see someone in the back, and then we can come back towards the front. Go ahead, please.
Hi, thanks for your presentation. My name is Jackie Oliwa, a pediatrician and researcher based at Kemri Wellcome Trust. and have an interest in pediatric TB. So this goes to Dr. Lazaro. So how did you handle expert ultra that had trace results? Did you have any children who had trace results? To the extent that they probably had signs and symptoms suggestive of TB. If they have a trace result, did you treat them as confirmed TB, likely TB? And considering this population that you were studying are HIV infected and their children, so likely to have post-bacillary disease. Thank you.
Thank you for the question. Yes, I can say yes. The trace results, we do put it as a confirmed TB. Unless if it is unviolent or negative results, that will already, we are not going to consider as a confirmed TB.
Yes, I think you, the lady. Go ahead, yes.
Hi, my name is Mariana. I'm a pediatrician, and I'm working in Iraq in a project with OCG. My question would be more on the laboratory technical skills required to do to use the stools as samples for GeneXpert Ultra. Was there any extra training required for the lab technicians to process these samples regarding to the normal processing of respiratory samples? Or is it something pretty straightforward just to do it in the stools?
Yes, I can say yes. Actually, the lab team, they need training on how to run the stool on GeneXpert. Because if you look on the sample itself, it's too different from the respiratory sample. So it means that the team in the lab, they need training, how to prepare the sample, how to collect it, how to put it in the expert machine. So actually our team was being trained on that, and they're doing it. And then I can confirm, for example, now the SOP was changed. It's not like the before. Now we have a new SOP, how to run the stool. So the team was trained, and now they're ready to do it, and they're doing it well. Thank you.
Thank you for the response. I would like to start a triage. So we've had 3 questions from Dr. Lazaro because he's interesting, maybe because he presented last. Huh? So don't forget, please, we have 2 presentations, PMTCT and inclusion of children in their own care that was presented by Sonia. I hope she's still connected. So if you have questions for one of the 2 other presenters, please go ahead. So you, yes, and then I'll go to the right here. Go ahead.
Yeah, good morning again. My name is George from Sierra Leone. I had 2 questions, although the one has been answered, but I will still reiterate it. I may like to know when the GeneXpert result comes out. No.
No. I'm going to cut you off because I said only for the other 2 presenters. So if you have a question for Dr. Umu or Sonia, then please ask those questions.
Okay. Let me go for the one that presented for HIV.
Okay.
For us in Sierra Leone, we really have difficulty in this identification access to the testing. Did you people think about the early infant diagnosis of HIV? Because that one is also key, because we need to start it from the start, and then before you think about the mother. Thank you.
Je ne sais pas si la question était claire. Oui, en fait, la question qu'il a posée, c'était est-ce que vous avez considéré aussi la diagnostic précoce, où on dit EID, ou Early Infant Diagnosis en anglais. Voilà.
Okay. Merci beaucoup pour la question. Effectivement, nous faisons l'EID. Ce test, il est fait par MSF. Et dans la présentation, je vous ai dit les difficultés auxquelles le pays est confronté. Aujourd'hui, nous faisons l'EID sur le expert qui permet de raccourcir le délai du diagnostic vu que les femmes, elles ont des difficultés à revenir pour faire tester leur enfant. Mais la grosse difficulté que nous avons, c'est surtout de voir ces enfants à la 6e ou à la 8e semaine. Donc, s'ils arrivent dans les sites, ils ont la possibilité de faire dépister leurs enfants. Mais le problème, c'est comment elles reviennent. C'est surtout ça la grosse difficulté. C'est pour cette raison que nous demandons l'implication des communautaires pour aider à améliorer cet indicateur. Merci.
Merci pour la réponse. Yes, we'll go to him, and then we'll go to the right afterwards. Thank you.
Thank you. My name is Karan, and I'm the epidemiology manager for Syria mission with OCPA. My question's to Sonia. So I saw that you did qualitative interviews with children, and I just wanted to ask, how is it different, and how is it more challenging to collect data with children? Because I know qualitative interviews with adults can be challenging. So just want to get a little bit more background on that. Thank you.
Sonia, you got the question? We can't hear you, Sonia. Just a second, please. Technical difficulties here. Is it unmuted? Yeah, it's unmuted, I think. Not yet. I think they're still working on it. Just a second. I think it should be good. Sonia?
Do you hear me now?
Yes, go ahead.
Great. I was saying thank you so much for the question. Actually, it's one of the key things when we think about research with children and youth. So a few challenges. The first one is the attention span. So the children, they really have a shorter attention. Well, many adults like me, we also have shorter attention spans, but the attention is very short. So we had to organize the questions very well, and balancing the moments of focus group discussion and interviews with the moments of other tasks like the body map, and to ensure that they will not bored with the question line. The second thing was some of our children, they had disabilities. For children with hearing problems or with the low vision, we had to do separated focus group discussions so we could actually ensure that the adaptations were good enough for them to understand what we were asking, and also for us to be able to compile the reply. And also in regards to teenagers, the issue was with the gender. So for children, it was easier, let's say, to do the focus group discussions with boys and girls in the same focus group discussion. But for some issues in teenager groups, we had to separate the ladies from the boys because they were not finding very easy to discuss some of the subjects in a joint focus group discussion. Those were mainly the difficulties. I would also say if we really want to have our children and youth participating in these research events, it would be very important to tailor the questions. Some of the questions that we ask, they are very technical. And the children, they don't really understand what we are asking. So one of the things we did was we asked them to describe their daily tasks, their daily activities. And from those, we then prompted with more specific questions. So for instance, fetching water, that would come from their own narrative of what they do during the daytime. And I think this more focus on their daily lives is actually one of the ways of getting good information instead of asking, do you have any challenge when you go? And also the technical wording like challenges, achievements, these kind of words, they mean very little to most children. So we ask them, do you find anything difficult, or do you find something more trouble than you would like it to be? These kind of adaptations, they were very important because they allowed the children to actually explain their reality in their own wording. Thank you.
Thank you very much for the response, Sonia. Prior to going to the question online, we have one person who has been waiting in the room, and then I'll ask a question from online. Thank you.
Thank you. My name is Robert Kosteczka. I'm a pediatrician with OCB. I have a question for Dr. Umu. You mentioned that there were loads of ruptures for the antiretrovirals during those years. Do you see many resistances or when the drugs come back that people have high viral loads that the drugs don't work anymore? Is there any data on that? Thank you.
Merci beaucoup pour cette question.
Oh, thank you very much for this question. In Guinea, the first problem of stockout, we are working with IMF, and there's a space, an amount that is given to the state, and so there is problem to do with the testing and ARV on first row, and of course they got consequences. They could increase the risk of transmission mother to child and also resistance. Since the year 2022 we are now using liter gravel, the first line of the schema of the schema, and we hope to solve this problem that has been there for years now, but still now there is more to be done. Thank you, Dr. Almo.
Yes, question from online. Can we conclude from your research that beyond the MSF and other NGO-supported PMTCT programs, where families rely fully on national available services, the rate of mother-to-child transmission is high?
Can you re-ask the question? Sorry.
Yeah, so the question is about the research, if it can fully conclude that the rate of mother-to-child transmission is high.
Oui.
Yes. Yes, we can conclude that because the objective that was, the target that was put by to end this case was above 5%, and the result I've shown here is 7%, the rate of transmission. Understand, we came from 36%, we came from far, from 36% to 12, from 12 we are now at 7%. Now, in continuing working, we might reach less than 5%, but that needs MSF participation because it is funding so many programs, because in the sites women feel they are well taken care of. In some sites we were able to identify there were women who testified other women advised them to go to XY center where they can benefit from better care, and so if efforts are put together we shall reach there. Thank you very much.
Been signaled that we are actually out of time. Sorry, I think, especially for those of you who are here, please feel free to grab Dr. Umu or Dr. Lazaro and ask them your questions during the coffee break. And thank you very much for Sonia for having presented and stayed online to respond to questions as well. Thank you very much.
Thank you. Can tell everyone's waking up now, so that's good. All right, so I have the pleasure of inviting Kemi onto the stage. Dr. Kemi is, I should say her full name, Dr. Kemi Ogundepe, is the pediatric advisor for OCB based in Brussels. She's a pediatrician specialized via the Baylor College with a special interest in global health, HIV and TB, and is going to talk to us about tactic.
Thank you, Nicola. As Lazaro already did some of my work for me in summarizing the need for more support in diagnosing and treating children with TB, I wanted to talk about a new initiative in MSF for that. So as we know, TB continues to be a challenge for us to diagnose, to treat, and even to prevent in many of our programs. More specificity on the data about TB shows that more than 60% of children with TB are never put on treatment for it. And MSF, like other medical organizations, we struggle to be able to do TB programming effectively and find these children and put them on treatment and get them cured. You may recall, if you've been following Pediatric Days, that we already talked about this challenge here in MSF in 2021, and we had a whole session on it. And so with that, we know that we've had this challenge, and since 2022, the WHO put out a new TB guideline that was specifically presenting 2 new TB algorithms for diagnosing pulmonary TB. And so with that, MSF saw an opportunity to make a big push with this new guideline to increase and improve our care for TB, both for preventing, treating, and diagnosing it. So with that as our starting point, we started to do some research to support projects in implementing these protocols, and we started that last year in a few projects. We introduced the TB algorithms for diagnosing pulmonary TB, and we looked in some projects at the validity, the feasibility, and the acceptability of using these new TB algorithms, and that was the start. And with that, we became more ambitious and more excited about the opportunity this presented, and we decided to go further with this new guidance from the WHO and try to have a bigger movement or bigger action around TB. And this has led to us applying for what we call a TIC grant in MSF, a specific grant given to projects that are innovative, and led to us receiving funding for the grant. And this grant is now called TACTIC, Test, Avoid, Cure, and Treat Cure TB in Children. And this is our new initiative that we have started since the beginning of this year, and we hope to roll out. And so what is TACTIC specifically? It's a project that will provide support to MSF-supported sites in different countries to support projects to work on 3 particular pillars, specifically to work on implementation of the TB algorithms and improving diagnosis and treatment of pulmonary TB. We'll also work on operational research to help us to understand how to best use these algorithms. And the last pillar will be in advocacy. So we started in several countries last year with research and a few activities. And this year, we're expanding to several projects. And so I wanted to ask, because you may have heard TACTIC throughout this week, who here is involved in some way in a TACTIC project in MSF right now? Please show of hands. So look around, they're all over the room, and they're here, and you could ask them about what's happening in their projects with TACTIC. There's also in the lobby, when you come in to the right, a booth for TACTIC specifically, and Jocelyn, who is here, you can see her raising her hand over there, and Uma. They're the 2 who will be able to answer your questions more specifically about it over there. We really hope that with this new TIC, very ambitious, we plan to support a lot of projects with it, that we will be able to finally make a dent and improve our TB diagnosis, treatment, and prevention in children. Thank you.
Thanks, Kemi. So now we have another speed poster session. So I will invite Hashim, Maria, Marissa, and Lazaro up to the stage. So I've lost my bell, but hopefully they will be able to stick to their 1 minute. Good. I see everybody.
Hello, good morning everyone, and thank you for this opportunity. My name is Hashim Al-Sayri, and I am here on the behalf of my colleague in ABS project, Yemen Mission. In ABS neonatal ward, we face outbreak with multi-drug resistant bacteria, such as extended spectrum beta-lactamase bacteria, and we would like to share our experience and how to manage it according to our resource. Our study outlined a comprehensive measure implemented in order to counteract this outbreak, and we measure the incidence rate between pre and post implementation of these measures. We find a significant drop in the incidence rate of multi-drug resistant bacteria. We welcome you to visit our poster. Thank you.
Thank you very much. Good morning to you all. Dr. Maria Louise Namulwana. Okay, so basically Kemi and Lazarus have been talking about diagnosis of TB in children and how it's a major health issue. So our poster is actually looking at the diagnostic performance of the algorithms in 5 different African countries where TB is still a burden. So join me during the break as we discuss the diagnostic cascade of these algorithms. Thank you.
So unfortunately, Marissa's not feeling well, so you'll just have to go visit the visceral leishmaniasis poster yourselves.
Hi again. I'm still going on with the TB. TB in children, like what I mentioned, I think is among of the threat 5 infection diseases in children, less than 5. And as we know, and I mentioned, we are still struggling to diagnose it. Then, that is why we are trying to see which tool that can help us. In Malakal, we try to do the blind focus to assess how will support us to diagnose TB. POCUS, for those who don't know that abbreviation, is a point of care ultrasound. For more information, you just visit us in our poster there. Thank you.
Thank you, everyone. So they will be beside their posters in the break, so please go and visit their posters. So now it is time for coffee break. If we can come back at 11:05 sharp, please, because we have our next main session, which is the HIV session. A reminder that skill stations are in the hallway. There's posters, there's booths. Please do go and visit them, and we'll see you back at 11:05.
Hi, everyone. You can start the video when you can. That'll be good. Hello, everyone. Right now, across MSF, staff are coming up with new ways to tackle problems, improving the way we work and the quality of care we provide. And you guys do this by coming up with workarounds, actually adapting existing tools to new users, or in fact coming up with fresh new approaches. And we know now that all of this is in fact innovation. However, more often than not, this work has been associated to big technical projects, which basically means that people working on other types of projects might not get to hear about opportunities and programs to support them take their ideas forward. At the Sapling Nursery, we want to widen the perception within MSF of what innovation is and who can be involved. And we do this by providing technical and financial support to MSF staff, tackling big or small problems that affect communities and the patients. And we know that innovation is driven by diversity, because diverse experiences mean diverse viewpoints, ideas, and solutions.
Ba mu yi tunanin cewar za a yi la'akari da ra'ayoyinmu da farko ba, amma mun nemi tallafin yin bincike. Mun yi nasara kuwa, an ba mu jagoranci da tallafi mai amfani don taimakawa ƙungiyarmu ta gano ra'ayoyinmu da gwada yiwuwarsa. Samun wannan littafin ya canza tunanina game da kirkira. Kuma a lokacin da abokan aiki suka samu labarin ƙwarewarmu, ya ƙara musu ƙarfin gwiwa da neman tallafi da binciken ra'ayoyinsu gabaki ɗaya.
And we know and acknowledge that nobody knows the problems that MSF staff face and tackle on a day-to-day basis better than MSF staff themselves. And that's why we set up this program to support you guys take forward your ideas and change the organization that way. This year, at the back of Paediatric Days, we are going to open a call for submission that specifically addresses the topic of pediatric innovation. So please do come and talk to us with ideas you might already have or actually problems that you want to address to see how we can support you. Thank you very much for your time and enjoy the rest of the day.
Thank you, Cesc. So we go to the next session. The next session will be moderated by Dr. Alexandra Cruz. She's a specialist in pediatrics. She has been working with MSF. Her last mission was in DRC. Yeah.
Thank you. But first, I have 3 questions for you in the room. So if your answer is yes, you stand up. If it's no, you remain seated. And for those of you online, you're welcome to stand up and sit down also. But who provides HIV testing of children in your project as part of the routine program? 2, 3. The question in your project, is HIV testing of children part of the regular program? Who do HIV testing of children? Stand up if you do. Stand up. So all of you. Yeah. Okay. Thank you. And now, who provides treatment to HIV-exposed children or HIV-infected children in your programs? Please stand up if yes. Okay, some, not so many. And of the rest of you who test but do not treat, who has a referral mechanism in place and some kind of follow-up to know what happens to the child? So, did you understand? The one who tests but don't treat. If you have a referral mechanism in place, and some kind of follow-up so you know what happens to the child, please stand up. This will be better next year. Thank you. We also have a word cloud for you to put in. It's under auditorium in the app, under feedback, and word cloud is, so you put in the words that come to your mind when you think of HIV and children. And the more times a word is put in, the bigger it is. So it's a creative way to share our ideas. So this will be running, I think, while we do the introduction. Yes? Yeah? Okay. So the first slide is for me. Okay, anyway. Welcome to this session on HIV, Why Are Children Left Behind? The need for accelerated progress in pediatric HIV care. I'm Alexandra Cruz and your chair. I'm Danish, from a small country, and I think to most not particularly known for anything or anyone, if known at all. But we do have 2 celebrities I think stand out. The female author Karen Blixen, whom this neighborhood Karen is named after, as she had a farm here and it's now a beautiful museum, and because she wrote world literature. The other is Søren Kierkegaard, a male philosopher, who stated you can only truly help your fellow human being by trying to understand where he is and meet him there. I think this also applies to our work, and maybe particularly in HIV. So actually, I think there's a slide before, no? Yeah? Okay. Okay. We have come a long way fighting HIV, but children and adolescents are still left behind. Globally, only half of children are on treatment, although they are at increased risk of disease progression. The agenda we have put together both reflects some of the challenges and possible solutions. We have invited a mixture of knowledgeable staff, technical specialists, and a brave young woman living with HIV. We do want you to engage. There's the word cloud, the chat, and the Q&A, and they are open throughout the session, and at the end of the discussion, the microphone too. But first, where are we in MSF? How many children did we reach so far? According to the latest figures available, we have a total cohort of more than 3,000 children. We included almost 500 children on first-line treatment in 22, and estimated 6% of HIV patients in our care are children. We want to do better, both in terms of quality and quantity. So now let's turn to the presenters for their contribution for us how to do this. Yeah? So I invite the presenters to come. And the first presenter is Doreen Mora Moracha, and she will share I'm a Beautiful Story, her personal journey and experience living with HIV and educating others on various platforms. For example, as a content creator on social media, member of Education Plus Young Women Leadership Hub, and co-creator of the International AIDS Society Youth Hub.
Thank you so much. Good morning. You guys already had coffee. Good morning. Yes. Now I want to give you a small exercise. Look at the person next to you and tell them you are a beautiful story. You people don't mean it. My name is Doreen Mora Moracha. I am a young woman living with HIV. I was born with HIV. HIV has been in the world for 40 years now. 40, right? More than 40. So in those more than 40, I have lived with them since the very first day I arrived on this earth to now. It's going to be 32 years in August, so it's been quite a journey. And I've been given 7 minutes to narrate 31 years. So, I'm a third born in a family of 4 children. We should have been 5, but one of them died due to AIDS-related complications. And I'm the only one who was left HIV positive. The rest of my siblings are HIV negative. My parents were a discordant couple. A discordant couple is where one person is HIV negative and the other one is HIV positive. So my mother is alive to date. She's still HIV positive. My father passed on 2 years ago. He was HIV negative. When I was, I think 24 years ago, when I was turning 8, yeah, that is when I was officially diagnosed with HIV. So mine was a case of late diagnosis, which I believe is more of a case of so many young children born with HIV. And at that time, Kenya did not have ARVs, and the ones that were there were very expensive. So when I was tested, and the doctors confirmed I'm HIV positive, was because I had herpes zoster. So it affected my left eye. And that time, you used to be sent home and told, just go home, love them, take care of them, just wait. You never know, because it was more a case of hope than treatment. So for 5 years after my diagnosis, I was still not on ARVs, and I still did not know I have HIV. In fact, I remember when I was 11, at school, we were taught about HIV, and we were told how HIV is a death sentence, and how people get it out of promiscuity, but we were not told about the aspect that children were born with HIV at that time. And I did not know that I had HIV at that time. In fact, I remember going home and promising that I was going to be a Catholic nun, because I don't want to get HIV. Whole time I am already living with HIV. So when I was 13, I was officially told that I have HIV. So the doctor told me, Doreen, you were born with HIV. you're going to start a special set of treatment called ARVs, and you're going to take them for the rest of your life. They did not tell me how long the rest of my life was. That was the first challenge. So I thought it's like 5-10 years max, and then we are good. Then 5 years into taking my ARVs, I stopped taking them. One, because there was a lot of stigma from family members that I did not understand why they were treating me the way they were treating me. Second, because I now went to boarding school, and all the kids will come and be like, what are these medication for? They're so big. So now I'm like, they're for a heart condition. Yeah, my heart has problems. But I did not have a heart condition. What I had was HIV that I was managing with my ARVs. So, sorry. I think after I finished high school, I stopped taking treatment. So I would go to the facility, I will get my ARVs, but I will just come and leave them at home. So my viral load was tested, and it was 70,000 copies. And I remember the doctor asking me, what is happening? I told them, I don't know. Even me, I'm shocked. What is going on? And this is actually to tell you, especially if you're a doctor and you deal with pediatrics, we lie, okay. As a former child, we lie. And we will lie because we don't, at that point, there's so many things that actually goes on in the life of a child at home that most of the time you will not understand. So at that time when I stopped taking treatment, I said, I was just as shocked as the doctors, and I told them maybe it's the time. And they told me, then go home and fix the time. Then I decided, and then they said, if you come back next time and the viral load is still high, we're going to change you to second line. So I told myself, because that time we did not have that line in Kenya, because you don't have third line, I'm not going to hospital, so I dropped out of hospital. So for 2 years, they were looking for me. They were sending social workers, all of those people, but I was like, I will come back, don't worry. So what took me back was an opportunistic infection. And this was, all of this was stemmed out from self-stigma. Because remember, I'm in a family where the only person living with HIV is me and my mom. So the rest of my family members, they don't understand. They're like, you should just take treatment and move on. But at this point, I'm feeling like this thing it's too heavy for me. And there is none of my siblings who can relate to it. I cannot tell my friends because when I was disclosed to, I was told I should never tell anyone I have HIV. Now, in 2024, I tell everyone I have HIV. So things have changed. And the self-stigma was so bad. And the thing is, when you're going through self-stigma, you cannot explain it to another person who does not get you. So if it's the doctor, their work is to tell you, why are you not taking treatment? In fact, even the doctor who handled me during that time told me, why are you not taking treatment? But I could not tell them it's because of self-stigma. So what I would love for adults, especially if you're supporting kids, is that I know you cannot get into the shoes of children, literally, but you can try to understand them and walk the journey with them. You can try to tell them, to encourage the parents and guardians earlier on that, hey, your child is HIV positive, but it's time you start talking to them about HIV, talking to them about living positively, talking to them about acceptance. Because it took me 23 years to figure out that I'm HIV positive, and it's for a lifetime, and it's not going to change. And that took a toll on me. But now I fully accepted that I'm HIV positive. I create content around it, around my lived experience with HIV. And yeah, subscribe to my YouTube channel. But what I would love to see is for us to live a world where there is no stigma, a world where people living with HIV are accepted, and a world where we are greater than our diagnosis. Thank you.
Thank you, Doreen, for sharing your story with us, a symbol of courage, hope, and resilience. And thank you to you for filling out the word cloud. We will comment on it during the presentation and also the discussion. And if we miss any of your words, please tell us during the discussion. And now for the next speaker, Ivy. Yeah. Ivy Kassiri presents the global picture of pediatric HIV and barriers to care for children under 5. Dr. Kassiri is an experienced pediatrician working almost 2 decades in pediatric HIV and integrated reproductive, maternal, newborn, child, and adolescent health programming, and is now consultant on the pediatric HIV portfolio at WHO Geneva.
Thank you very much for the kind introduction. I apologize for a nasty voice, but hopefully I'll be able to get through that presentation. So I'll be just going through the global picture of pediatric HIV and the barriers to care for children under the age of 5. Sorry. Okay. There are currently about 1.5 million children living with HIV globally, and only just above 50% of them, just about half of them, are have access to ART. There are 130,000 new infections with HIV. This has declined over the years since 2010, but as you can see in the graph, the first graph above, the decline, the rate of decline has kind of like plateaued. And when we look at the AIDS-related deaths, we have 84,000 AIDS-related deaths in 2022. And this is quite disproportionate when we look at adult deaths. Children account for 4% of all people living with HIV, but then account for 13% of AIDS-related deaths. This disparity is unacceptable. When we look at the global map, I just want to highlight where the children living with HIV are. In East and Southern Africa, we have 930,000 children living with HIV, and in West and Central Africa, we have 400,000 children living with HIV. We carry the burden of pediatric HIV globally. When we look at new infections on the African continent, we can see, that the new infections are actually declining, yes, but the infections are declining more rapidly in East and Southern Africa than they are in West and Central Africa, which looks more or less like a straight line. That's the green line in the graph. And when we look at it from this point of view, you can see all the new infections are happening, almost all the new infections are happening on the African continent. But what is interesting is that we have 58,000 children in the high burden area of East and Southern Africa. But when we look at West and Southern Africa, I mean West and Central Africa, we can see that they have almost the same number of new infections, which is quite worrying. So this is the story we have been, the same sentence we've been saying over and over again, and really it is sad that we're still saying the same thing. While there has been significant progress to date, this progress has stalled, and children living with HIV remain hidden. They remain left behind when you compare the indices to adult indices. So in the green bars, we have children's statistics, and in the red bars, we have the adult statistics. And we can see that 63% of children compared with 87% of adults living with HIV know their status. 57% compared with 77% of adults living with HIV are on ART. And when we look at virus suppression, we have only 46% of children on ART virally suppressed compared with 72% of adults. There is regional variation in the key indicators and gaps. When we look at children receiving ART, when we look at East and Southern Africa, we can see the region is doing slightly better than Western Central Africa. And these are, this is ART coverage over the years from 2010 to 2022. When we look at the gaps, knowledge of status, ART coverage, and virus suppression, at the top bar we have the global indices, but when we look at Western Central Africa, we have a bigger gap of children not knowing their HIV status compared with Eastern Southern Africa. And we look at the viral suppression in Western Central Africa. We have only approximately 30% of children on ART who are virally suppressed, compared with around 50% in Eastern Southern Africa. So from the previous maps, we can see that almost 90% of the children 0 to 19 years living with HIV are on the African continent, and in particular in sub-Saharan Africa. The countries with the highest numbers of children living with HIV: South Africa, Nigeria, Mozambique, Kenya, Tanzania, Uganda, Zimbabwe, and Zambia. And half of the new infections can be found in 4 countries: Nigeria, South Africa, Mozambique, and Tanzania. So one would wonder, it appears simple enough to fill in the gaps. The solutions appear simple enough. Where there is a gap for children who are diagnosed, we need to identify the children. The gap for treatment, link children to care and optimized ART. And where there is a gap of children on for virus suppression, retain them on ART and keep them adherent on ART. And create an enabling environment for these elements to happen. But it is not as simple as that. So why are children left behind? We'll just have a quick look at the gaps. Why is it not that simple, those equations to result in coverage? Sorry. When we look at policy, in some instances, there is suboptimal uptake of guidelines and recommendations. So WHO comes out with guidelines and recommendations, and sometimes these guidelines are taken up slowly, or they may be adapted in different settings. We have an example of postnatal prophylaxis guidelines, which when we did a policy review in 31 countries, we found 17 different approaches to postnatal prophylaxis, which were all adaptations from the guideline. There are challenges in translation of policy to implementation. There's often lack of prioritization of pediatric HIV and obscure funding towards pediatric HIV programming, leading to low coverage. Data availability, quality of data issues, which make it difficult to identify what exactly the gap is. Data is often not disaggregated in a manner in which you can identify the different populations that are not being covered. There are supply security, supply chain security issues, with including challenges, especially for low volume production of ARVs. Low coverage of final confirmatory 18-month testing. This is particularly challenging because this is an opportunity that needs to be captured. After 18 months of age, children are less accessible because in the first 18 months, they are coming in regularly for growth monitoring, for immunizations and what have you. But after the 18 months, they become less accessible and therefore more difficult to identify. And suboptimal ART regimens and unfriendly formulations. For research and development gaps, there are research challenges in children especially younger children, leading to limited evidence and slow development of effective drugs. And at facility level, there are several challenges: long distances to facilities, long waiting times, lack of systems for linking mothers and their infants, especially personal identifiers, suboptimal lab systems and networks leading to long turnaround time for results, health worker challenges, including awareness, skills, and attitudes, shortages of commodities and poor retention at the facilities, limited availability and quality of psychosocial interventions, and quality of service delivery, which is often not integrated and not differentiated. At individual level, we have children who are under 5 are dependent on the adults to bringing them into care. So they're dependent on another individual for access. And often children living with HIV have challenges in this area with multiple or changing caregivers, or even no caregivers at all. There's low postnatal attendance, poor retention and loss to follow up in facilities, lack of caregiver disclosure, especially when they change caregivers, lack of understanding and fear of diagnosis and initiation of treatment, and other caregiver priorities. Caregivers have other children, caregivers have work to do. So this sometimes is not, the child is not a priority for them sometimes. There is stigma and concerns about privacy when it comes to bringing the child to the facility, and cultural beliefs. In the community, again, stigma and discrimination keeps these children hidden away from us, and limited community service delivery makes access to services particularly difficult. And from socioeconomic point of view, there's poverty and gender-based violence. We have had several successes in pediatric HIV. I'll start with the testing, with the rollout of point-of-care infant testing, which has significantly shortened the time for testing and turnaround of results. Comprehensive approach to infant testing, which, when we look at children and where we can find them, and approaching programs approaching the service points where children are most likely to be identified in a comprehensive package, has been particularly successful in identifying children. And one in particular is family index testing, where testing of biological children of adults and siblings living with HIV has shown to be particularly successful. ART optimization and regimen simplification, I will talk about that in a short while. Differentiated service delivery and community engagement. I spoke about this briefly, but I'll just show that in the policy review we carried out in 31 countries, countries seem to have taken up this comprehensive approach, which is the guidance that WHO has for case finding. And we have many of the countries doing all of these activities in the areas where children are most likely to be found. And when we look at treatment optimization, this has been one of the successes of pediatric HIV of the recent years. And one asks why treatment optimization is critical. And this is because children are less likely to be virologically suppressed, are more likely to acquire HIV drug resistance from their mother. They have less treatment options. They are looking at lifelong treatment, and they're more likely to fail with multi-drug resistance. So starting with the best drugs, timely identification of virological failure and switching to appropriate second-line treatment can minimize selection of drug resistance and optimize future options for children. And when we look at the evolution of preferred treatment regimens for children, I will not spend a lot of time, as my colleague Mo is going to be talking about guidelines, but I just wanted to show that over the years, treatment has progressed towards simplified and more effective and less toxic regimens. And in 2018, dolutegravir-based regimens was recommended as the preferred for all populations from 4 weeks of life for ART. And in 2021, we had the introduction of generic dolutegravir 10 milligrams. We can now see that pediatric ART is now harmonized across populations and aligned with adult standards of care. I will not spend too much time here. I just highlight that what is new here is we have dolutegravir-based regimens preferred for first and second line ART, and new on the board is a fixed dose combination of abacavir, lamivudine, and dolutegravir, which was introduced last year, and we are in the process of scaling up this formulation as it is a one fixed dose once a day formulation, which is very convenient for children. I will not go into this, but these are the guidelines for WHO, DTG-based regimens for first and second line, and in our policy review, there is a wide adoption for DTG-based regimens for first line across the countries, but adoption of DTG for second line has been slower. And when we look at we want to look at this, is that, sorry, just one more slide. Yes, that while DTG has been adopted, we can see that as the preferred treatment option for guidelines in 2022, we can see that even there is variation in the adoption. So you can see that for some countries, they have adopted as recommended from 4 weeks of life. I mean, yes, from 4 weeks of life and from 3 kilograms, but some countries were still lagging behind by recommending DTG only for children above 20 kilograms. And we can see that in some areas, DTG is still not the preferred regimen. Finally, I'll just very quickly look at communities. Communities are the custodians of children living with HIV. It is important to engage the community actors if you want to find these children, if you want to link them to care, and if you want to keep them in care. So community responses include advocacy, community-based service delivery, community financing and sustainable efforts, sustainability efforts, and monitoring and research. Community engagement is critical for addressing barriers and to access, retention, and adherence. And programs have invested a lot in community providers and extension of services closer to hard-to-reach populations. However, still children under 5 are being left behind in community models, especially differentiated service delivery models. We find that community models and DSD models are being reserved for children above ages of 5, and children below ages of 5 are still confined to facility-based service delivery, which is a barrier to care. And we would like to see this change with children, younger children who are established on ART being able to access community-based service delivery. Thank you very much.
Thanks a lot for providing us the global overview and setting the scene in spite of your voice and not feeling well. So Dr. Cashel will join the panel later, but now we move on to the next speaker, and this is Dr. Katie Simon, who will speak about integration of HIV screening and case finding into EPI programming in Malawi. Dr. Simon is a pediatrician and medical doctor and director of Tingete. It's a project supporting delivery of high-quality, client-centered healthcare to people living with HIV and their families in Malawi. And you're also the co-author of the Malawi National TB and HIV PMTCT guidelines.
Yes, thanks. There we go. So thanks so much for the introduction. 2 tough acts to follow. As she said, I'm Katie. I've been working with the Tingate program in Malawi for the past 12 years, and I'm really excited for the opportunity to be here and appreciate some of the amazing work that MSF is doing around the world. We've collaborated with MSF programs in Malawi over the years, but it's really nice to have a more global perspective with a focus on pediatrics. So I'm going to share with you today just some implementation experience about our pediatric and adolescent case finding approaches. Happy to talk about some of our other work in the breaks or at lunch if anybody's interested. But a specific look at how we've recently integrated case finding into our EPI vaccination programs in the context of our comprehensive case finding approach. But first, just a quick word about Tingate. Tingate means yes we can in the local language Chichewa. And we are an outreach program, we're USAID funded, and we've been implementing care and treatment programs using community health workers and clinical staff for the past, since about 2008 actually. Baylor College of Medicine Children's Foundation Malawi, which is our home, is a local NGO providing clinical care specifically to children and adolescents at the referral hospital in Lilongwe. And the outreach program grew out of this, recognizing that when we started, we were having trouble reaching children. So we used community health workers to expand our case finding efforts, initially starting with pediatric case finding, expanding to PMTCT, and then about probably 6 or 7 years ago to the full comprehensive cascade of care for families. So we're very family focused in our approaches. So we heard from Ivy the global setting, just to give you a little zoom in on what's happening in Malawi. Right now, Spectrum estimates suggest that about 1/4 of the people living with HIV in Malawi who are not accessing treatment, who are living with HIV, are children. And for us, at our 100 or so facilities that we support, that translates to about 2,000 children, which in some ways feels like a lot because that's 2,000 children who are not accessing treatment, but in other ways, it's actually not a lot because they're spread widely across service delivery points, across communities, and reaching them is a challenge. So this is just a quick look at our approaches to case finding, and the point here is that we really need to be comprehensive and family-centered in our approaches. We need to reach people where they are and help them to get care as part of wherever they are accessing services. So I'm going to talk today about the EPI program, but this is just a tiny piece of a very comprehensive program that involves provider-initiated testing and counseling at the facility, making sure children with malnutrition are accessing testing, for example, and then also making sure that self-tests are available to young people who want them, that we're providing access to testing for partners of pregnant women, et cetera. So it's part of a much bigger approach. So just a quick look at the PMT-CT cascade. We had a really nice presentation earlier this morning. In Malawi, we actually have very good PMT-CT HIV testing coverage. The coverage at 1st and 3rd, and we have very good access to testing prenatally. So 1st and 3rd trimester testing is almost 100%, but until recently, we really didn't have an access point for women after they delivered to know their HIV status. So the national program introduced testing during breastfeeding about 2 years ago, and what I'm going to tell you about now is how we implemented that. And initially, we were thinking about this as an opportunity to diagnose women who had incident infection during pregnancy or during breastfeeding, because we know they're high risk for transmission to their infants. But it turned out also, incidentally, to be a great way for us to capture women who had fallen out of care, who needed additional support. So what was the problem we were addressing with this program? About 1/3 of child infections in Malawi take place when mom has a new infection during pregnancy or breastfeeding. Another big chunk is women who fall out of care. And I mentioned this already, we have great testing coverage prenatally, but some challenges postnatally. So this was an opportunity for us to provide testing for women who had previously tested negative, but also to reach testing for their partners, either if they're present with them, or to provide self-tests for the women to take home for their partners. Also to offer pre-exposure prophylaxis to HIV-negative women at risk who qualify according to our national guidelines, and to integrate family planning services into that postnatal visit to give women the choice to have children when they want to, and make sure that if they are living with HIV, they can achieve viral suppression first. So we have a team of community health workers who are seconded to these health facilities and do a number of different things, from triage to outreach into the community. And to implement this, we essentially just did a rota change and made sure that we assigned a community health worker to these EPI visits to provide education and HIV testing to women who were bringing their infants. And the reason we said 6 to 9 months is because that coincides with the 6 to 9 month EPI visit for women who had already tested negative. If a woman came in and had not tested during pregnancy and their child was younger, they certainly could access testing sooner, and any woman who requested testing would be offered a test at her convenience. But this was just to catch people who had tested negative at maternity. This is just an example of the tool that the community health workers use to track. It's tiny, so I will zoom through. But essentially what it captures is, it just helps the community health workers to triage who to offer a test to, looking at the infant's age, whether the mom has had a previous HIV test, and then based on that result, if the mom should be offered a test that day. If the woman was already known to be living with HIV, then the community health worker could have a conversation with her about how's it going? How is it going with your medication? A lot of women move after delivery from their mother's home back to their initial community. Many women also choose to take their ART at a different health facility than they are seen for their infant's vaccine visits. So it's an opportunity to engage in a conversation with her about how it's going. Has she missed a viral load check because of movement, or had any challenges with her adherence as a result, and how can we support her? And then also to make sure that the baby is engaged in the early infant diagnosis program and hasn't missed any testing milestones. And then I mentioned linking the HIV negative women to PrEP if they wish, or for their partners as well. So this is just looking at the results of implementation in the last 6 months, from October to March this year. And during that period at these 100 or so facilities, we had about 50,000 women who were screened. Half of them had recently tested HIV negative, so didn't need a test at that point, but still accessed counseling. About 2,500 of them were already known to be living with HIV, so weren't eligible for testing, but we were able to talk to them about their care. But there were about half of them who were referred for HIV testing. And of those women, the vast majority of them were HIV negative. So we only had 32 women who were newly diagnosed with HIV in this group. About 200 of them declined testing, but we were able to identify 32 new women. Now you could look at that and say, well, that's a failure. Or you could look at that and say, actually, this is a success of the Malawi PMTCT program. Let's look at these women living with HIV who we interacted with and see how we're doing in supporting them. So we had about 2,500 women who had previously known their status, and about 2,200 of them had milestone testing available for their infants, but there were about 167 who were offered DBS testing through this EPI visit because they'd either missed a milestone or they'd missed enrollment because of that movement that I talked about with their mothers. So again, an opportunity to identify some children who may have fallen through the cracks. So that's a quick word about our EPI integration. And on a very related note, just to make a plug while we're here, we've talked a lot yesterday about keeping mothers and infants together. And making sure that we're assessing mother's risk when we have her wherever we are. So that doesn't have to be at a community, in a facility, it can be in the community. Is she at risk? Is she someone who needs an HIV test? And does she have a baby? If she's living with HIV, has that baby had the appropriate testing? We often catch things when we ask. So just making sure to ask about the baby on the back is really, really important, and treating them as a pair. And also, I don't have it on the slide, but remembering about her partner. Is her partner somebody who would be interested in having a test? So just as a take home, that was a whirlwind tour of our EPI program. Integration of HIV testing into pediatric services is feasible. I didn't talk today about our family mapping tool, Ivy mentioned it, but we found a lot of children just by asking women in care about untested children, and many of them were over 10 years old. And their moms had been in care and were virally suppressed, and their children were not diagnosed yet because they didn't know that their children could still be infected. We have many opportunities to assess children for HIV, so let's not miss them. And don't forget about the baby on the back. Thank you.
Thank you for sharing and showing how it can be done in practice. And let's move on to Kemi. You already know Kemi. And she will take us on a tour of the world to MSF projects. And some of these projects are in the room.
Yes, so I'm going to do a quick tour of some MSF projects where we do HIV care in non-vertical settings, just to give us an idea of what we do and how it's going. Eventually. All right, so it's a tour of the world, but it ends up being a tour of West and Central Africa and Eastern and Southern Africa. But we're going to talk about a few projects. So the first one I will talk about is, we'll start from babies and go all the way up, about a PMTCT program that is in Salambile in Democratic Republic of Congo. It is a project that is in the Salambile region, which has gold mining and is prone to a lot of armed conflicts related to mining and other things. And it's in DRC, where the HIV prevalence is estimated to be between 2 to 4%. The Salambile project supports hospitals and health centers, specifically a general hospital that covers most of the services in the hospital. They're supported by MSF. And they support 8 primary health centers and provide ARVs in 3 of them. So looking at the data they shared from last year, they had a program, they have ANC care, and in the ANC program, they had about nearly 6,000 women who were passing through, and among them, they were able to test 98.5% of them for HIV. And the testing yielded 52 women who were HIV positive. Among those 52 women, 42 of them were able to be enrolled in care immediately. Few others were not because some declined. Some were referred to another center to be tested or treated, and they did not make it there. And one refused the HIV test result. Then of the 42 women, 24 of these women were not delivering at the centers supported by MSF. So unfortunately, we don't know what happened with the babies who were born, and they were not able to find out whether they were born and put on prophylaxis. But there were 20 babies who were enrolled in the PMTC program from this group of women, born from 18 women, and the majority of them were able to be started in the first 72 hours of life. The success of the infant prophylaxis is unknown because they are not able to finally do the confirmatory test at the EID or the 18-month test because there's no mechanism for that in this program. So the project shared some successes in their program in that they're able to provide PMTCT through the setup that they have with staff who are very strongly motivated and trained in how to do it. They had high antenatal care attendance, and MSF support for PMTCT is well accepted in the community. And they were able to provide prophylaxis successfully to these newborns mentioned. They mentioned some challenges, specifically that you could see that some women refused to be transferred to the sites where they would need to receive treatment. There was a large number of HIV positive women who were lost on the way in terms of getting their children linked to care, and it's because of these movements, they have to be tested on one site, treated at another site, or delivered at another site. So they're trying to see how to link all of those together. MSF is a challenge, but an opportunity is in charge of most of the ARV medications. And so the government, if the government doesn't step in, we could have a challenge with that. And viral load is not able to be confirmed and done for pregnant women, nor is PCR available for children. So it's a barrier sometimes for completing the PMTCT program. So that's about the PMTCT program in Salambile. Now I'll take you to two HIV testing programs in ITFCs, in inpatient therapeutic feeding centers, in MSF, where we test children with severe acute malnutrition in the wards. So the first one I'll take you to is in Awil, South Sudan. And there we have, in South Sudan, an estimated HIV prevalence of 2.5%. And the program in Awil has been there since 2008. And it's a project that supports a hospital, the general hospital, including maternity, newborn, pediatric IPD, and ITFC services. And has a large pediatric ward with up to 165 beds and up to 230 when there's malaria and malnutrition peak. They test for HIV for children with rapid testing, either for the mother, if their child's under 18 months, or for the child, if the child's older. HIV care is done by another NGO that's supporting them. So in 2023, the data they shared from the ITFC is that they have a total of 1,222 children who were admitted, and they were able to test 52% of them, and they had among them 8 children who had HIV, who were HIV positive. So the successes they shared were that when they are able to find these children with the help of this other NGO, they're able to enroll them or link them to them immediately and start ART while they're in the hospital. But the challenges that they shared were that it's not always easy to cover that many children because they don't have a counselor dedicated. There's no space for this, so they're doing this testing and counseling in the emergency room typically. There's a very strong stigma component in this community, and a lot of people refuse to actually be tested or refuse actually the results when the test is done. And there's poor compliance, so the people come back and they find they were on treatment, but they didn't continue. And there's no follow-up in the MSF facility dedicated for children with HIV. The next project we'll look at is in Kenema, Sierra Leone. And this project is in Sierra Leone, where there's a 1.4% of HIV prevalence since in 2022. And the project has been open since 2019. It's a project that is consisting of a hospital where there is a pediatric ICU, IPD, and ITFC. There are 35 beds for the ITFC, and in high seasons, they have about 130 admissions per month, 173 admissions per month. They're able to do differentiated testing. They can do HIV, EID with GenExpert for the younger children and for, rapid tests for the older children. They have good data from the last 3 years that show that they admitted to the ITFC between 1,300 and 1,900 children. The testing coverage is between 97 and 99% of the children who are seen and admitted to the ITFC. And the HIV positivity rate ranges between 4.1 and 4.8%, so much higher than what is presented for the whole country. The successes that they shared were that nearly 100% of the admissions to the ITFC are tested, and they're able to provide differentiated testing. The challenge was that initially the children could be tested, but they couldn't be put on care because the treatment was from another facility, which required them to show up there. Now they have a different setup where the health center next to the facility has a treatment, so they can enroll them in care currently. So now we'll look at 2 other projects, this time looking at HIV differentiated model of care that could be useful in conflict settings, specifically community ART support groups, we call them CAGs. We'll look at project in Batangafo and Zemio in Central African Republic. So Batangafo is the first one that has CAGs, and they've been open since 2006 in the Batangafo region, and in 2017 they started the CAGs. These CAGs provide care to HIV positive people in groups, about 6 or more, where they one person comes to the health center to receive the medications. And they have specific criteria for who can qualify for a CAG, which are listed over there. They shared some data from when they started in 2017 to 2024, showing how they've progressed in the number of CAGs and the number of people enrolled in them. They mentioned that the CAGs have been going well in that they've been able to expand them. People accept them well, and they've now been able to have one group where there's adolescents and it's well accepted. The challenge they have is that, of course, we mentioned in CAR, it's a conflict setting with issues with transport and movement. So if one person who is the CAG distributor cannot make it, that could compromise the care for the whole group. And this can also lead to poor adherence if that person is compromised. And one thing they noticed in their group was that there's very few men who are implicated, and they're concerned that maybe they're missing some. Then we look at the project in Zemio, which has a CAG, and which has CAGs also. And they have been active since 2011 and started their CAGs in 2016. They target a population that is mostly refugees and IDPs. So they have both CAGs where they have these groups, and they have pharmacy fast track so people can get drugs quicker if they are stable on ART. And they give medicines every 6 months. So here's the data for the CAGs that they had last year. And in this particular CAG setup, they have a total of 110 children enrolled in them, even some children less than 1 year old, 1 to 4 and 4 to 15. So that's interesting to note. So their successes is that they're able to improve access in this conflict area to ARVs. The patients are very invested and involved, and they're able to get their medicine. They've greatly reduced the congestion in their health center because the patients are receiving medicine in community. And they're able to assure continued ART supply. And CAR has seen this model and been very excited and want to adopt it also as a national policy. The challenges are similar to what's been mentioned in other places. The viral load cannot be really done, so coverage is a challenge. If there's one person compromised, once again with insecurity, unable to visit, it compromises the care for the group. And the drug stock out, specifically in CAR, there's rainy season and there's issues with roads and accessibility. That affects sometimes the ability to be able to supply drugs to the site and be able to distribute it to the population. So that's just a whirlwind tour of the group of people who are receiving HIV care in different sites in MSF. I want to thank the teams who shared the information and shared openly their successes and their challenges.
Thank you, Kemi, and thank you to the project for this quick tour de force to some of our projects. And now the next speaker is Professor Mo Ajachi, who will update us on where we are on HIV guidance and recommendations today. And Dr. Archie is an honorary professor in the School of Clinical Medicine and Pediatric Infectious Disease Specialist in the University of KwaZulu-Natal and King Edward's Hospital in South Africa, and a specialist on the management of HIV-infected children in resource-limiting settings.
Thank you very much. So again, I think that was a whirlwind tour, this is going to be even more whirlwind. It's always very difficult to try and give you an overview of everything around the changes in terms of antiretroviral treatment and diagnosis in 15 minutes. And really what I'll try to do is really pick up a few key areas in terms of where things have gone and where we think, we hope, and we want to go in the future. Again, I think I was really inspired by many of the things that MSF are doing and the programs that are put into place. It really shows how grassroots changes can make a huge difference in terms of access of care, but also outcomes of patients and the people that we treat. So Ivy spoke to the around really the major issue that we're dealing with is really trying to understand why this major difference in terms of the outcomes across the treatment cascade for children are much lower than in adults, and that's both across the diagnosis, access to treatment, and biological suppression. And that's, many of us are trying to delve into what are the issues and really how do we address those issues in a systematic way to get the best outcomes for children living with HIV. So, and this is from the Global Alliance for the Ending AIDS in Children. And they looked at several different pillars in terms of trying to eliminate AIDS in children. Many of them include closing the treatment gap in both pregnant and breastfeeding people, preventing new infections in this population, and addressing the rights and gender inequality that we see in the societies where HIV is prevalent. And then I will just delve into and focus on really early testing and optimizing comprehensive treatment options for children and adolescents living with HIV. So the first option is really around diagnosis. and this is the IMCI guidelines in terms of access and looking at symptomatic diagnosis of HIV. And while this may be an option in terms of diagnosing without diagnostic testing, this is quite late in terms of the diagnosis, and we're often having a lot of morbidity and mortality associated with the HIV diagnosis, and you really want to try and ensure that you make the diagnosis as early as possible. And that's really, we need to do that through early infant diagnosis. So the WHO recommends using your nucleic acid amplification techniques in terms of early infant diagnosis, and this includes doing it at birth, 4 to 6 weeks, 9 months, and 18 months in terms of the testing algorithms. And there's significant country variation. In South Africa, we do our testing at birth, 6 months, and 18 months, and those are all early infant diagnosis. And I know in many countries, those are not often available, and you have to do it in terms of where countries have testing available. So the early infant diagnosis testing has, largely increased. Sorry, and I was just going to look at, and sub-Saharan Africa, there's been a marked increase in terms of access to early infant diagnosis. And as we heard in terms of the discrepancy in terms of new diagnosis of children and where we are having issues is Western and Central Africa, where early infant diagnosis has actually dropped, and we really need to address those issues. So the new tools is really looking at point of care testing, and there's several platforms in terms of WHO pre-qualified early infant diagnosis testing, and these are include the Gene Expert machine that can actually, you can use both the TB and HIV testing for these. And then when we look at the operational strategies in terms of access to care, and certainly what we want to do is access those unknown cases, or those children who are outside our care paradigm and are lost within that period. And the strategies include offering testing in inpatient wards, and we heard, malaria to malnutrition and TB wards, but also proactive testing, index cases of children from adults with HIV, and testing more globally within the community. And one of the options are looking at opt-out testing. And this is a study done in Zambia by a colleague, Rashida Fred, and they looked at opt-out testing conducted within routine clinical care for children. And one of the interesting things is really, what they showed was they could increase yield for HIV diagnosis from 2.9% to 4.5%. And looking at the factors that where you had, you changed the outcome in terms of how why they were not often tested. Often it was the child disappeared before we were testing, there was no counselor available at the test, or they were referred to another testing. So these are always very practical ways in which you could, opt-out testing actually allows for earlier testing and removes any of those gaps that occur and prevent children from accessing testing. So in terms of the clinical classification, it remains relatively the same. I think one of the difficulties is the clinical staging hasn't changed from when the initial staging, and as we move toward universal testing and treatment, using it as a method of diagnosing change in terms of deterioration becomes more important. So, moving on in terms of antiretroviral treatment options, and Ivy, described this in terms of the access to dolutegravir. And I've put, side by side the WHO guidelines versus the US guidelines, and you can see that there's been alignment between the two guidelines. And certainly what we are now moving towards an integrase inhibitor first-line regimen and second-line regimen, both in the US and in the across the globe as part of the WHO guideline. So what you'll see is that currently we're using an NRTI backbone together with dolutegravir as our first-line regimen for children over 3 kilograms, and 4 weeks of age. There's going to be new data presented at IAS, and there's some data from the CROI conference that really gave us some data around an optimal strategy for using dolutegravir in term neonates, and that will be probably the new way in which we go, and then that dolutegravir will go from birth in term neonates. And if you look at the US guidelines, they're using bictegravir and dolutegravir, but both of them are integrase inhibitor-based regimens. Similarly, the NRTI backbone remains relatively the same with using abacavir and 3DC. Some data that was presented last year showed this superiority of a TAF-based regimen for children for second-line treatment. And with increased access to TAF, that may be an option for changing that abacavir-based regimen to a TAF-based regimen in the future. So what has happened is there's been this rapid deployment and switch for dolutegravir, both for first line and second line. And there's been, several country programs have shown impressive improvement in terms of virological suppression in children with the transition from either PI or NNRTI-based regimen to an integrase inhibitor-based regimen. So when you look at how we deliver these services, and just to look at a differentiated service delivery model, and this is quite a good paper that looked at what are the different types of models of differentiated service delivery across Africa. And this looks at really putting the patient at the center of your delivery of antiretroviral treatment. And that looks like, when are you going to give it, where are you going to give it, who are you giving it to, and what are you giving? And so if you look at the most simplest way of doing that was really around multi-month regimens, which includes provision of ART revision, full refills at facility, and increasing the time gap to either 2 months, 3 months, or even 6 months in very stable patients. And this moves along in terms of weekend clinics, holiday clinics, teen clubs, family-centered models, and community-based models, which allows to moving that treatment as close to the patient as possible and having access to treatment as easy as possible. And then lastly, it's looking at advanced HIV, and again, unfortunately, with the difficulty in terms of access of treatment, but also access to diagnosis, we're often getting children presenting late with treatment. And this is from the package of care, for advanced HIV in conjunction with the WHO advanced care guidelines, and looked at really screening and screening for TB, cryptococcal disease, malnutrition, treating appropriately, optimizing treatment, and then screening of those patients. And then the last few minutes I had was really looking at is really where do we want to go from? Optimizing treatment, and then the prevention strategy that goes with it. And then in the last few minutes, really looking at where do we want to go to, and what do we want to have in the future. And we really want it to be aspirational, looking at an optimal product and positioning. We want better formulations for children, better drug delivery mechanisms that give you longer access to treatment and a longer duration of therapy to treatment. And we're getting there. So one of the options is cabotegravir and rilpivirine. So this is a long-acting injectable formulation given 2 monthly. So it's registered for use in adults. And there's several different studies looking both in children, going down in the current study, CRAYON, looks at it's going down to 2 years of age and looking at pregnant women, but also in non-adherent youth. Other formulations, including this microarray patches, and very recently we heard that you can deliver a measles vaccine via microarray patch. And this is very similar technology in delivering antiretroviral treatment through a microarray patch, and you can give drug for up to a week with attaching the patch for up to 5 minutes down to 2 minutes. Remove the patch, and it provides drug for that child for that duration of time, and very easy to deliver, and removes that problems with giving treatment for young children. And there are several other long-acting formulations, including broadly neutralizing antibodies. Lenacapavir is a long-acting, first-in-class capsid inhibitor that can be given subcutaneously as a 6-monthly injection. And again, I think trying to find a companion drug for that is one of the issues in terms of its rollout. So I think just to leave it, I think we've come a long way. I remember when we started giving antiretroviral treatment, we had to crush adult tablets and open capsules and give subunits of treatment. We then moved to giving syrup formulations, which required our caregivers to go home with huge packets of multiple oral formulation, liquid formulations. And now we've come up to a once daily regimen that's a dispersible tablet that can be given very easily and very palatable. And really we want to move towards really long-acting formulations. We have to give treatment, and one of the things we hear from our patients in our studies when we move them to long-acting formulations is that they're removed from that burden of daily reminder that they are HIV positive. So they don't have to remember that they have to take their treatment, and that's a huge relief and removes that stigma attached from HIV. So we do need to expand access to integrated point-of-care nucleic acid testing for both infant diagnosis and biological testing. We need to ensure that adolescents, pregnant women, and lactating women benefit from these new formulations. And we combine these evidence-based interventions, both biomedical, but also looking at the social and the psychosocial aspects associated with it. So we do strongly believe from where we came from that ending AIDS in children and adolescents is attainable, and we do need sustained commitment from MSF and many other partners to ensure that we reach that goal. So thank you very much.
Thank you for the status on the tools available. So to follow up on these inspiring talks, for us to actually walk the talk, to improve and increase our HIV care for the children, Esther Casas will moderate the debate. Esther is head of the International HIV Working Group and also working as HIV/TB advisor in Southern Africa Medical Unit with MSF. And maybe we can get the word cloud in the back.
Thanks. Thanks a lot, Alexandra, and thanks a lot for the great talks. And thanks a lot also to all of you. I'm so happy to be here today. Sorry. Doesn't it work? Let me change this. We have better tools for everything, isn't it? So what I was saying is that let me just say thank you to everyone, because I'm very happy to be discussing pediatric HIV here today, because I'm actually Is it working now? Okay, maybe there is something with me. With me? Back to stage. Look, I think that my main message was like, maybe, and I would like everyone to say it like that, maybe today we have a bit of a milestone. We are living a bit of a momentum to change this pediatric HIV care from being neglected, at least in MSF, to not being neglected, and all of us engaging much stronger. With that, I also would like to welcome Chris. We had Chris before, so he needs little introduction. He's program manager in OCP, and he brings a lot of experience on HIV and TB. So we have a very diverse and excellent panel. Thanks, Ivy, for joining us also in the panel. And we're going to start, look, I think it's the moment to have a bit of conversation around why are we not doing what we should be doing and what we know that we have tools for. So to start that conversation, and I want to hear a lot your opinions, I'd like to start with our panel here today, and maybe to Doreen and Ivy to start with, if you would have a quick reflection on, first of all, what are the main barriers that we see in the communities that we work with? What prevents us, what we should be aware of from the side of the community in terms of accessing better HIV care, from diagnosis to treatment and long retention? A bit short words.
Thank you very much. I think so far the major problems we have is stigma and discrimination. HIV has changed a lot. Better treatment, as we've seen from the presentations, and even improved data, but stigma still remains an issue. And because of the pre-existing mindset that we've had for a long time, most of the time when a child is born with HIV, it's more of, it's like a shameful thing, for lack of better words. And that alone is a huge barrier, because then seeking medication becomes a problem, retaining them on treatment becomes a problem, and even ensuring that they're now undetectable in the long run becomes a problem. So, yeah.
Thanks, Doreen. And maybe Ivy and maybe Kemi as well. But do you have any ideas? What are the opportunities that we have to face that and to overcome that? Doreen, and this is an open conversation, so.
Yeah, there are several opportunities. A lot of the time, just like Doreen has mentioned, there is stigma, but there is also fear. There is also fear among mothers transmitting infection to their children. And so opportunities include education, educating these mothers. Usually we focus on mothers in the PMTCT cascade. And these mothers who are accessing treatment, accessing ART, usually decreasing the risk of transmission for their children. But the highest risk for transmission are the mothers who are not on ART. So finding those mothers and making sure that they're accessing care is really important. So the opportunities we have are within the communities, within the structures in the communities, and making sure not only that the communities are educated about HIV and its transmission, but also, stigma reducing interventions that make it easier for mothers and their children to access facilities and testing. And also making sure that our facilities are welcoming these women and children into care, and not creating a situation of stigma within the facilities.
Yeah, I think you covered most of it, and I wanted to make a plug, since we have a lot of people from different projects, that part of the challenge is also because most people who are from those countries, we're living in the communities where we're supporting in terms of healthcare. And also we have sometimes some stigma and some misunderstandings about HIV that spills out when we're providing care for children with HIV. So first of all, we need to, as Ivy said, look for opportunities to test and find. In all the things we're doing, we already seen many opportunities and places where we can do that. But also, we need to also, for those who don't feel comfortable or know much about HIV, to understand that HIV is just another medical condition, and that if we talk about it in community, as we talk about pneumonia, as we talk about diarrhea, as we talk about malaria, that will also spread out to how we address it and how they come to us with being able to disclose or be concerned about having HIV. And I think that comes with us having comfort, some of the knowledge we have today now about the fact that HIV is easier to treat and easier to test for, and you can be healthy, vibrant, and have a wonderful life with it. For some reason, we're behind in our thinking, even as healthcare providers, that is actually the case today.
I just want to add, so I think one of the, again, I think in terms of diagnosing mothers and preventing transmission is one issue. But again, I think one of the areas, and your experience, displayed is, one of the, trying to ensure that adolescents and children remain in care, and violently suppressed is another major area. And from some of the work that we've done in trying to develop interventions to improve biological suppression and retention in care, some of the major issues really around the internal stigma that comes with HIV. And then how do we develop resilience and ability to deal with these internal issues and work past those issues. So there are several different resources in terms of strengthening the internal resilience of children and adolescents and build self-confidence and ability to self-manage their care. And I think we do need to think about how do we empower our adolescents living with HIV in order for them to become more self-sufficient and take ownership from it. And one of the other things that we learned when we started off developing an intervention for adolescents living with HIV, they didn't want it to be only about HIV. They wanted it to include career advice. They wanted to include how to have a healthy relationship, how to navigate those issues. So I think while we think about HIV, we do need to think about beyond HIV and see the individual as a holistic individual.
Indeed, I think that you have addressed a couple of topics that we definitely wanted to raise, and I think that this empowerment of the adolescents, and we don't do anything for the communities without the communities, and it's about for those communities to guide us through how is the care that they want. I also wanted to touch a bit on and you said nicely, adolescents in particular, they don't want to talk only about HIV. But also what happens in our projects, and I'm making the parallelism that you will see now soon, is that in the projects, in the places where many of you are working, HIV is not the only thing that we have to think about. There are many, many competing priorities, and we call them integrated projects. And we have many programmatic challenges that I would like to ask your opinion, Chris and Kemi. What are the main challenges? What would you like to raise, and what do you think that could be opportunities to enhance that when it comes to integrated HIV care in those pediatric general pediatric programs, malnutrition programs, etc.?
Thank you for the question, Esther. I think we have had, as mentioned by people who have presented different angles to pediatric and adolescent HIV care, is that we've made a lot of progress. However, there are missed opportunities, I would say, because in that sense, when you look at the different aspects of HIV, from diagnosis to HIV care, the reality is that there's a lot of different points of contact, and I think we mentioned this yesterday as well, that there's different points of contact with the healthcare system, with community health workers, with individuals who are, I would say, sensitized to this. And we miss those opportunities. So for example, in the testing, when Alexandra asked the question at the beginning, how many people here actually practice testing outside of vertical projects, meaning that having the opportunity to, when you have malnourished children, you have children, when you do think of TB and you think immediately HIV, do you have a child having diarrhea for more than a week, what's going on? These kinds of things, that's one. The second thing is looking at the, something that came up as well is the family approach, meaning if you have the mother who's not doing well, well then you see the child and you shouldn't make that link immediately and say, well, this woman looks unwell, what about her child? And I think these kinds of opportunities are missed, and I think that's where we could, especially in our projects where we see thousands or hundreds of, look at the number of consultations that we spoke about yesterday at the beginning of the Pediatric Days. We're talking about 6 million contacts with kids, with children, in a year. And the question is, out of those 6 million, what is the fraction of those 6 million? Do you actually, I don't know, give it 30 seconds, a minute to think, okay, maybe, should I propose a test? Could this be linked to HIV? And if yes, then make that next step of what Kemi had presented. Okay, now maybe the person has been tested. How do I link this person to care? And how do I simplify the life of this child? Because that's where it becomes, very quickly, it becomes complicated, because it's taking drugs every day. It's trying to pick up those tablets. We talk about the differentiated model of care. Whereas I think it was in Uganda, if I'm not mistaken, in the Ministry of Health, they mentioned this in the national system, that you, in theory, this is on paper, you could just go to any pharmacy to pick up your drugs if you have a number. I have never seen that in any context. So the question is, when are we going to get to that point where, you know, you could actually, once you've been diagnosed, you should be able to easily access your treatments and, of course, advice, you know, support, whatever kind of support that means. Thank you.
Thanks, Chris. I will try and talk about the low-hanging fruit that we have, that we can take the opportunities to intervene now. The first ones are already in places where we have a space to just, it's already written in that we should program HIV testing and treatment, like in ITFC's and nutrition programs. This is where we should aspire to reach 100% of children who are seen in this site, especially if they're seen in inpatient facilities with HIV testing. It's something you have to plan for. It's not something that you have to just do on the side. Like vaccination, you have to say, okay, we're going to do it and actually budget for it with operations. We look at all the operational bosses here, that they actually have to put money to that and not just expect for it to happen on the side, on top of the 200 consultations a day that a person has to do, etc. So this one, we can work on facilitating, and we know we can do it. We see it's possible in several sites, even with busy hospitals, that we can do this. So that's one of the low-hanging fruit situations. Also with TB, if any child is found to have TB, we can easily test for HIV. But then the other places that we can probably do much more, and we are seeing it in MSF and other places, is with PMTCT. So, so far we've been very good, and we seem to be very good at catching the mother if we have ANC, getting good coverage for that during ANC, and most of the time in the maternities, getting good coverage for that, testing all mothers, and most times also starting the child on prophylaxis. But then, after that, most sites cannot account for what happens to the child once they leave the neonatal ward. And this is a tragedy because this is the opportunity that we're missing in many places to follow the child in OPD, follow them up till the time that we can confirm that they are either HIV negative or positive with a final test. And we have seen models and we've seen examples. It doesn't cost a lot more money, and OPD is already running. Sometimes you may just have to set half a day where these patients come and you see them with their mother, integrated. These kind of things can be done, but we have to think about them and have to plan them. But this is one where we are very, very much behind in most of our programming and trying to catch those babies. Very, very good at starting off the treatment, and then we don't know what happens after 6 weeks of life. And I think we missed this opportunity, but we have great opportunities. We have great models of how we can close this gap.
Thanks, Kemi. You know that in MSF, we do a lot of PMTCT. We have plenty programs that integrate, the most of them, like close to 90% or more than that, integrate HIV testing in ANC. Really, only a handful of our projects report, and I just finished with the data last week, report following the babies after exposure with early infant diagnosis. And a handful means a handful, not more than that. And I think that this is something, it's our first step to work towards that better. Huh? But Katie, you've told us some of the opportunities also. Where are we missing programmatically? What could you tell us on where can we find those children, in addition to what Kemi was saying?
Sure, thanks. And I think Kemi's pointed out, I think the two key areas that we definitely don't want to miss being TB, malnutrition, 100%. For the other areas, I think it depends very much on the prevalence and the setting where you're working, but you have to have it in your mind in order to think about what to do. So it can be, and I'm glad you said what you did about it not having to be expensive, because we saw an example, I think yesterday there was a poster about an NCD integrated model. We have models of care in which we follow children and adolescents and adults longitudinally, and if we're trying to set up systems that are not stigmatizing, then integrating HIV into those other care programs is the best way to go from a person standpoint and also from a funding standpoint, because you don't necessarily want to have funding separately for HIV programming. So that's one thing. The other thing is just around sort of what do people want. I think we've talked a lot about self-stigma, and I think there's two angles to it. One is right now, still, however many years we are into this, the burden of education falls on the person living with HIV in many cases. So what do we need to do to shift that and make sure that the conversation is happening everywhere so that people have and this obviously is much more complicated, but at least we can start with the education. We provide tons of health education every day. So what are the extra little pieces of information that need to be provided about what treatment is available and that you can have access to care? And that you can request to have your care when and where you want for the most part. People still do not feel empowered in many cases to say, and I'll give an example of our setting. We have many facilities that are on the border with Mozambique, and people go into Mozambique for farming. And they know that they're going to go for 6 months, but the provider gives them an appointment a month from now, and they're afraid to say anything. So they get lost to care once a year at the same time every year until we teach people you can ask for this. And then the last bit, just so I don't take up too much time, is demystifying pediatric and HIV for the providers. I think there is still a lot of fear about taking care of children with HIV. And we saw, sure, there are things that are complicated, but for the most part, it isn't. We just need to demystify it and make it not a specialist thing so that people have access to the resources they need. And in this era post-COVID of virtual access, we have so many resources at our fingertips, even in the most rural places. So making sure people know what tools are at their fingertips when they don't know what to do, I think can also be a great way to sort of expand this effort.
Thanks so much. Thanks so much. Mo, to the clinicians in the room, to the pediatricians and the nurses and those clinicians that see children in the room, what do we don't want to miss when it comes from the clinical point of view? What do we don't want to miss in our wards and in our OPDs to reach and to find those kids and treat them?
Yes, I think one of the main things is really around early diagnosis. So I think one of the, once you miss the opportunity and, the child develops an opportunistic infection, developmental delay, malnutrition, you're really playing catch up. And, I often tell, my patients, when we're treating them, especially when they're coming up, with, really advanced disease, it will take 6 to 9 months or a year before they recover. And so, you don't want to end up in that situation. And I was just, reflecting, we used to see a lot of cryptococcal meningitis in our adolescents. And I haven't had to treat cryptococcal meningitis for the past probably over 2 years now. And that's really because we've had, we've really been able to identify and start treatment as early as possible. So I think one thing is, as we've been speaking about, is really around identifying the opportunities to make the diagnosis early, engage with care, and start antiretroviral treatment. And just to highlight the point in terms of how simplified the treatment has become, the major change that's happened in South Africa in terms of access to pediatric HIV care has been the shift from it being a doctor-centered care model to a nurse-centered care model. And that's really been a game changer for improving access to care for pediatric HIV and really integrating it within your IMCI and other community-based programs where it's not seen as a siloed approach and you can then have access to care. And then the other major area is really how do you retain patients in care. And I think that's in an area that we're still having issues with and trying to ensure that we have systems as robust as possible to support families where they are doing well on treatment, and that's probably 90% of our patients, is to ensure that we don't penalize those families and make them come every month, make children miss school. And one of the, again, one of the things we've heard from our children and our adolescents is, they have difficulty having to explain to their, their school friends why are they away from school every month. You can't have a heart disease, or you can't make excuses every month while you're away. And to try and find ways in which we can, and they find a lot of guilt in having to lie about why they're away from school. So, finding ways in which we don't penalize those, stable patients and ensure they access care as close as possible and easily as possible. And then for those patients who are having difficulties, or the families that are having difficulties with treatment, how do we support them and how do we address the issues that they specifically have? And they are, multitude. And I think it's not a single thing that you need to intervene with. It's really looking at in the most holistic way, and some of them are external factors, but internal factors, and we need to find ways in which we adjust those individual factors for those individuals. And again, that speaks to that differential care model.
Exactly, very relevant. And differential care, it essentially means how are we adapting our systems to deliver care in a way that suits the need of the people that we care for and the needs of the healthcare systems that we're implementing. And I also, yeah, Ivy, please.
I just wanted to Mo mentioned late diagnosis, and I just wanted to just remind ourselves the tragedy of late diagnosis. In that, if we have late diagnosis, the ones who reach to you late, those are the few survivors who have actually reached late. It means several of them have already died along the way. And this goes to a plea to always have the index of suspicion and act on it. It brings to mind one case I had. I usually use this as a teaching moment. I received a patient who was referred to a tertiary center. And when you look through the patient's clinical book, this patient had had a diagnosis of suspected TB with suspected HIV infection for around 3 months. Every time he went to the facility, it was suspected TB with possible HIV infection and was sent home with antibiotic treatment. And the patient had classic TB and died on arrival. So his diagnosis was so delayed that he didn't make it. So the tragedy of late diagnosis is mortality. And it's very important that we have a high index of suspicion for infection. And now that the treatment has been so simplified down to 1 month of age, WHO does recommend initiation of treatment same day, if on the same day of diagnosis, if the caregiver is ready for it, and even initiation of treatment outside of a health facility. So treatment can be initiated in the communities. It is that simple. Now we even have one fixed dose combination. It is even more simplified. So we don't have the excuse of not being able to initiate the treatment early.
Thanks so much.
Just to thank you for saying that. This is the thing I wanted to highlight to our audience, because this is what I find when I visit projects. For not actually late diagnosis is in starting treatment immediately the diagnosis is made. In the past, we had to think what stage, et cetera, et cetera. Thankfully, from the WHO downwards, they've said, you find a child who's HIV positive, if they have no contraindications or other things, you have to start first. On that day, start them on treatment. I've seen many projects I've visited where they do know the child is positive, they're waiting to sort things out, treat this, treat that, they've asked the other MOH for the medicine. 6 weeks later, the child is still not on treatment. He's received 3 rounds of antibiotics, and I see this again and again and again. And I don't know whether it's our hesitance or fear of starting it, but now we have so many options, and we don't have to think more. Once you see it, you can treat it. And you can confirm the diagnosis so easily these days. So please don't be shy. Just go for it. If there's a child in your ward who is not on HIV treatment when you get home, please start them.
Indeed, please don't be shy, but also please now let us know. What are your questions and concerns or experiences that you'd like to share?
Should we go first with the online platform? Because there are many questions coming.
Please.
So I think some of the topics has already been covered, but one of the main questions is about disclosure. So it's a question to Doreen, maybe to Mo and Kemi. How important is to disclose the diagnosis to a child, and how would you do it?
Thank you. And disclosure is very important because it also kind of solves the problem around self-stigma. In my case, when I was disclosed to, my major motivation was food, because every time my mom took me to hospital, she would buy me food. So to me, it was a good thing. But now, not every child is me. So most of the time, parents lie to these children about one health condition or another, and the child grows up with that hope that at one point they're going to be off treatment. But this is lifelong treatment. You have to prepare the child psychologically. In fact, start from the teaching aspect. I usually recommend the teaching aspect, where you teach the child about HIV, teach them about taking treatment, even sometimes just time them that at 8 p.m. it's your time to take treatment, so that they can be able to do it on their own. And as they grow up, it kind of becomes part of their routine. And when they're older enough to understand what living with HIV is, then tell them, because you already taught them what HIV is, you taught them how to take the treatment correctly. Now it's time to tell them, hey, you are actually living with HIV, you were born with it, but it doesn't make you less of a human being. It doesn't mean that your life is over or it's a death sentence. You can manage it by lifelong treatment. That way, accepting is easier as compared to how I was told at one point I was going to be okay. Then I realized at some point that this is actually for life. That is what led to me stopping the treatment altogether. So for you to be able to retain this child all the way to adulthood is for you to also empower them with the education. Yeah.
Such a powerful message, isn't it? The child of today, it's the adolescent of tomorrow and the adult of the future. And this is work for life. So it does make a difference, right? More questions.
No, let me just add, so I think one of the other, one point is really around disclosure is a process. So it's not a single entity. So it's, to start the process as early as possible and build on that process. And there's several different models, and there's quite a bit of resources online and flip charts that help you. So make use of them. People have tried and tested them, so make use of other people's activities.
And then just to say the ages, that you can realize that we can disclose a general idea of that you're taking medicine every day and it's keeping you healthy from age 5 or 6. And then from age 9 to 10, 11, depending on the developmental age of the child, you can start talking about that is actually HIV. But as you said, it's definitely a gradual process, both in the diagnosis, but also in the treatment understanding. And it should be something that is done repeatedly. Don't just say disclosure done and you expect the child somehow to remember it. You don't remember what we talked about 5 minutes ago. It's a process that you may have to repeat again and again to concretize and to make sure the child is able to understand.
Can I add, sorry, one last thing. Just about the process, the guardian is part of that process. So starting to speak with the guardian as soon as their child is diagnosed about how their role will evolve and change as their child grows up can also help, because we spoke earlier about how the guardians have a lot of feeling, the mom may feel a lot of guilt about this as well. So helping her understand that she can help her child. And, the ages are a guideline. Some kids will start asking why they're taking medicine at 4, and that's a great time. So if mom knows from 1 or 2 that this is going to happen, then she can be prepared to help support the process. The other thing we see a lot of in our cohort is once an adolescent is fully disclosed, the guardians are like, our work here is done. Peace. They still need the guardian, right? Yeah. It's just the dynamic has to change to now we're a team, we can do this together, how can I help you? Yeah. So they're not being policing, but they're also not completely gone. So just to add that.
What we said yesterday, mom and baby for malnutrition, is mom and baby for HIV, and it's probably mom and baby for any area of pediatric care, isn't it? I think there is a hand raised there, yeah. Please. If you can tell your name and where do you work?
Bon après-midi à tout le monde.
Good afternoon, everyone. My name is Roam Césaire. I come from Chad. I work with OCP at the border with Sudan in a pediatric. I want to thank you all for your presentations, and we have seen so many slides speaking of HIV testing and the death rate presented in many countries, especially underdeveloped countries. Now, my question is this: does the problem of lack of ARVs in those countries couldn't be an object of discussion. Since we are all actors present here, can't we discuss that? Because many a times when we see the rate, the mortality death is high, and there is a lack of sufficient
another very relevant and important medicines in the care for these kids. Chris, maybe you can start.
Chris, voudrez-vous commencer, et puis je ne sais pas si quelqu'un d'autre peut en parler après.
Which is a very important one, because making a diagnosis without being able to provide treatment is very problematic. The reality, I think, is that there's a lot of different actors. There are many actors who are involved in providing access to ARVs, whether it's donors behind entities like UNAIDS, and the Global Fund, etc. Then you talk about, PEPFAR, so this is from the US, and then of course the governments of the countries that are also tasked with arguing and fighting, and this is unfortunately the case, fighting for budgets to co-fund, for their own treatment. And then in other settings, like what we've seen is whether you have areas of conflict, where you have places where there's geographic issues with access, very quickly places like, the Congo DRC comes to mind. It's very complicated to get the drugs out there. And so the question, I think, is, it comes back to all of us, like we were discussing yesterday, in terms of synergy. The reality as well is that we have lots of actors, so which means the governments, the UN agencies, different NGOs, who are able, I think, to find where those holes and where the gaps are to be able to complete them. And to give that example concretely is that, for example, during this conflict, the last 2 years conflict in Congo DRC, because MSF was one of the only actors that had access to be able to pass through certain, I can call them literally front lines, MSF was able to transport the drugs. So that's a very practical thing. Means the drug was available in the country, the drug was actually at the capital of the province, but because of the conflict, the MOH could not move. And so we said, well, we are moving, we are able to move. So all the drugs, so antimalarials, vaccines, by the way, we transported vaccines, and we transported ARVs as well. So we say, okay, we will transport them to the health facilities to make them available. So these are practical things that we could also do in order to ensure that there is limited, and if not as much as possible, zero stockouts of drugs for patients.
I didn't entirely follow the question, but just maybe to add on to the issue of supply chain and quantification of medication, which we are facing right now, quite challenging, stemming also from the quality and availability of data, followed by the accurate quantification and timely quantification and ordering, and making sure that there are no splits or gaps in the procurement systems is still challenging in many settings, and we still have a lot of instances of stockouts and poor communication about imminent stock challenges, which can also be, backstopped if it is communicated in time. So there are still some challenges in both national systems in arriving at adequate supplies of drugs in countries and in programs. So that is one of the challenges.
Thanks. Still, time is running fast, but I would still like to take a couple of questions or points or sharing statements from the audience, please.
Okay, thank you so much for the panel for this interesting discussion. I think I heard Professor Moy mention that in South Africa, one of the big shifts is making HIV the nursing model more than doctor's model. Would you please explain more a bit about this and how it is implemented, please? Thank you.
Again, so I think, again, it's really around the differential care model. So, both we've got nurse-initiated and managed care of antiretroviral treatment. So nurses in community health centers and primary healthcare clinics go through a special training program that teaches them about, so it's over above their normal nursing program. It also gives them the ability to prescribe medication, which was a major hurdle that we had to overcome, with our pharmaceutical council, because initially, most drugs had to be prescribed by a doctor. So having some sort of prescribing course for the nurses and having a certificate that goes with that allowed that to happen. And then what we've done is then allowed for a parallel doctor-centered care, which really deals with advanced HIV and complicated cases. So, now the only thing that unfortunately I see is treatment failure and, complicated OIs and, treatment resistance. And many of the primary care is, devolved to, the lowest, as close to the patient as possible in their community. So I think it's about, again, I think it has to be something that has to be provided within the context of the country, and does require, and again, we as a clinician body had to fight with the pharmaceutical society, because that was a huge fight, and not only for antiretroviral treatment, but also for PrEP as well, is to allow nurses and pharmacists to be able to prescribe PrEP, which are relatively safe and life-saving treatments. So I think, again, a concerted effort to, again, nothing happens by chance. You need to plan for it and ensure that you have a system in place to facilitate that task shifting.
Thanks. There is a hand there, and there is an online question, and hopefully we can take another hand, and we walk to a closure. Thanks. Yes, please.
Well, thank you. It's a kind of two questions, or maybe a provocation about self-stigma. We as doctors, pediatricians, we start to tell to the child and to the parents, don't talk about this disease. Talk like monthly, you're not going to the school or something, you have a heart disease. Then we are telling to the child, you have a bad disease. You have something that you shouldn't talk about that. Then the self-stigma starts there. And it can be a big challenge for us before the child has contact with the population or external contact. We are already creating that for the child. It's a challenge, how to deal with that. And the other one is about diagnosis. We are talking about 6 million children. And then if, for me, the diagnosis will be the easiest part, even it costs a lot, like 6 million tests will be expensive. But then we come for the second step, it's life treatment. So it is costly and difficult, complex to maintain. We are talking about that, how to deal with that. I mean, these two problems can be a big challenge for us when we are planning to help in these 2 points. Thank you.
Thanks so much. I know we want to react. Keep that thought for the take-home message. Let me take a question online, and I'm coming to you.
Thank you. Children and pregnant women have been in the exclusion criteria of community ARV groups, CAGs. Can now they be included? Can we talk of family CAGs?
Kim, you want to go or I go?
Great question. They're slowly, as I was saying, is a hope, and now in some CAGs they started to include them, especially with certain criteria being met. I think OCA is going to be sharing some results of their CAG groups they've done that include children, and they'll explain how they included those ones, the ones under 1, the ones 5 to 15, and et cetera, and how they did that safely. So we will have some examples that we will be able to see. It's a slower one because of children grow faster, et cetera, that people have to think about differently, but there are ways that are being developed.
And I think an important message is that we always think that kids, they need monthly prescriptions, monthly refills of this chronic treatment, and this is not the case. And we have nice guidance and nice tables and longer refills that can go 2-3 months and later on 6 months again. So I think that this definitely nothing is written on stone on how we design our system of care. Your question.
Thank you very much. Mine is a mix of question and recommendation, probably. I could say that I must declare that it's my first time to be on Pediatric Days in MSF. And with my experiences in MSF, I've never worked with PMTCT, but previously worked with Ministry of Health in Tanzania, and we had a program called PMTCT, which was changed into EMTCT. And one of the success stories was to include the father in the program, and really this helps a lot with elimination of or prevention of transmission of HIV in children. Yeah.
Thanks so much. Thanks so much. And are we closing, or can I take a couple more questions? We're closing. Then I think that, but because we are closing, please give us like 10 seconds for us to share the 1 second take-home message that you would like to share with everyone else. And I'm going to start with Ivy. And I'm going to include myself.
Okay, I'll start. Since I'm at the beginning, I'll also start at the beginning, is we need to find the children. For me, it's the entry point. We need to find these children in order to put them on ART. You will not have children surviving if they are not found. They are hard to find. Sometimes we need to be very active looking for them in the communities. Don't forget the older children. Often we are following mother and child, but let us follow mother and children in the communities, including the older children.
Yeah, I think for me, I think it's really around emphasizing that person-centric or the family-centric viewpoint, and many of the issues that arise in your example of patients moving away and not telling us, we can address them if we include the patient as part of our treatment model. So I think really around emphasizing the need for putting our patients at the center of our treatment model.
Doreen.
As for me, let's normalize the HIV conversation. We have had HIV for so long. It's time we stop being shy around it. And from you as a healthcare provider, create that trust with the child, that they know that they don't have a heart condition. They have HIV. They're going to be on treatment for the rest of their life, but you're there to work with them as well as the healthcare provider. And to the guardian, they're also there to hold their hand. So if we normalize the HIV conversation, we'll be a step closer to reducing HIV-related stigma. Thank you.
Thanks, Doreen. Katie.
Thanks. I guess mine would be, and I said this already, around demystifying HIV care specifically for children and adolescents. We have the tools to do this. We don't have to invent them. We all can. We just need to start thinking about it and integrating it into the everyday activities that we're already doing.
Yeah, my key message is to give you homework, to go back to your projects, to look at the current activities you're doing and see where you can inject or optimize HIV testing and treatment, and also keep the children who are already on HIV treatment successfully treated and growing and developing and becoming adults wherever you work.
And my takeaways come back to integration. What I mean by that is every single department, every single unit within the healthcare ecosystem should always think about HIV, which means the pharmacist, when you arrive in a project, are there ARVs in your stock? If yes, great. Are they moving? And if not, why? If you're a midwife, they're thinking about PMTCT, that you should be able to give treatments as well. In malnutrition, a child is not gaining weight, maybe he has HIV, etc. So if everybody's thinking about it and doing something about it, I think we can also move that forward.
Yeah, thanks a lot. Exactly. My takeaway I'm going to share is children left behind living with HIV are where we don't treat HIV. So I think that it's a lot of, as you were saying, in our routine daily activities, think HIV. In our wards, no child should leave our wards, our IPD care, or our OPD care without an HIV testing. And I think that like that, in anywhere where we work, we're going to hopefully turn that tipping point. And I'm going to now finish that session here and hand over to Alexandra. Thanks. Do you want this? It's working now.
Thank you to you. Both in the room and online, we are sorry we couldn't take all your questions, but we will be available just outside the building on your way out. But for now, we heard what they think, but what do you think? What are the highlights that you will take with you from this session? So, in the room, we suggest old-fashioned way, you take a piece of paper and you write your 2-3 key messages that you want to take home, your highlights from this session. And when you leave the room, wait a bit, then you leave it in the 2 boxes there. Yeah? And you're very welcome to discuss with your neighbor on your table what you want to write. We'll give you a few minutes, and online, we can't take your papers, so write it in the chat. Yeah, I think it's nice. So it would be working now, I think. Thank you for filling out the papers. There are 2 boxes at the entrance, at the exit. But before, we, the organizers, would also like to share with you what we hope we got across for you to take home and consider. Children and adolescents are still left behind despite the increased risk. And this is on us in our projects. Windows of opportunities to test and treat in MSF and globally. I think you heard from all the panel the different opportunities, and that we need to think about it in an integrated way. Oh, here. When TB, think HIV. When HIV, think TB, because co-infection is frequent and carries a high mortality. Tools and guidance updates are available, so there's no excuse. We got to do the job, and we got some of the tools presented here. There are more on the resource library on the platform. There's a stand outside. There are papers on the flyers on the tables, and we will be outside. So we can do better. We can do better in our HIV continuum of care, because like Esther said, we need to diagnose the baby early, to start treatment early, and to prevent later on for adolescence and transition to adulthood and parenthood that the next child, the next generation is infected. So, thanks a lot for your participation. I hope we addressed all your suggestions in the word cloud. We will finish the session now. If anybody is particularly interested to continue the conversation, we will be outside for you to meet the panels, ask the questions you didn't have time to hear, but also to meet colleagues struggling with the same challenges that you are. Yeah, and then the last point, don't forget to put the papers in the boxes when you leave. Thank you.
Thank you, Alexandra. Thank you, the panel, everybody. And we have a few announcements. We'll be coming back exactly at 2:15 after lunch.
And just a few important announcements. For MSF staff, we are running some workshops on Sunday. If you haven't already, if you've signed up, please confirm you are still attending at the registration desk. There are also some places available in some of the workshops. So if you're going to be around tomorrow and didn't sign up but are interested, also see registration. The workshops are child safeguarding, pediatric chest x-ray POCUS, pediatric pain and procedural sedation, and a MAMI innovation workshop for nutrition. So if you're interested, please see registration desk. And thank you very much to those of you that returned pediatric guidelines. That is very kind of you. For project staff in the room that didn't get them, please also see Maria at the registration desk. Hopefully she can help you. We may have a few that we can give you to take back to the field. And a reminder for the speakers in the HIV session to just head to the briefing room straight after here, and then they will be at this designated area at lunch for conversations with coffee, because I know there are a lot of questions in the room that we didn't get to. And I don't think I've forgotten any other announcements, but please return on time at 2:15. I know that we have lots of activities and people to speak to, but please, for the sake of the speakers and the running and the online participants, please try and come back on time at 2:15. Enjoy your lunch. It's in the restaurant across the way.
Again, 2:15.
Effort to come back on time, much appreciated. We're going to start the afternoon session. It is our final session, and at the end of today, please don't run away. We are going to attempt to get a whole conference photo at the end of the day. So please, if you can, if you don't have to rush off to catch a flight, please stay around and we will have a photo all together so you can remember this occasion. We are going to start with another breaking news session from another one of the pediatric advisors. So I have the pleasure of introducing Dr. Sophie Janet, who is one of the pediatric advisors for OCPA, based in Dakar. She's a pediatrician with a specialization in neonatal care, and she's going to talk to us about zero separation.
Thank you so much. And I don't know how many of you attended last event to the PED Days. Can you stand up, the ones who were there? Stand up, please. Come on, we just have lots. We can exercise. Okay, very few. Oh, and most of content coordinators. So my question was, for those who were attended, it's a quiz, huh? What was the first session of the event?
In progress.
Anyone remembers? Zero separation. And I'm so excited to be here today because after a year and a half, I think, we are managed to put all MSF together, 5 working groups finally talking together and having one point in common. The 5 dear meds approving, well, all dear meds of all the OCs to release a new position paper on this very important topic. We have seen yesterday and today how important it is to integrate care for mothers and babies. So with this, I'm going to explain a little bit the position paper. We all know that the relationship between the mother and the baby starts even before the baby is born. Pregnancy, childbirth, and postpartum period are pivotal moments of vulnerability for both. Sorry. Sorry, I'm not managing well this. Sadly, every year, 300,000 women die during childbirth or due to pregnancy-related complications. And a staggering 2.5 million newborns die within the first month of life, most of them during the first week, and a majority of them in the first day. You can imagine what those numbers mean. These statistics underscore the vulnerability, the profound vulnerability of this dyad. And the challenges don't end there. Soon after birth, we often witness in our projects how healthy newborns are put aside, and if they're lucky, under a rhythm warmer, but most of the time they are wrapped and put next to the side of the mothers. And this limits essential newborn care interventions that we know that works and decrease morbidity and morbidity, such as skin-to-skin at birth or breastfeeding in the first hour of life. And we avoid the bonding of this couple. And this separation is perpetuated when one of them needs medical care. And this is the sad reality of most of our neonatal units, and I think it's not only about MSF, but in most of our countries where we work, this is even in high-income settings. This is the reality of newborn units. Now we change to the disco mode. No, sorry. So I want you to see this image and tell me what is missing here. There's missing space for mothers to be present, and also, why not, fathers and other family members to support the care. Mothers, because who do you think this baby wants to be? With this man, very scary man in white, or he wants to be close to the mother? So it's not a brainer. We're not talking about new things. We're talking about essential and fundamental things here. We're talking about these children and the mothers deserve to be together and have an integrated care. So I'm so glad it took us a year and a half to produce a document. But this document really means a lot because there's so many working groups involved. We have, as you see in the picture, sexual and reproductive health, pediatrics, nutrition, nursing, mental health, but there's many other multidisciplinary people who supported this initiative, logisticians, med operations, many other people. And so here we are with a new document saying that in all MSF projects, we endorse integrated maternal and newborn care to do a paradigm shift in the care we provide for mothers and babies. So it's time to do it, and I will take you through this document very quickly because there are core principles that we need to understand. The document will be in the pediatric booths where you could read and see the different initiatives that are under zero separation that are well known to decrease mortality, such as KMC, so immediate kangaroo mother care, breastfeeding, and other initiatives. But I will take you through the core principles. The first one, the first one, integrated care. And we talked today and yesterday about this. We need to integrate care and provide a holistic care for mothers and babies at any opportunity and across the health journey. If we are in a neonatal unit that we have a mother next to it, we need to ask the mother, how are you, mama? Do you have a postnatal depression? Do you have malnutrition? Do you have any signs of any health issue? And we are not doing this, and we are then doing this siloed care. And the other way around, where we have the mother present because she came for, I don't know, another visit, we need to see how is also her baby. So any opportunity where we have this dyad, we have to give them a holistic care. How to do that? We need to be creative, and there's way, and there's people who have been doing this in some countries. We need to promote proximity. Currently, our services are divided in neonatal care and maternity care, and they're a complete disconnect. We need to rethink the way. We need to think ways and creative ways to do that. And for example, in our setting, sometimes a baby born in the maternity who needs antibiotics or who just is healthy but have a hypoglycemia, it's sent, or have risk of hypoglycemia, is sent to the neonatal unit. Can we not just send a nurse to the maternity to do that next to their mother? Why do we need to do that? So proximity. I'm almost fun. I know I have 1 minute left. Person and family-centered care. And this is the core of the Zero Separation Initiative. We need to put mothers, fathers, families as the center of the care. And what does that mean exactly? We need to ask them what are the priorities, what they need to make our medical action adapted accordingly to their needs. We need to change the way we work. Really is driven by them. It's obviously that the medical interventions we know are evidence-based, but there's ways to deliver them differently with accepting their culture and their needs. And this is the thing we need to start changing. We need to empower women, fathers, families, and community to be active owners of their health and of their children. Because if we have a mother who understands what are the disease of her child, the nutrition that her child needs, we will have a healthy children. So we need ownership, for their ownership. And finally, but not least, autonomy and respectful care. Mothers' choices, mother voices need to be heard. They know what is best for them and their children. And we need to support them. We need to create enabling environments and supporting care for them. So this is it. But for me, Zero Separation, it's a call for action for everyone. We are all actors of change, and we need to really think the way we provide care for mothers and babies and start delivering the care they deserve, because we deserve to give them something better. So thank you all. And now I'm so excited. Sorry to give, we were here, the talk of one person who has started coordinating the implementation of Zero Separation in MSF project. So this is possible. It is a starting point, but we can do this in MSF, in humanitarian settings, and across the whole movement. Thank you.
Thanks, Sophie, for sharing your passion and your dance moves. And as she mentioned, we're now going to have a PED talk by Sergio Cabral. So I'll invite him to the stage, who will give really a practical example of how zero separation can be done in real life. Sergio is a pediatrician and cardiologist and has a long history with MSF, starting back in 2007, and was one of the first pediatricians in the field. So thank you, Sergio.
Well, I will be reading because I'm so in love with a zero separation. If I speak freely, I'll be speaking for the whole afternoon. And I will do it in French because I'm in Burkina Faso. I think it's good to speak in French. Imagine
a maternity where a mother comes with abdominal pain, where this is not authorized. Birth takes place well. Birth takes well. They are both in good health, and the baby is birthed in a room. The mother of the child does not rest 2 hours after birth, this is the reality of maternity in Burkina Faso. Zero separation, as Sophie has spoken about it, is a humanized approach where there is patience with the patient to sustain the mother and the baby, where they are prioritized, and the mother is allowed to make her choices. During hospitalization, when the baby is sick, she has the right to be accompanied by her mother. The ultimate expression of medication with a truly biopsychosocial approach for maternal care. One of the objectives of MSF is to integrate zero separation strategy in care in the project. In 2022, MSF started to support medical centers within Dakar, and in 2023 a new construction was made for a maternal neonatal unit was constructed. Sorry for that. After some steps within this construction process of constructing the neonatal maternity unit, we started working on the former maternal units. From then, we concentrated our efforts on the former maternity unit because we needed to start between December and January. We had a delay, and we started with the maternity that you see so that we could start with zero separation. This small maternity unit allowed also the husband to come during the birth, but the conditions were very limited. However, with the reactivity that we were able to do some adaptations to be able to attain the ideal setting. Today, the reality has changed, even if there are certain constraints as far as implementation of zero separation is concerned. We have been able to establish that the establishments slowly after the birth, the child is put on the chest of the mother before cutting the umbilical cord, and the baby is put close to the mother immediately, and the birth room, we allow the father to go and take care of the baby, to change the nappies, to wash the baby, where now the companion of the mother or the father is able to undertake their professional, their parental responsibilities, and not as healthcare responsibilities, but rather the parental responsibilities kick off from that particular point. This was made possible because we have a team spirit. We also work with the Ministry of Health for us to be able to accomplish these objectives. For us to achieve zero separation, the first step to overcome was the perception of the staff vis-a-vis the population on zero separation mentalities, to be able to combat the traditional mentalities. We also have permanent contact with the pregnant women and communities for us to be able to understand their perceptions and mentalities in place. Thus, we have been able to adapt medical care to needs expressed by the families and the community. Thereafter, we started by training the personnel. We were able to carry out training on zero separation with the simulation. We're going to show you our staff worked on the simulation to prepare them before maternity, and also during the implementation in the small maternity wing. The staff were extremely passionate and enthusiastic to able to work with the companion, to work with the wife. The fact that we're able to see men within the bathroom, that was extremely interesting for the team, and we started working in such a manner with the pregnant women. We thereafter started thereafter started follow-up training with the team and midwives. and the officers in the new strategy so that they can respect the framework that has been put in place. We also have a participatory interaction, and the staff were able to work with the mother, the baby. They started to participate, and they were able to encourage the mothers towards this change. The parental part of it is the first part. Secondly, we have to manage behaviors, which is one of the most difficult parts to do, and this is the responsibility of the staff. We started off with essential elements of zero separation in cesarean sections. We allowed the companion to come into the room. The state, there was confidence in the zero separation approach by the personnel. Therefore, we are able to do an animation within the unit. The personnel were a bit tense, but because the babies responded well, I was able to calm them in that particular occasion. In that case, the midwife did not put the baby in the maternal wing, but they're going to take the baby to the room. We're able to calm the baby and go forth with zero separation. I took the baby and put it in contact with the baby, and I explained to the mother what exactly happened. I left the baby with the mother for intimate contact between the two. And the woman, the mother looked stressed, started to stretch, in happy and to smile. She embraced the baby, and also we noticed that the operational team initially was tensed, but now they were very satisfied with the results. This gave us so much confidence, such that 2 days later they were talking to everyone within the operational team on what zero separation is. That gave them passion and energy to continue their work. When zero separation was accepted, the several changes, we were able to see spontaneous attitude change. We midwives that constitute were very the bathroom is extremely technical because that exposes the women. But because there was only one woman in the room, the midwife was able to allow the husband to go in and accompany his wife because he was alone. At that particular stage, there was privacy in the room. Simulation and training was equally done to support the doctors, nurses that were taking care of sick children within neonatal unit. This baby, as far as neonatal health is concerned, had some few challenges. The staff were resilient using the methodology because for them they thought that they are overworked, they had too much of a burden, but the need to take the best care of the child. What did you do? We put a practice where every other child after examination must be must feed from the mother's milk. The fact that the conception we were able to learn that that is prevention for different problems of respiratory infections, amongst other infections. Zero separation allowed us to boost the essential quality medical care. We have the maternity. Here we've got the bathroom. Here we have the man together with his wife. We have got the neonatal unit here. We have a very comfortable chair that is next to the bed. The bed is very comfortable. We have the mother. We can see that these structures are the same always. We've got a bed for the mother, a place for the grandmother of the child. And it's not only kangaroo method that is used. It is also, then there's also the need to observe the child for any medical conditions. We can see for twins, if you've got premature twins, what we need to do, we can have the mother with the child or the children skin to skin. The cost of zero separation is very low and the impact is very high. Consequently, we recommend it to all the maternities to apply zero separation next year. We expect to come back and present to you the results of this initiative that we've started. Thanks to you.
Thank you so much. So nice to see the practicalities of it and see such family-centered care happening as part of zero separation. So we're going to continue now with the neonatal theme. We have the neonatal oral presentation. So Sophie will moderate this session and I will invite the 4 speakers, so Philip, Tanya, Marina and Bar Mamadou up onto the stage, please. So we will continue the neonatal theme. We might see more of Sophie's dance moves, I don't know.
Clap very high, I can start dancing, that's fine. Thank you. Well, continue clapping to welcome the new speakers for this oral presentation. Come on. So we will start. This is an oral presentation for neonatal session. You have already seen how important neonatal care is, so we will have from some of our projects to hear some experiences. So we will start with Felipe Gosa-Ovabum, Medical Coordinator Support for MSF WACA, who will share his experience and analysis of the contextual analysis of hypothermia in Nigeria. A big clap for him.
Good afternoon, everyone. Allow me to greet you in the typical Nigerian official way. So, good afternoon, distinguished ladies and gentlemen. I've not finished. Men of timber and caliber, men with experience far beyond this world. It is a pleasure to be here on behalf of Katsuro Dano, who was our epidemiologist and anthropologist at the time when this study was done. So at the time, and we're still having discussions between MSF Japan, MSF WACA, and designs, DTM, Designs That Matter, on the use of the baby warmer. So now at the time, before we consider this, it is important to think about what are the problems in terms of hypothermia. So I'll be presenting the very short study we conducted at the time, which is the incidence and the contextual analysis of neonatal hypothermia at Garangamawa Maternal and Child Health in Kano State, which is a facility that MSF WACA supports. So now this is Kano. It's in the northwestern part of Nigeria. So during the cold season, we have dry and cold air from the Sahara. So around February, the temperature drops to as low as 20 degrees. So now, neonatal hypothermia is a major risk factor for high mortality. And the study, like I said, was done to understand the incidence of neonatal hypothermia and to improve midwifery care and to reduce related neonatal mortality. So now this is Garangamawa maternity and maternal and child health, sorry. So now the study was done in January. It was done in February, but quantitative data was collected in January. It was a mixed method. Data of newborn in 2022 of January collected anonymously on a spreadsheet, and the statistical analysis was a one-sided test for binomial proportions. So for the qualitative aspects, non-participatory observation was done at the delivery room and postnatal care, observing how the maternal and child health staff follow the warm chain and the interaction between the staff and the mothers. So individual semi-structured in-depth review was done with 8 maternal and child health staff. So this was the results we got: 206 newborns in January, of which 26% had hypothermia. We also, in the non-participatory observation, we discovered that it took about 40 minutes from birth until the baby was forwarded to the mother after delivery, during which time the midwife was wiping the baby, using olive oil, putting the baby's clothes on, and cleaning the mother. So you can see that the KMC was literally can't be seen here. So that gives you an idea of how difficult implementing KMC was. So the delivery room entrance were kept open, which was another challenge. And for after delivery, for the mother to access the PNC, she has to come out in the cold and go back into the PNC ward. So there was neither heating system in both places. So traditional home delivery in Kano, usually when the labor starts, they prepare a thread to tie the umbilical cord, a razor, the windows are closed, and they boil water. So immediately after birth, they bathe the baby, remove the vernix of this from the skin, and pour olive oil, which they use to massage the baby. So you can see under it says that cold makes the mother and the baby become ill, hence the reason for some of the practices. Now, when we interviewed the midwives, they heavily rely on putting the clothes on the baby rather than KMC. Warm chain was prone to interruption, and whatever was left of the warm chain was further complicated when it was a complicated delivery. So, in addition, a few midwives didn't remember the MSF definition of neonatal hypothermia correctly. So, in our discussion and conclusion, the proportion of hypothermia in neonates was significant. The delivery room is recommended to have a door. The delivery room and the postnatal care ward should have heating system, and the staff are encouraged to build the knowledge of neonatal hypothermia and skills to maintain warm chain. KMC has been shown to have an important role in preventing hypothermia and must be encouraged, which we have been doing as part of our capacity building, as part of the MSF worker strategy. So special thanks to Katsuro for doing this study, to all the participants who were willing to be in this study. We also like to thank the entire WACA team, from Kano coordination to Abidjan, for their unwavering support in conducting this study. And this was the ethical statement. Thank you very much.
Thank you so much. And hold your questions. I have many, but we will do it at the end of the session, okay? So let's now, please, Tanya Hassan. We welcome Tanya. She's a pediatric intensivist doctor working in MSF, who has a vast experience in training, and she has supported the implementation of CPAP in Mosul, Iraq. Over to you.
A little short. Assalamu alaikum, everybody. Greeting you in the Iraqi ways. So I'm presenting an Iraqi study. Okay, perfect. So I'm going to be talking to you about our experience implementing CPAP in Mosul, Iraq. Ideally, the Iraqi team would have been here to present this, but you're stuck with me. Unfortunately, they couldn't come due to administrative reasons. But I want to just acknowledge our CPAP focal point, starting from the right, Dr. Muhammad Amir, who's the CPAP focal point, and the three CPAP focal point nurses, Khalid, Ali, and Khulud. So thank you very much. All of this hard work would not have been possible without them. Just a quick ethical statement. The study fulfills the exception criteria of the MSF ERB. So a quick introduction. It's an unfortunate paradox that access to basic life-saving therapy is limited, particularly in the regions of the world with the highest burden of critical illness, pediatric critical illness. In fact, about 80% of the global 6.4 ventilation that is very common in high-income countries, but less so in low and middle-income countries. Despite the fact that it's highly recommended by the WHO, particularly for preterm infants with respiratory distress syndrome. And this comes from very strong evidence that in preterm babies with respiratory distress syndrome, CPAP, when compared to spontaneous breathing with supplemental oxygen, is associated with reduced use of mechanical ventilation and a significant reduction in mortality, approximately 50% reduction. It is, however, associated with about increased rate of pneumothorax, and that's the main complication of CPAP. The data in low resource settings is less available, but the data that we do have suggests that bubble CPAP can reduce the need for mechanical ventilation by anywhere from 30 to 50%. So what is bubble CPAP? What you'll see here is a closed circuit consisting of an oxygen concentrator, a humidifier that leads to an inspiratory cannula into the patient's nasal interface, and then the expiratory limb that's submerged underwater. The number of centimeters that it's submerged underwater determines the positive end expiratory pressure that's delivered to the baby's lungs, or the PEEP for short, and that keeps the baby's lungs expanded. So a little bit about Mosul, Iraq, where we implemented this. Mosul was the last ISIS stronghold, and it was devastated by a prolonged war and its aftermath. And it's with that in mind, and at the request of the local hospital team in Mosul, that we decided, or MSF decided to implement bubble CPAP in April 2021. So the objective of our little study is to assess the key aspects of implementing bubble CPAP in a humanitarian setting and describe our initial cohort of neonates treated along with their clinical outcomes. So what you see right here is the CPAP machine that we use. It's the Diamedica bubble CPAP. So this is the oxygen concentrator, the humidifier, the inspiratory limb that connects to the baby's nasal interface, the expiratory limb that's submerged underwater, and we can adjust that to deliver the amount of positive end expiratory pressure that we want to deliver. So we collected clinical data over 16 months, up through July 2022, and we used descriptive statistics to assess the feasibility and outcome of CPAP. So I'm really bad at talking and looking at the slides, so the sound is a bit strange. So we trained over 50 healthcare providers using a multimodal teaching approach consisting of theoretical interactive teaching, case-based scenarios where we built a small NICU over the course of the day with various infants with indications and contraindications for CPAP, and we used those cases to illustrate the various complications and the reasons why we would escalate or wean respiratory support on CPAP. We also used hands-on practical training using mannequins and simulation. And then finally, we used supervised implementation for a couple of months at the bedside when CPAP was implemented. So a little bit about the indications and contraindications. So to be placed on CPAP, the neonate had to be more than 1 kilo and more than 32 weeks gestation. They had to have a respiratory condition that would benefit from CPAP, and they need to have signs of respiratory distress, hypoxia, or apnea. They also needed to have an absence of the contraindications for CPAP. And the contraindications for CPAP are mainly things that would not benefit from CPAP. So for example, facial injuries or anomalies of the respiratory tract that would prevent you from delivering the PEEP, or a cyanotic congenital cardiac disease whose hypoxia wouldn't correct with CPAP, or for example, severe neurological impairment, SARNet stage of 3. So there were 93 neonates that were placed on CPAP during the study period. Approximately half of them were term. And the primary respiratory diagnosis was respiratory distress syndrome, followed by pneumonia, transient tachypnea of the newborn, and meconium aspiration. The average duration on CPAP was actually quite short. It was a little over 2 days. And the maximum setting on CPAP was, did not exceed a PEEP of 6 in 75% of patients, and the highest PEEP that was provided over the study period was actually just a PEEP of 8, so not a very high PEEP. So a little bit about the outcomes. The majority of patients, about 2/3 of the patients, recovered and were discharged home. 7 of the 93 patients were discharged against medical advice, 8 were referred, and 14, or 15% of patients died. So chart biopsying those 15 patients that died, and remember that the children that are placed on CPAP are going to be the most critically ill children in the NICU. Approximately, well, 7 of the 14 were found to have contraindications to CPAP that were recognized in retrospect. So what does that mean? Of the 7 patients that died, or sorry, 7 of the 14 patients that died, later, if you break those 7 patients down, 3 of them had congenital cardiac disease that was identified later, 1 of them had an anomaly of the respiratory tract, and 2 of them had severe burst asphyxia that you can only diagnose several days after delivery using SARNet staging. Approximately half of the patients, of those 14 patients, also presented in extremis or were placed on CPAP in extremis, so either with severe and rapid deterioration and hypoxia or at the point of gasping. So these are children that in a higher resource context would have probably gone straight to invasive ventilation. The major complication we saw was nasal lesions in about 17% of patients, followed by irritability, and pneumothoraces in 5% of patients. And that's actually, the pneumothoraces statistics actually in keeping with other implementation CPAP studies. It's usually around 5%. The team was taught how to recognize them using chest x-ray and ultrasound, and how to decompress them when found. So most of them were recognized early and decompressed. So just a minute about barriers to implementation. The primary barrier is actually the human resource needs. So you need a very high nurse-to-patient ratio to deliver CPAP. The safe nurse-to-patient ratio that we determined was 1 nurse to 2 patients on CPAP, or if there was only 1 patient on CPAP, then that nurse could take an additional 3 non-critical patients. CPAP also requires prolonged training needs in the form of a training pediatrician and a nurse that are present for a long time. We also highly recommend this concept of a CPAP focal points. We found that that can aid in the transfer of ownership and facilitate continuity of training and quality assurance. And then finally, we would recommend a lot of collaboration between MSF settings where CPAP was implemented, because there's a lot of redundancy in the training needs and in the troubleshooting that happens when you implement a new project. So that's really an invaluable resource that should be tapped into early. Another barrier is misapplications of inclusion and exclusion criteria, so the contraindications that are recognized later. Unfortunately, this one is hard to overcome because, for example, if you're going to wait until you get an echo to confirm congenital cardiac disease in an infant, it's going to be too late to initiate CPAP. The child would have already deteriorated significantly if he doesn't have congenital cardiac disease. Same with SARNAT staging. So there will be a number of patients who are found to have contraindications later. Cultural acceptance is the last barrier to implementation, and we would highly recommend that in any CPAP implementation project that the first few patients placed on CPAP are very straightforward patients, not patients in extremis, just to build the confidence of the team and to facilitate learning. So just to conclude, the majority of patients improved on CPAP with minimum associated morbidity. There are a number of patients that will not benefit from CPAP either because they have contraindications to CPAP that are recognized later or because really they are so sick that they require a higher level of care that cannot be provided in those settings. And that emphasizes the importance of clear context-appropriate indication criteria, training, and expectations of what CPAP can and can't accomplish. And then finally, using CPAP in a humanitarian setting may be feasible, but it is associated with high human resource needs for both training and practice. Thank you very much. Let me know if you have any questions.
Thank you, Danny. And for those who were here 3 events previous, we talked about CPAP, and one recommendation that came from that is we could do CPAP in our projects, but never homemade CPAP. So we have material to do safely CPAP, and this needs to be done by the coordination. So please, when you are in your projects and the new pediatrician arrives and say, oh, great, let's do homemade CPAP, you say, no, there is a statement, and we need to do it safely, okay? Just this little note. Now, please welcome Marina Gonzalez-Arias. She's a pediatrician with newborn care specialist. She has vast experience in working in Africa, and she joined MSF in 2021, and she will present her experience with the teams of us reducing neonatal mortality. Over to you.
Okay, good afternoon, everybody. Thank you so much for this opportunity because it's, I think, very important for us to be able to share our experience in apps when we were trying to reduce neonatal mortality. So first of all, for those who don't know Yemen, it's a beautiful country but has been suffering armed conflict for the past years. There where you see the star is where APS is located. So OCBA arrived to APS around 2015. When they arrived, the hospital was quite little, around, I think it was 30 beds. But then it started to grow and grow a lot. So when I arrived in February 2023, so last year, we had a neonatal ward with 88 beds. And we have a very busy maternity with like around 900 deliveries per month. Also, we were supporting ITFC, pediatric ward, emergency department, laboratory, surgery, mental health, so everything. We're going to focus on the neonatal ward. So just a picture of our neonatal ward, how it was by over the year of 2022. So in the picture, you see it's divided in 2 areas. Inborn and outborn department, because this was the way they used to create the wards. And then inside there were little rooms and separated by acuity, so green, yellow, and red rooms. So it was quite a very busy ward. We had like around 250 admissions per month, and the bed occupancy rate was quite high along the year, especially in some peak months during June to September. And the most important one was the mortality. So around, during the year of 2022, the mortality varied between 12 and 30%, with a mean of 21.1%. So 1 every 5 babies that enter the neonatology would die. What we first needed to do was to analyze what was happening in the neonatal unit to try to find out what we could be doing better. So the main causes of mortality were prematurity, sepsis, birth asphyxia. This probably is the same in most of the neonatal wards. So we also use the DEX tool that maybe some of you are familiar with it. that tries to analyze like the contributory factors to the mortality. So we found that most of the contributory factors were associated, and the ones that we found more frequently were complexity or burden of the disease, care setting inappropriate, escalation failure, and documentation of care. So after we thoroughly analyzed the mortality, we came up with an action plan. So, well, this is just like an example of how the action plan was made. So we went through every problem and then proposed activities to tackle every problem, and then prioritize them by how urgent they were, by priority, and also by feasibility, so how easily we could solve these problems. And then we made a chronogram. Okay. So for the activities, we started the implementation during March, April 2023. And we focused in, like, well, they were like many activities, but we divided them in 3 main pillars. So improving zero separation. I say improving because we never reached the goal standard of zero separation, but we were working towards it. Better adherence to neonatal protocols, and reducing nosocomial infection. Okay. After, to analyze our success, what we did was to compare the 6 months after the implementation of the activities with the 6 months before the implementation of the activities, and also to the previous year to see that there was no like seasonal bias because the weather or something else. Okay. So about promoting zero separation, okay? This one is the first one because it's the most important. So the unit had to be redesigned. Before there was like no room for mothers at all. So we tried to create rooms like the ones that you see in the picture that had like a crib added to the bed for the mother to be together with the baby at all times. But not in all the rooms we could do that, so in some of them we just had chairs for the mothers to sit beside the babies. Also, we revised the admission criteria, so the less severe cases would stay in the maternity with the mothers, and one neonatal nurse was assigned to the maternity so she could follow the cases there. And we created a breastfeeding and kangaroo mother care group that will meet every 2 weeks, and we would discuss, especially with the health promoters, what were the barriers that the mothers were encountering when they wanted to breastfeed or to do kangaroo mother care. So every 2 weeks we will have new things coming up, and we will try to find the solutions for these problems. Okay, so for adherence to neonatal protocols, this might seem quite obvious. Neonatal protocols were there, but sometimes it was difficult for the doctors to adhere to them, and sometimes there were like misinterpretation of the guidelines and many things. So we did formal trainings. Every week we were doing a neonatal topic, and also every day during the rounds we were doing bedside training. No? But also we had to improve the rotation of the medical doctors between the departments, because they were being one day in neonates, the next day in ER, the next day in ITFC, so this was very difficult for them to have some continuity. And we selected focal points to stay in the neonatal department, so to make sure that the things that we were implementing were staying there. And also we created a mortality committee to revise the cases every week. For reducing nosocomial infection, so in APS project, we had access to blood cultures, and we were detecting a lot of multi-drug resistant sepsis. So Klebsiella, Serratias, and there were outbreaks inside the neonatal department. There is a poster that Dr. Hashim explained before, so if you want to see the poster, there is more detail there. But what we had to do is to reinforce a lot the IPC measures, and we created an SOP to early detect, early treat, and isolate those cases of multi-drug resistant nosocomial infections so that it didn't spread all over the neonatal ward. So for the results, well, as you can see in the trend, so in the post-implementation period, we really had a significant reduction of the mortality. When comparing to the prior 6 months, we have a 24% decrease in the mortality. And also when compared to the previous year, it was a 26% reduction in the mortality. And what is better is that the trend is still going down. The last one is for December, 6.8%. And for what I know, it's still below 10%. So we are very happy with this. So, well, just to conclude, we know that mortality in neonates is quite important, so 50% of our under 5 mortality. So it's, we should talk about it more. And we know that low-cost combination of activities can have a significant impact in mortality. So we know that kangaroo mother care and breastfeeding at zero separation can reduce the mortality, but it's not easy to implement it. It needs a lot of effort, but that doesn't mean that we have to stop trying. So we need to try harder just. Also, for the medical staff working in the neonates, as someone said before, the neonates are not just small children, so we have to have specific trainings for them, and we need to have a specific staff taking care of the babies. And I think also it is super important that the local staff is involved and is involved in all the decisions and in all the projects, because otherwise this cannot continue over time. As for limitations, of course, we were comparing different periods of time, so there can be other factors included. And because this is a combination of activities, we don't know exactly which activity was the one that had more impact than the others. Just to finalize, I really want to thank the team in APS because they were amazing and they did an amazing work. Also the mother of our little babies, because without them, nothing of this is possible. Thank you.
Thank you. As we saw, big hospital with a lot of admissions, a lot of mortality, but big opportunities also to change. And so congratulations for all the team and all the effort that have done, because it's an amazing example that things can happen, and then we need to continue and follow this up. So thank you so much for your experience. Now we will switch to French, so put your audios in the other side, now I see. Bienvenue, Dr. Bamam.
You're most welcome, Dr. Bamam. He's a medical doctor since 2018 in pediatry for the last 4 years. He works with MSF in Mali since 2020, and he worked with OSEPE, now with OBA. He's coming to share with us his experience in improving the quality of newborn. All right. Oh, thank you for giving me the floor. Good evening, everyone. As she has said, I am Dr. Mamadou Rumbana. I am sharing about a training that we had. I think many people in this place helped in training. The team of Médecins Sans Frontières in Mali, I am sharing this experience on a virtual training that we had as a catalyst on improving natal care. First of all, let's speak about the Douaza project. It is one of the 4 missions in Mali, knowing that Douaza is at the heart of the country, and it is about 719 kilometers from Bamako, which is the capital city. On administrative position, it is a region, 18th Malian region. But on sanitary, it depends with the 5th region, i.e. Mopti, on its healthcare. Now, speaking of this, since the year 2017, our activities started at the health center and also at the periphery peripheric areas. The Ministry of Health, a support service, we had 7 of them at the reference health centers: pediatry, neonatology, nutrition, maternity, and emergency surgeries. And so the work has been intensified in Mondoro, Urumi, and Boro. And in childbirth, the service was created in the year 2020. At that time, there was only 1 admission center and hospitalization. And at the end of the year 2023, there was a reorganization, which is at the same time admission and hospitalization space. And now we have about 30 admission per year. What are the challenges in terms of health, birth health? If we need to think about the training, the quality of the clients, which is inadequate, which is lifting up the number of cases of death, and so there's high level of insecurity. Therefore, there are many initiatives that have been put in place, i.e. strengthening of the work. Now there's need for structure, i.e. gynecologists, anesthesians, and the training of people how to behave around the bed of the sick, the analysis, definitions, without forgetting the accompaniment. Now, accompanying the team, there's a virtual training that was organized for 2.5 months on all that has to do, and so the team was represented by this personnel and 2 medical practitioners or doctors. The chronogram of the training was as follows. 1, it was a training on tempo to know each training module. Secondly, there was a case of preparation of women. And so there were cases of situations that were shared, not only a virtual class for our nurses, but also for our medical doctors. It was a place of sharing knowledge and skills. It was very interactive. Now the question is, what happened to this question? People gather together to work and find together, they identify. We can now call Abraham Abra because of such. So this happened in observation when the care was being given. So we need to check what is there in terms of environment, procedure, the personnel, or the tools. Or the tool rather. So this was not only with those who are treated, but also parents, and that is families, and so we did some good number of analysis, including death, mortality, not only working with our supervisors, that is our heads of projects of the mission, but also to our trainers, showing how much we were happy to have our capacity built, how much we were happy to have learned so much through this childbirth care, and at the same time also expressed our will to improve the new birth care, child care, and they asked us to put in place an action plan, and we did. After that, why not do it why not develop a draft that was done, and later on here we are to make a presentation. So we need to look at the impact. So of course it was positive. Speaking of action plan, it is good to know that there were other plans that were ongoing. However, our action plan came to boost that because we brought them on board to discuss about the same. Part of this action, considering time, I'm not going to many details. Part of those plan of actions, we have training. There was need for theory, reality. Considering the project, we also needed to think on the practical aspect with sciences and assimilations in order to better feed the ethics, especially neonatal animation. And there was a part of reorganization of the case. And always at the work plan, there was a need for training. And as you always know, in some places it is parents and grandparents and grandmothers who decide on which kind of treatment will be taken. So we needed to sensitize not only the community, but also people within the structure. Now, we need to think of practical activities when we need work, for example, we need to see how kangaroo care is done. There was need to define the criteria. Though it is well put in place, we need to check. This was occasion to share this in many other places so that the person will know the respect of this work. And so be it small presentations or interactive exchange so that we may help each other understand why it's important to respect one another. Still in the plan of action, there was capacity building at neonatology, knowing that we have 4 nurses to cover the gap. So we had 1 per shift, and also gynecologists. We had 1 for 4, and now we have 2 out of 6. That means 8 of them. And of course, I will not take a lot of time, so let me go straight to the conclusions. As you can see, these are action plans that are on the way. Some were fulfilled, some are still yet to be fulfilled. And as you can see, the positive impact of the neonatal cases during the first 3 months of the year 2024. And here what do we have? Here's some pictures of neonatology word and also kangaroo treatment. We have a nurse that is teaching women how to do kangaroo mother treatment kind of work, and we use the cleanliness that the women will use at home, because in some contexts you may reach a place they use the hairs, so there is need to ensure that they can use them back at home, even with their husbands. They could use those to offer the same service. To conclude, we can see that this training, this virtual training, it was interactive and has allowed us to gain new knowledge in an isolated context. And we also had analysis of many other problems and change. And this was done thanks to the Neonatology Center, of course, accepting the project Mama Kangaroo, and also the implementation of the protocol of the MOU. And so we're trying to see how to reduce the mortality, at least from the year 2025. And with this, I thank you, and I share some of the images that we had during the training.
I don't know you, but I'm very proud of our teams in the field.
Je ne sais pas à propos de vous, mais
And we've starting to see some change. So hope all these efforts, I hope they last, and we need to continue all the efforts.
who have just arrived, will they get such training? Because in the project, we always have a good turnover. And so I think there is need to have training for new staffs when they come. Is there kind of a training as a follow-up? Thank you.
pour la question.
Oh, thank you for the question. Yes, as I did not go through the whole plan of action. There is a multidisciplinary team that was put in place so that to do follow-up, so that the plan that has been put in place and its implementation, and so it's already in the plan. There is a team that is there ready to work. It's a multidisciplinary, not only for doctors, specialists, of course, with those of health and community work, because they are helping us in sensitization in the community and also even in the reference health centers. Thank you.
Question online, is that correct? Yeah.
Yeah. I will try to do a translation from French to English, considering I'm Spanish. Let's go. So for the zero separation in the neonatology, would it be possible to replace the cots for a bed for the mother and the baby? I think maybe for Marina or any other, well, zero separation, you've been talking, the three of us. So. Thank you.
So the principal problem is that the space. So if you want to put beds in all the rooms, then you have to reduce the capacity, and the pressure is very high. So it would be the ideal to have beds in every room, but it was not possible at the moment, but this was the plan in the future.
Yes, other questions over there in the back and then in the front. Just remember to say to who the question is directed, please.
Yeah. My name is Ali Sheikh. I am from Beda Project, epidemiologist. My question is towards my friend from Nigeria. Brother, you did incidents of the neonatal thermia, and then I was expecting the result, like something to have like incidence rate or incidence proportion, or maybe relative risk of the outcome. But in your outcome, you showed us like proportion of hypothermia. So how did you conclude with that? So what happened to the analysis of the relative risk, all that stuff?
Oui, je veux répondre et puis further boost my answer. So, in general, we were trying to understand what was going on in Garangamawa in terms of neonatal hypothermia. So it was really we trying to have an understanding, and then at the time we were having lots and lots of discussion on the use of baby warmer in close collaboration with Designs That Matter. So we really needed to have some information. So that was why we went ahead to do this very short study. But I think at the time too, Dagi was our medical coordinator, so he will give us more insight.
Again, I was expecting that you were going to ask us this question. So this was an opportunistic study. So in end of December 2021, I got a proposal for an MD, PhD in epidemiology and master's in medical anthropology available for 3 months. I said, okay, let's get this person. And then we wanted to use Katsura Adano to help us understand epidemiological and anthropological perspective of some of the activities we're doing. So this was not done as a study, this was just done as a mechanism of understanding what is not working in our activities and how we can improve it. And the findings were helpful for us. And we thought it is really interesting to present. Thank you.
Thank you. So I think we were limited on time. So maybe if someone have a question for the CPAP implementation, yeah. I don't know who. Okay, at the back.
Good evening, everybody. I am Ulrich. I am from Central African Republic, and I'm working on Simon project in Haiti, in southern part of Haiti. I have two questions about CPAP. As we said, using CPAP in a humanitarian context is feasible. My question is about the outcome. Is the outcome linked about the gestational age, or is the result, the outcome, independent of the gestational age? This is the first question. And my
Sorry, is the outcome independent of what?
The gestational age.
Gestational age.
Age, yes. Because we use it in preterm baby.
Mm-hmm.
And the second question is, do you use, in this pilot project, do you use only CPAP in this preterm baby, or do you use CPAP also caffeine all together, and what is the result about the using of CPAP only, or using both CPAP and citrate of caffeine? These are my questions. Thank you.
Using CPAP and caffeine.
Caffeine.
Okay, yeah, thank you for your question. So to answer your first question on prematurity, we didn't analyze the data, the mortality data. Our numbers were not that big, so the total number of patients was only 93 over that time period. Obviously, we're now 2024, so we have more data. We just need to collate the data, and I think it would be useful to do the analysis, as you said, and do subgroup analysis based on gestational age, underlying diagnosis, and birth weight, other varying factors. We didn't do that analysis, but the evidence that I presented at the beginning of the study suggests that CPAP is particularly beneficial in low resource contexts for preterm infants. That doesn't mean it doesn't benefit term infants as well. It just means that the impact was greatest in preterm infants. Your second question about whether we were using it in term infants and older children. So we were using it for all neonates over the study period. My understanding is that OCG is now expanding CPAP in Mosul for infants above 1 month of age as well, so not just neonates. And I know there are other MSF projects, for example, OCP in Liberia, where they were using CPAP in children, not just babies. So I know MSF, you can use bubble CPAP in any age group, but it is particularly useful in preterm infants. As far as caffeine is concerned, you can use both. Again, we didn't actually look into which infants were receiving caffeine and do any kind of subgroup analysis, but I think those questions are very important, and in a bigger trial, you could do subgroup analyses so that you could adjust for varying factors like caffeine, preterm labor or prematurity, and gestation and birth weight.
Well, thank you, everyone. And I'm really sorry for the ones who still have questions. I have many questions. So I will see you outside later in the coffee break. Okay, thank you. Thank you, everyone.
All right, so to conclude our neonatal session, we're going to finish with neonatal speed posters. So I would invite Mariana, Ivany, Alison, and Anna Valori to come to the stage, please. So as with the other sessions, they will have 1 minute to present their poster to you, and it is going to be the lucky last break session to be able to go and ask questions for the posters.
Hi, everyone. So if you're working in your project with small babies, vulnerable babies, and you are wondering, how can I implement KMC? Or my KMC isn't working that well. Well, I did a systematic review on quality implementation strategies to implement KMC, and I have some recommendations that I believe could be useful for some of you. So please come and visit the poster.
Hello, my name is Ivany Kamala. I'm from Tanzania. I work with Läkare Global Health as an implementation consultant, and I would like to share with you one of our successful endeavors in Tanzania. That is the Safer Births Bundle of Care. So Safer Births Bundle of Care is a well-proven package of 4 components. That is the training of maternal and newborn care, especially for postpartum hemorrhage and resuscitation, as well as the use of clinical tools that you have seen at our booth, existing structures with low-dose, high-frequency supervision and mentorship, as well as the use of data for local continuous quality improvement. So our goal was to reduce 10% maternal mortality, 25% fresh stillbirth, and 50% fresh neonatal deaths in the 24 hours. And so we have been successful to do that in the 30 sites in the 5 regions, Mwanza, Tabora, Geita, Shinyanga, and Mwanza, by reducing 45, at least for the preliminary outcomes, to reduce 45% of neonatal deaths, as well as 70% of maternal deaths with these initiatives. There's so much to learn from the Safer Births Bundle that it's very possible to have a local initiative to give that results. So come to our booth and learn more about that. Thank you.
I have 1 minute to convince you why pediatricians should be interested in multiple micronutrient supplements in women of reproductive age, and our trial to look at the optimal dose for women in Kenya. So you've heard that 1 in 4 babies are born small and vulnerable, and there's extremely good evidence that antenatal multiple micronutrient supplements, MMS, reduce low birth weight by 15%, stillbirth by 9%, small for gestational age by 7%, and preterm birth by 4% compared to iron and folic acid. So WHO in 2020 recommended the use of antenatal MMS in the context of research. And currently, the MMS that's given is 15 micronutrients in the Unimap formulation. But we're looking at whether that dose is sufficient for women in Kenya. So come and see how we're going to look for the optimal dose. Thank you.
Hello.
Alors, elle est très belle, mais elle est toute petite. J'espère que ça ne vous gêne pas trop. Notre post est sur l'expérience.
Cascade training strategy. As you all know, helping babies breathe is a skills-based training to teach basic neonatal resuscitation. And as you also have heard throughout these 2 days, neonatal mortality is a high burden, it's a big burden of children mortality. And amongst neonatal mortality, perinatal asphyxia is our second leading cause in the projects we support with MSF, but also globally. So yes, come chat with us about your experiences trying to implement helping babies breathe. But also don't forget, help the baby to breathe, but then keep them skin to skin with their mothers. And come check out the skill stations that we have, where you can practice ventilation and also these beautiful wraps. Thank you.
So if you haven't already, please vote for your favorite poster in the 3 categories we mentioned before. We will be announcing the winners at the close of the day. So now it's time for the final coffee break. It will be your final chance to go to the skills stations, the booths, so please do visit if you haven't already. And just a notice for those of you that are registered for workshops tomorrow, please meet in the lobby during this coffee break, and the conveners of the workshops will be there to just finalize your spot and give you instructions for tomorrow. So enjoy your coffee break. Please be back at 4 o'clock sharp to start our final session of the day. Enjoy your coffee. This last session with our final PED talk. So I welcome Dr. Yanusa Soleimani to the stage. Dr. Soleimani is a doctor working with MSF in Niger since 2020, and following completion of a diploma in management of sickle cell disease, has now taken over as the doctor responsible for the chronic care program in the project, which includes sickle cell disease. So he will be speaking in French for those of you that need headphones, and I will hand over to him now.
Merci.
Thanks a lot for the floor. Thanks. Hi, everyone. It's a great pleasure to be with you. It's an honor to speak to you. Our experience on SS in an MSF context that we did work in collaboration with the pediatric unit. We're going to look at the context first of all. This is a pediatric project that takes in charge children less than 5 years. MSF has taken in charge malnutrition and other medical pathogens that are pediatric in nature in the hospital and equally in the integrated health centers. Moreover, we've got a unit that it takes charge from 2019 with 750 patients to improve quality and take charge of SS.
La drépanocytose pour voir est-ce que c'est faisable dans un contexte MSF.
To see what is possible. Sickle cell is a sickness that attacks the cells, and so it eats the good ones and replaces with the bad ones, and so this creates deformation of the red cell. And you see here the image. Here is a comparison between a red cell and the form of red cell with sickle cell. And so what happens here is you see this one is easy to be contaminated, and so we need to take care of this on the supplementation of folic acid and the deparasitoids in case of pain, prophylaxis in areas where it is attacking. Now, speaking of hydroxyurea, also known as hydroxycarbonic, is what has been used in many years fighting blood cancer, and it can improve the white cells, and it can help to remove negative cells, and so it helps in reduction of vaso-occlusive crisis. It also adds of hemoglobins. It plays a role in hemolysis because it helps to rectify the hemolysis. It is also myelosuppressions, which can create a diminution of neutrophil and plaquettes. And this has two business names, commercial names. Uroxyurea, which is rated IP 500 milligrams that children with small weight can use, and Cyclose that comes as 5 milligrams, which is more expensive but more adapted for small children with a small weight, underweight, sorry. Now, in the context of hydroxychloroquine, in our kind, there is need for training of personnel and also technicians of laboratories. So there is need to consider a selection and make consent from parents. We use the tools. These are the tools of data collection and sensitization on sickle cell and the use of hydroxyurea. We are about 100 milligram dose. How have you selected the patients? In order to choose the patients, for the sake of time, I'll go quickly. We use the criteria that we have mentioned on this chart, i.e. inclusion, exclusion, and non-exclusion. How did we explain to families after selections of their children? We spoke to families to have their consent. We explained to them what is hydroxyurea, why are we giving them that, and what is its advantage. And also they mentioned that we helped them see the use of it. We also shared with them the secondary effect of it, like reduction of fertility, which is reversible, and also there's matter to do with the blood. How did we then start hydroxyurea? After a full set of tests that was done, there is a need to check at the blood, education on therapy on hydroxyurea and hospitalizations between 48 to 72 hours. So there's need for adoption according to the weight. So we need to consider what is important, so we may need to have some hospitalizations for observations of the patient. We also add doses based on our observations. How do we do follow-up? We do our best to see the child after 15 days. Now, this is the clinical aspect, looking at the various signs that helped us or led us to give the child hydroxyurea. Here is the summary that you need to look for, especially here that is in green. You will see the signs, and the one in purple is a criteria for hydroxyurea, please, sorry. Now, how do people use this medicine? The people are hesitant to use it because of the side effect of it, especially on fertility, and we do ensure them that there is a possibility to solving that one. And so parents now begin to see that their children taking treatments, their health are improving. However, we also face challenges. There is the current political situation in Chad. There is also some work that has to do with follow-up that we are lacking because of the condition of the country at the moment, i.e. the quantification of fetal hemoglobins. There was also problems to do with negative results that are not in line with the parameters of hemoglobins. We are speaking of some advocacy to improve the treatment of sickle cells. Now, many people do not show interest on this sickness while it's a chronic disease that is creating chronic pain or recurrent pain. And sometimes parents spend a lot of money, and so this can really misorganize family and kill many children. And so we need to help patients by ensuring them access to prophylaxis, i.e. packet of hydroxyurea, the training of personnel in order to improve treatment by creating units on taking care of this case. We also need to create a space for testing and ways to combat this disease. And also there's need for public health, because when we look at the reality behind sickle cell, we need to have decentralization so that many sick people are helped. In conclusion, the initiative of the treatment by hydroxyurea needs the consent of parents and also to have vigorous parameters for the hemograms in order for this to be served. Thank you very much for giving me the opportunity to share with you my experience of hydroxyurea in the context of MSF.
All right, so now we go into the final session, which is an operational roundtable. So I'll invite Joanna Thompson up, who will moderate this panel. While she's coming up, for those of you that attempted the quiz, very well done. Most people scored very highly, which shows people have been paying attention. Some people scored more than the total points, so I don't know what you did, but very well done. All right, so we'll now go to the operational roundtable.
Thanks, Nicola. So we've talked about this how we frame this final session, and we've called it an operational roundtable. The idea being that we want to take out the key messages of this, these last 2 days and put them to operations. So I'm delighted to welcome 5 people to the stage with extensive experience in MSF. First of all, Mónica Camacho. So Monica's from Colombia. She's got a background in political sciences with extensive experience in the humanitarian field and 23 years with MSF. She's held numerous roles in field coordination and head of mission. Spent 6 years as operations manager for OCBA in various East African programs, and now holds the position of humanitarian representative for East Africa. I welcome back to the stage Chris Mambula. So Chris is a Nigerian doctor who you know from previous sessions, program manager for OCP. Gul Badshah, is Gul here? There he is. So Gul is from Pakistan. He's got a background in business administration, held various positions from log to PC and head of missions. He's currently the operational manager for OCA. Kennedy Olela, so Kennedy, there he is. He's Kenyan by background, got a background in nursing, held various positions in coordination, in diverse contexts, stable and unstable contexts, and been with MSF for up to 20 years, I think. He's the Deputy Cell Manager for OCBA. And I welcome back to the stage Roland Kaya. So Roland, you know from our opening speech, he is the General Director for East Africa. So very diverse profiles, countries, and I think on the stage we have here over 100 years of experience with MSF. So hopefully we can draw some information out of this session. So I'll move over to the couch, I think, and we'll start the session. Okay, so we started the first session we had was on vaccination and vaccine preventable diseases. And we heard a really heartfelt testimony from our colleague in Malakal about the devastating effects of when we don't vaccinate and the effects of vaccine preventable diseases. We were presented with some data showing that we're not doing well on a global level, but also at an MSF project level with routine vaccination. There's a lot of missed opportunities and we're lagging behind. And the comment was made that it's not a matter of vaccines, but a matter of vaccination. So I'll put this to Gul. You asked for vaccination. So operationally, what are we doing wrong? And what do we need to do better in terms of vaccination?
Yeah, okay, it's working. I was just wondering about MSF capacities, how much we can do in terms of vaccination as a medical humanitarian organization with all the opportunities. But at the same time, we also have a history, and we do believe that we are responding to emergencies. And I think that mindset, where we are not really focusing on the preventative side, this is the lacking factor. I think we all have these missed opportunities everywhere that we see, is because we don't think on that direction. We are only thinking on one direction, curative side, to respond. And then the other one is also thinking about us as a medical humanitarian organization. We are also having capacities in terms of emergency responses, and that always takes away our direction towards doing things, saving lives, that is immediate one. So for me, that also provides that opportunity for us to vaccinate more, because we have more and more opportunities that patients keep coming to us. But then at the same time, I think we are firefighting. We have a lot to do. We in terms of disaster that we see, the conflicts that we see, the humanitarian needs that we see elsewhere, in other fields, we focus more on that side, and then we do not have the capacities to really focus on the preventative side because we keep firefighting. All the vaccine preventable diseases that should be really covered by the vaccination are not really done, and then we are always responding to the outbreaks. And I think with this, we lack that mindset. At the same time, we do not have that kind of resilience to think as an organization who can work on preventative side. I think we would have to really work on that mind shift. Of course, we all talk about the missed opportunities, and missed opportunities are always there, which we can easily tackle as an organization. So, yeah.
So can we do both? Can we respond to emergencies, which is what we like to do and what we've historically done? Are there measures we can put in? There was mention of multi-antigen campaigns. So what are we doing to incorporate preventive strategies in our emergency response?
I fully agree with that. I think, like, for example, in certain closed settings that we are working in so many camp settings. We are regularly responding to the outbreaks, while we do not really think on the preventative side that we can work on preventive multi-antigen vaccination campaigns in those settings. Could be really cost effective. This is also one of the side that I think is part of that missed opportunities, I would say. Same time, we are working in primary health care, and when we look at our engagement with the local organization, with the local actors, and including the host government, we do not really engage on the level to understand what is happening there. What do they do in terms of vaccination, routine immunization? So I think, yes, we have all those opportunities to engage on that level, to have better understanding, and also to advocate. Because not only MSF can do everything, but we also need to have effective advocacy. And I think that is the part that we are also having we are lagging behind in that, and I think we need to improve.
Okay, thank you for that. I'll move to Kennedy. The next session we had yesterday afternoon was on nutrition, continuing on with the theme of prevention, because that was really something that came out. Again, we respond to malnutrition and often with food. But is it feasible to focus on preventive strategies in MSF? And what is MSF's role in malnutrition prevention?
Thank you. I think, first of all, given the magnitude of the needs in terms of malnutrition, and in regards to the funding by the partners, I think MSF, it will be really difficult because of our funding system, our priorities. So, as MSF, what are our operational, priorities? Do we need to go for food? Do we have budget for that? I think we need to push also the international community in terms of funding, because what we are observing today, a lot of funding, cut in fundings in virus by different organizations. So we will not be able to go into prevention. And if we go into prevention, then do we have the capacity in terms of budgeting? I think we need to work with the international community, the governments, to see their policies in terms of implementation. I think this is something that is key, because otherwise we have to go into food distribution. Do we have the capacity to do that at MSF with the needs that we have? So I think this is something that we need to discuss with the governments, their policies, what are their policies in terms regarding implementation, what are their priorities? Because always we are responding when there is already, huge malnutrition outbreak in different countries where we work.
Okay, thank you. Which links also to the next session this morning on HIV. So we heard that East Africa and South Africa have carry the highest burden of pediatric HIV worldwide. And the themes of stigma, low coverage across the continuum of care, and integrated care were key problems in tackling pediatric HIV. So Monica, what programmatic innovations can be considered to improve retention in our programs, and how do we work with other actors to achieve that?
Thank you, Joanna. The work that I'm currently doing is, I am the responsible of engagement for the East Africa region.
And not only for HIV, if I can extend to the other areas that you have been discussing the last 2 days, I think there are plenty of opportunities. We have a massive and extensive knowledge on the different experiences that you have been seeing on these 2 days, but we are still very, very, very egocentric, and we are still looking always at how we do things. And I think we are rightfully being proud of what we are achieving and what you people in the field are achieving. But as well, I think we need to see that and acknowledge and recognize that there is a massive and extensive experience outside there in terms of alternatives of models, alternatives of how to understand perception issues in communities, how to build up partnership with communities or with other type of institutions. So I think there is East Africa and Chris, that is the responsible of Kenya. I think the region has a massive, extensive experience, and this is just one of the regions where we work. But we need to be more humble and see how others are doing and learn and share as well. The colleagues of WHO and UNICEF, and I see people from Save the Children still holding with us, they encourage us to I think these kind of initiatives where we are opening up, where we are sharing and being transparent on the challenges and inviting to hear others how they are doing things, and as well to work more with local organizations, with universities, academy, and ministers of health. I think we need to be, teams are busy, you are very busy on trying to do the work the best manner and to serve those patients in the best manner. But we need to as well, other parts of the responsibility should be how to share more the kind of, not only information, but good practices or challenges. So I think that's something that we are improving, but we have opportunities to do more.
Thanks. And I mean, we talk about collaboration a lot. What does that mean? Can you give us an example, just to bring it to life, of an example of what successful collaboration can look like within MSF?
There are I'm trying to think of something concrete, but there are different models of care. Kenya has pioneered since ages different models of care, and the mission, I know they have positively engaged patient-centered approach. There are a lot of initiatives that are there, and I know the teams have tapped in and learned and empowered and learn each other with the other partners. So there are community-based organizations, patient or patient-centered, how do you say? Patient groups. So yeah.
Thank you. Over to Chris. So let's talk about zero separation. So we use zero separation, but it really is an umbrella term, and it really links, I think, all of the themes we've discussed this session. We're delighted that you've been here for the whole 2 days. But it came up in the nutrition session when we talked about maternal malnutrition and the links that it has with the newborn and child throughout the life course. It came up somewhat in the vaccination session, but more in the HIV session this morning, and then certainly in the neonatal discussion this afternoon. What does that mean for MSF and how can we operationalise integrated maternal and neonatal childcare?
That's a really good question. I'm not sure that there's a very easy answer to that. In the sense that we do know the points, I can say the pressure points where we can try to make an impact, and these have been mentioned during the last 2 days, as you said. So starting from the activities, and I think looking at it from a very pragmatic, in a pragmatic sense, is that as MSF, the types of activities that we know how to do very well, that we can make those changes at least within the our own sphere. So which means when you have a maternity service, there is possibilities within that project to create change and to implement zero separation. But at the same time, I think it's also important to do what we have discussed with WHO, UNICEF. It's also to let the people around us, and I think it's part of understanding our environment as well, let people know what exactly we're doing, why we're doing it, and very often we pilot things. We show that there is something that is actually possible. That said, I mean, there are, and I think this is where MSF, our strength is to more or less model or pilot or show using different approaches. And that's the beauty of having numerous sections, which is, I would say, a big strength of ours, even though it can be a weakness, or it is sometimes weakness, especially in contexts where you have all sections doing, present in a particular place. So for me, it's also being able to show, and like we've done in this scientific days, but not only, I think it's very important what was mentioned by UNICEF and WHO yesterday. These platforms that exist, whether it's at international level, so meaning at Geneva and beyond, looking at regional level, but more especially at country level, so meaning coordinations, and also project level where we have some of these cluster, so-called cluster meetings, or these kinds of meetings to show other actors exactly, okay, well, this policy sometimes has been integrated or written by the Ministries of Health. However, because we all know that change takes time, and if nobody has tried it, then people don't even see that it's possible. So I think that's where our strength is, to say, look, we have been able to implement in this project or in that facility or in this hospital zero separation. And what does it mean? What do we understand by that? What are the challenges that we have faced? How much does it cost? Very quickly, people will start asking you, is it more human resources? Is it more finance? Is it more space and logistics, for example? And I think they mentioned it today. You would see that almost all of the ones who talked about zero separation, especially for neonates, we change the kind of beds, we change the spatial arrangement, we change the patient circuits, we add more staff. So that's resources. So I think if we can do it at our scale, and that's what's important, we don't pretend that we can change everything, but we do it at our scale, we should show that to other people outside of MSF as well.
Thanks, and I think just important to note that we're not just talking about the environment when we talk about zero separation, and I know you're not saying that, but it's an important point because people sometimes think that, well, I don't have the space, I don't have the resources, so therefore we can't do it. But there are things we can all do at all levels to implement integrated care. It's about thinking of mother and baby together. That's been an overarching theme of this whole conference. So to have the message that zero separation really just means keeping mother and baby and child family together at all times possible. But thanks for that comment, Chris. And we'll move to Roland and then we'll open it up to the floor. So Roland, you open this conference with a very articulate speech outlining the current specific vulnerabilities of children and the need to prioritise on paediatric health. So what is your vision for paediatric care in the East Africa region?
Okay, thank you. As we all know, I said yesterday that more than 50% of our activity is actually concerning under 5 years old. And this is a reality. It's not something which we are just reading in the books. I think the first point of attention should be on what we're talking about, family-centered approach. Because you cannot take care of the children without taking care of the mom, and what you just mentioned about separating them. So in the culture in Africa, and many other contexts, we know that the mom is actually the one taking care of the baby or the children in the household, and this is really important. And if we don't understand this way of integrating the mom in the process of the treatment of children, we are going to miss a lot. The second thing is about our way of doing. Usually, we tend to go as a MSF, we do things, and we don't care about local actors who are already there. And when I'm talking about local actors, I mean local stakeholders, like traditional healers. We have also traditional leaders. We have the MOH, we have the government. So there are a lot of stakeholders whom we don't actually integrate in our approaches, because we come, we work for 6 months, even 5 years, and we leave. After that, it collapses. So if it's collapsing because we did not think about a long-term approach which can make every effort we are doing sustainable in time. So all of this, talking about what Gul just mentioned in terms of vaccinations or nutrition, one of the aspects on which we are really behind, and we are happy that we are pushing a lot on it, is anthropology and sociology. We tend to work on guidelines which are implementable everywhere in the same way, while we actually forgetting that all societies are not the same, all cultures, all our beneficiaries, all our patients are not the same. And things should be adapted according to their culture. I saw as well on the presentation talking about cultural barriers. And why? How are you going to handle them? Because if we don't know where they're coming from, we feel like they are not accepting the treatment. Yeah? But they are not accepting because we are not the one accepting the culture. And because we don't understand it. We tend to do things our way. So to make sure that we really reach the point where we want to be, we have to make sure that these aspects are integrated in our plans and look at the long-term vision in terms of capacity building for traditional healers and so on. Those one, I don't mean that we have to send our patient to them. It means that we have to help them to reconfigure, try again to reorganize, how to say, the patient behavior, the health-seeking behaviors. Because people tend to go to the traditional healers to take care of the children. But in the field, we tend to not include them in our program. And sometimes, I have seen that we are including TBAs, yeah? A traditional birth attendant, in our program by training them and so on, and also helping them to refer some patient to us. Because if we don't do that, then I think we are missing the point. So my point is, let's look at the question holistically by integrating the family-centered approach. Thank you.
Thanks, and thank you. And we had the opportunity to discuss with Ndesh and team about the vision for East Africa, and this concept of local rootedness was very strong, and sustainability. So I guess that's a little what you're alluding to in some of what you've said there.
Yes, thank you for that question, very specifically to Eastern Africa. Actually, Eastern Africa and Southern Africa, together with MSF Spain and UK, we're in the process of creating a OD, Operational Directorate, and it's called MSF Ubuntu. So we are at the moment working on a project which is actually taking kind of a direction where we would like to the medical approach, yeah, which is actually integrating as well the pediatric part, because we cannot escape from it. It is part of, as we say, part of our core activities. So pediatric is part of our structure for MSF Ubuntu. Locally rooted and acting globally, it means that we would like to understand what is in the culture, what is happening in the place where we are, and then use this experience to implement it somewhere else. Because what we see today in Ethiopia could be also applicable in Bangladesh. Yeah, so we are actually pushing on exporting our experience to many other places. Thank you.
Okay, thank you. I'm going to hand it over. I'm sure there's burning questions online and out in the audience, so I wanted to leave plenty of time for questions. And in MSF, we love debate. We pride ourselves on it. And these people all have very thick skins, have been around for a long time. So if you've got something you want to ask or push, now's your opportunity. So if you, please, when you ask a question, just again, let us know your name, where you're from, and if your question is addressed to someone specific or it's more general. They're all scared. Thinking about the main themes of the session and the ideas that we'd like to see operationalized. How can we embed those key themes into our operations, and how can we call on our leaders in operations to call to action? Because we've talked a lot, we've said a lot of things, but how do we combine those medical and operational fields? Thanks, Roberta. Go ahead.
We have heard a lot of super interesting topics coming over and over in this edition, in the past, and from your panel today. And we keep talking, and I'm very glad about that, of the importance of involving community, having the patient at the center. But despite being super important, sometimes it's difficult to try to understand what it means practically in our fields. And I think one of the big added value or take-home messages that I take home with me from this event is that we could see a lot of innovative projects that actually help to inspire others to see how they can, what they can do in their own projects to make this happen. So, but the MSF Paediatric Days happens every now and then, and it's specifically for pediatrics. How do you think we can get better in communicating successful stories and make sure that people actually pass from, yes, I have to engage community, to action? And we are doing it. I'm not saying we are not doing it, but I think we should be able to communicate more practical examples so people can get really inspired and operationalize it. Are we doing enough? This is a general question.
Any volunteers? Go ahead.
The simple response to that question would be no, we're not doing enough, in the sense that we could do more, a lot more, in fact, about either implementing things that we have already had as policy or as guidance, or strategic plans by the different sections. I think after or during the COVID, I can say during the COVID until now, there have been numerous, I would say, positive changes that have happened. So for example, we have webinars. I've started seeing exchange of information, exchange of ideas between sections. So sometimes I see something pop up in my agenda. I have no idea who this person is. I look at the topic and I see that it's OCB or OCBA or OCA presenting something, either an experience or to talk about something, certain subjects that before COVID, I can say that that was almost non-existent, apart from these in-person meetings that we do, as you said, they're not very often. So I think trying to maintain these kind of scientific fora / operations, meaning that having a melting pot of, being creative and saying maybe it's once a year, every 6 months, trying to have, a moment in time where we can actually discuss amongst ourselves. I think that's a practical thing that we could do. Second thing is that, is there cross-connectivity, meaning that we have, when there are initiatives that are being pushed by one section or another, or one mission or another, do we share? I mean, a simple example, we've been talking about prevention, and this is 7 years ago. We did what I would say was a really, really interesting and good project in Côte d'Ivoire, or in Ivory Coast, where we introduced hepatitis B vaccines in a country where prevalence of hepatitis B nationally was above, what would be the threshold for introduction of hepatitis B vaccination at birth. How many of you here know that we did this? Nobody. And this is basically in the entire Côte d'Ivoire, nobody before MSF vaccinated babies at birth with hepatitis B vaccine. It doesn't cost much, a few cents. We did this, piloted it. There are reports that have been written, so most likely either it hasn't gotten diffused, etc. So the question is, how do we improve together sharing of information, sharing of interesting experiences that we've seen in the pediatric days, but not to keep them in these great meetings that happen once every 2-3 years, but then how do we kind of create that fora where we can exchange, where we can share from our experiences?
Yeah, but just to respond to that, we're not even very good at doing it ourselves in MSF. We define ourselves by OC, don't we? I'm OCP, I'm OCBA. It's how do we shift that? I mean, you brought up some positive experiences, but I think there's a way to go in. Sometimes it feels like separate organizations, that we're talking about. And we are the same organization. So I think there's still room to move even internally, let alone externally. But I'll give the word to Monica on that.
No, it's a very valid point and question and concern, because we have grown too big and we are working on silos. So leave alone between sections, but I'm sure between cells within the same or in a mission. One project is not aware of what other project has is doing, or challenges, or models or approaches. So it's a big issue. I agree. I think there are valid opportunities and very valid moments, but I think we have to be mindful all. We have all responsibilities, and these people here at operations on how to be able to share experiences and create maybe not these big formal spaces, but some more spontaneous sharing. And I think it's the responsibility of all of us as individuals to really connect and, what is this initiative? And you have Hep E, there was a vaccination. You are people that are going through different projects. So it's everybody's effort and a mindful effort, because we are a big organization and we have to acknowledge that. It's very hard to, you have seen how many bulletins and how many platforms we have to share. And at the end of the day, we are not sharing the important things. So I think it's an individual responsibility. I think we have to do more, be more mindful, and continue thinking on what kind of spaces during your coordination days, your medical weeks, or specific days, but your debriefings, when you arrive to a project, share what you have done in the past. I think it's just the small work of the word of mouth that will help, because I think there is no other way.
Go, well, you can scissors, paper, rock, and you can decide who goes first.
Yeah, thank you. I would look at it in a different way, because for the last few years since 2016, this initiative is in place. It means every year we meet, there is a list of outcomes, recommendations, and so on. So for me, it's more about managing expectations on how these outcomes are transitioning from this room to the field, actually. Because when we're putting something on a paper like a recommendation is not a decision. It should go through a way, through a channel, for which someone has to validate it and make it actionable. And many of us are part of processes when we're discussing about annual plan, strategic plan, and so on, and project proposals. And for medical colleagues who are working specifically on the clinical guidelines and so on, you have a lot of opportunities actually to bring this point into those discussions and to make them written on stone in different documents. So sometimes it's not very clear how what we are discussing here is actually coming to the field. If something is in a strategic plan, it's already a good thing, because that is already saying that this is the direction of travel. But then from there, it goes to the country policy, and from the country policy to the project proposal for implementation. So there are quite a lot of things which many of us as contributors to all this process could do also. And also the same for our colleagues who are not part of MSF, but who are from the MOH or from different organizations. It's the same, and the same we do. We learn from the others and we bring it to us. So it's mainly on how we manage these expectations and how the outcomes are used from this meeting to the implementation in the field. Thank you.
Gul, did you want to?
It's very quick. Sometimes I see that at desk level, for example, how the flow of communication works between different sections. We are more aware about another section, activities in the country, than our country team, who is sitting there and working with the same section in the same city. So, you know, the flow of communication and learning, this cross-pollination between different sections, is something that we really need to improve on all levels, because we have different forums where we can also share experiences and where we can learn from each other. But somehow we have some reluctance that we stay within our sectionhood, thinking that this should stay within the section, while when it comes to such forum, we share. But then on day-to-day basis, we also need to learn from each other, and we need to have that open dialogue between different sections. So I just wanted to emphasize on that one also, because this is ongoing process that we do.
Okay. There any other? Yes. Tesh. Don't be too nice.
Thanks so much. My name is Teshome. Most of you know me as Tesh. I am working for MSF Okba, based in Nairobi. So I heard from this panel and also from the previous, most of the challenges we have are of mindset origin, lack of change in the mindset. Now for this discussion, I will be citing 3 examples where we say, at least I heard, that it is the mindset which is mainly contributing to. The first one is in the gaps in our operations that we have. Second thing is listening to our stakeholders, you know, whether it is patients, whether it is local communities, and also local organizations. And the third is partnerships that we want to do, especially when we think about also sustainable programming and handover. So we say we have the resources in most of the instances, but the mindset of how we do things still is not changing. So for me, the question is then, because this mindset has been raised by people in the field, people in the headquarters, people at the middle level. So the question is already acknowledged. So for me, the question is then, why we are struggling then to make this, change in mindset? Is it because maybe MSF is not that democratic the way we think, and we are getting autocratic and dictatorial leadership? Or is it because maybe MSF is too democratic and decision-making is given to the lower level, and then we are getting lost in the in between? So my question is, what can we do to, to bring this mindset? I mean, because it is us, I believe, who are making such changes over.
So an identity change, really, for MSF. So are we too autocratic or too democratic? Kennedy?
Yeah, thank you, Tesh. I think the nature of MSF and how we respond to the needs sometimes push us to not to change not to have that mindset that you are talking about. First, we respond to emergencies. And in many circumstances, I think we are driven by what we see before us and the lives that we want to save. So unless we have a policy change where we involve all the stakeholders, specifically the Ministry of Health, which is our major partner, and understanding their policies, regarding the implementation of activities and programs, then as MSF, we will continue to be in between, either democratic or not, but also just focusing on the needs that we see at the moment. I think this is the starting point. For example, if we look at, vaccination that we've been talking about, we had a talk yesterday. None of us talked about cold chain. None of us talked about what is the role of Ministry of Health in terms of planning. How are we involved in ICG in terms of, what are the priorities? The declaration of an outbreak, for example. As MSF, we are not even allowed to collect samples. What we will do is that once the outbreak is there, we will focus on the implementation and the response. So I think unless we work on policies and understanding the policies and get involved in all these aspects of management, then we will still do the same thing, whether it's whether it is communicated, collaborations that you talked about, unless this policy changes. This is what I think.
Yeah, and I think on the identity shift, though, it's also, I remember when I started with MSF, it was, what's your exit strategy? What's your exit strategy? It was in South Sudan. A 5-year exit strategy didn't seem very feasible. What about the entry strategy? Sometimes we focus so much about what we're leaving behind, we have these piecework projects that things have been added on rather than thought out from the beginning. How do we change that, or is that shifting within that sort of mentality shifting within MSF?
Yeah, thank you. Before coming to your question, from Tej's question, I would say we are both democratic and non-democratic. It depends on which stage of a process we are talking about. Because there are stages where actually we need everyone involved, bringing ideas, putting them together, and so on. And there should be a stage where we have to cut the crab and say, no, this is the direction of travel. Because if we don't do that, it means we will be stagnating, we won't move, okay? And if we don't move, it means we are not there. In general, what I think is that we should be flexible enough to adapt our decisions according to the situation, according to the context, according to the circumstances. Because everything is not the same everywhere. And depending on, because then we don't give a leeway to open door to changes which don't make sense or which are going against our policies, rules, and regulations. But I would say, as part of a management team, I would say the best thing to do is that we should design the main lines which would give the direction to the colleagues in the field anyway to say, if I have to close a project or start a project, this is the element I should be looking at. That we have those documents, right? But I would say we should look at the directions, not directional, but not, how to say, prescriptive. Yeah, because when we are prescriptive, actually, we are kind of killing the initiative. We are kind of blocking people who have a lot of things.
Yeah, just a quick one. In MSF, we always have this discussion that are we here for sustainable change or are we here for the emergency response and we leave? And this is what we always think. We are here to respond to emergencies. And the mindset that we are talking about and the policy change that Kennedy also mentioned, I think we need to have that clarity that we are here to save lives, but in parallel, when we are doing these things, there is also something that could also bring sustainable change, and we should do that. But our people refuse to do that while there's a small investment that we could do, while we can change the approach, that the way we are saving lives, and we can work with others to make sure that that change lasts longer when we leave. I think this is something that we are talking about, the mindset. I think this would also change with the policy, but also sometime and most often in my experience in the field, I have seen one person blocking everything, saying, this is not MSF. While no, basically MSF does lives change, save lives, but same time does things in a way that does not disrupt the current system that we are in. And when we are leaving, there is some change that we have brought in that continues after. And we can do that with a small investment and with the intent, which sometime we are lacking. And I think that brings, like, you know, as an MSF, who we are as an organization. We should not only focus on emergency response, only disrupting everything and leaving. We should also think about what we are leaving behind.
Thank you. From online or from you? Yep.
Yes.
Online question. Go ahead, Maria.
There's an online question. How can we ensure that pediatric and neonatal care are valued as specialty areas, meaning that projects are supported by pediatricians and specialized pediatric and neonatal nurses? This is essential for improving quality of care and developing the skills of generalists.
Okay, so I think that'll resonate with a few people in the room. I think it's true that, I mean, we have, as you've highlighted, the majority of our activities is pediatrics, and in every country, pediatrics, pediatric nursing is a specialty. It's sometimes not perhaps considered a specialty in as much as perhaps other specialties, say surgery. So the response to the question was how do we ensure that it's protected as a specialty, and we have people with a specific skill set to. Go ahead, Chris.
I think that the answer to the question was largely given by the pediatric working group a few years ago, where we came up with the neonatal packages, basically. So that means that you kind of stratify what level of, I would say, what level of care, you know, whether it's primary, whether it's secondary, whether it's tertiary, all the way up. And of course, then that would help you define what kind of resources you would inject inside. Why? Because in fact, what I've seen in contexts like that I was following before, like in Mali, in Niger, etc., there is a lack of human resources on ground, which means that you have to import those resources. It's not a question of protecting them. Yeah, we can protect them all we want, but tomorrow, if we say we need full-time 3, 4, 5 pediatric, so neonatologists, I'm not so sure that we have that many people who are available, who are, able to go into these contexts. And not even adding, this is a pretty much medical operational discussion that we've been having for 2 days. We haven't talked a lot about the different contexts where we can't, for example, what happened in Jahun, what happened in places like Putiala, this famous profiling. So you say, well, we can't send anybody who's not, African descent. That cuts off basically a large chunk of the people who are may be available to go to these projects. So the question then is, how do we calibrate our project and adapt it to, one, the medical need in and of itself, but also, the constraints that we have. And I think people do appreciate, I think the projects that I've seen, Mararumfa, Kutiala, Jahun, we do really appreciate the pediatricians that do work in these projects and the nurse specialists that also contribute to really keeping that level of care where it should be. But I think that's just that constraint that we have. So either we say, well, we cannot, in this context, we cannot. So what is basic minimum that we can provide in this context? And then keep going up, depending on, obviously, if you're in Iraq or if you're in other contexts where we have a lot more resources, perhaps we can do as much as is possible, so to speak. Thank you.
Well, there's a lot of... Monica and then Kennedy. Go. Do you want to go, Monica, and then...
More than an answer is an anecdote from a non-medical perspective. I had the privilege to work with 2 of your facilitators, with Anders and Dr. Nicola, in a very, very difficult project, specifically and very focused on neonatology in 2014. And I'm very glad to see the progress, that many of the challenges that the teams were facing in terms of everything, resources, protocols, different approaches, it's been discussed, and it shows that the priority is there. It's something that it was very easily to be told, close that, because it's extremely challenging. We are talking about very, very difficult challenges, and I'm very glad to see the progress that we have made and how it's not only prioritized, but how we have moved forward and advanced a lot. So as well, there is a lot of, I think, very clear evidence that it is a priority. It has been prioritized, and it remains there. So,
Kennedy, did you have something?
Thank you. Yeah, I just wanted to mention something. Dr. Chris talked more on it, but I think the location of our projects, where we are, they are in secure areas, in conflict areas. And, neonatology, you need skilled resources. How many of those skilled resources will be able to come to those projects in those insecure areas? So I think we need to start thinking on how we can have, building capacity and training of the local Ministry of Health staffs. We have a new aspect of decentralized care model. Why don't we introduce also SRH in those areas? Because we work in the main hospitals where patients already in critical conditions are being referred to. So we deal with the situation at a later stage. So I think we need to also start thinking on how we can have local capacities, because getting those skilled resources in those insecure areas will not be easy. Thank you.
I think I'm okay. I think I've got a minute. Yep.
Yeah, it's a quick one on this question. I think we have a golden opportunity coming up. Our strategic plan cycle will resume the new one is starting in 2026. And it means from now to 2025, there will be a lot of discussions on new strategic plan. It's a good opportunity for all of us, actually, to push on having this clearly highlighted in our strategic plan for all sections. Thank you.
Thank you. And I'm getting the, okay. we'll just start to summarize some of the key themes. So again, the resounding themes throughout these 4-5 main sessions have been preventive aspects of preventive care, which is a bit of a mind shift, I think, for MSF. Providing care across the continuum of care from maternal, newborn, child health, making sure that we're not missing gaps. Integration of care, so combining maternal and child health interventions and sustainability and working in collaboration with other actors. And it's easy to put that, I think, on operations. But I think what we've also seen in these key themes is we've got so many missed opportunities that we can already, all of you can already all be doing. And I think Kemi brought that really to the forefront in the HIV session. But in the vaccination session, we saw a study that, you know, people coming to our facilities aren't being vaccinated. So that's something you can go home today and do. So vaccination, early infant diagnosis and treatment, and in the nutrition section, making sure we're addressing maternal and newborn aspects of nutrition. So I just want to quickly put it through to the panel members. Your, I guess, messages for the group here as primarily representatives of the field, what would be your key messages for what people can do? What can we do now, concretely take away from these few days?
From my end, you summarized it well, and I will say a bigger effort on sharing those experiences. We have to lean on Ministry of Health. They are the ones that are able to trigger and extend those achievements that we are having. So we really need to be more at field level, at capital level, at regional level, at a global level. So we need to improve our engagement on the achievements that we are doing day by day.
Yeah, for me, the simple is MSF does things within its limitation, but we also need to ignite change, and we need to make sure that we pull in others, and we also hold others accountable to what they are mandated for, and to have the wider impact of what we do and how that replicates elsewhere also through other stakeholders that we can bring that change. So for me, looking at the PEDS, children's are the most vulnerable. And MSF does that, as we say, like 50% of our program is anyway focusing on pediatrics. So what kind of things that we can do ourselves and also show it to others so they can also learn from us and we can learn from others and bring that bigger change, because we are limited in our resources and we do limited things, but we can also have wider change that we can influence.
Yeah, from my side, actually, I would like to repeat what I just said now. We have an opportunity to add a lot of things in our strategic plan. As you know, if it's once in the strategic plan, it means it will follow up to the field. So in all the discussion you will be having in the coming months on the strategic plan of your respective OCs, please bring this to make sure that pediatric is part of the core activities, really highlighted as something specific, and it will be implemented. The second thing is that, as Gul just said, our resources are not limitless, which means let's do with the minimum we have, but try to get in touch with the community more in depth to understand their needs and then act with what you have. Thank you.
For me, I think I'll just use single words to capture basically what I have picked up from these last 2 days. Collaboration, transparency, synergy, zero separation, learning as well, sharing, and I think, you know, this mind shift that we were talking about as well, like I think it starts from us as individuals. So I think we should get to it, meaning that as you leave, if you can share with someone, share it. If you can involve someone, then involve them, ask questions, and let's see how to, you know, kind of get momentum to move forward.
And zero separation's 2 words, but we'll let you have it.
For me, I think we need to work on, you know, advocacy and also involving policy changes so that we could have chance to implement our activities with less, pressure, because in many areas where we work, we respond to outbreaks, but we are not part of the policies that are being implemented. We are not part of the international community where policies are being amended. So I think this could help us in future and advocate more for other organizations to also come in our areas where we work.
So with that, I'd like to thank our 5 panelists. I think I take the sign that you're up here today and participating in Paediatric Days as a sign that you're truly invested in pediatrics and the place of pediatrics within MSF. So thank you for joining us today and joining this discussion.
All right, I hope you don't mind we let that session run over a little bit, because it's really why we're here. Obviously, we're here to learn, but we're really here to drive operational change as well. And I think hearing from Yanusa before then as a PID talk really shows that, because our very first PID days, we talked about sickle cell disease, and then it's been operationalized, and so we hope that for the future. Now, next, I have the pleasure of inviting Dr. Roberta Petrucci back to the stage as leader of the Paediatric Working Group, and which is why she has the very tough job of summarizing the last 2 days in, I think, 10 minutes. So good luck.
What a fantastic journey. These last 2 days for me were amazing, and I think from the energy that I feel from the audience and you all, you agree with me. It has been 2 days of exploring new perspectives, sharing experience, idea, but also meeting new friends. And I really hope that most of us will go back home with contacts of friends and colleagues from another project we can keep in touch with. People that we have been meeting on the screen for ages and never met before. So I think it was a great human experience. I personally think that half of the value of such an event comes from what happens out of this room. You know, all the exchanges we have. So I'm very glad that we are back together after a couple of events that were online. So just to give you a few figures, we are about 260 people in the room, but we shouldn't forget that we have 1,400 registered participants online. I really would like to thank those that attended online, because we know how difficult it is to follow. So thank you for being with us. I find, again, very inspiring to have the opportunity to be physically together with you. Thank you very much for being here, but especially thank you very much for being so active and so engaged. I have the feeling that compared to previous edition, people maybe before were a bit more shy, but you have been amazing. So the richness of the discussion was really completing very nicely what was happening on the stage with the amazing speakers we have. So I would like to ask you to stand up, because I think you really deserve an applause, and I think you're so beautiful. I will take you a picture. So well done, guys. And now back to the hard task of trying to summarize some key messages. So key message number 1 will not come out of a surprise. It's going to be, we have to keep mother and child together. I don't think we're going to repeat it enough until we actually see each mother and child physically together. But again, it's not just a matter of physical proximity. We need to remember to keep them together in the health journey that they will have. There is no healthy child without a healthy mother, and the other way around is also true. So keep this in mind. It's true for many topics. It has been mentioned, basically, if I remember well, in all topics that have been touched over the 2 days, from nutrition, vaccination, neonatal care, HIV. And thank you for the HIV people, because I think it was Esther. We always talk about newborns and children being with the mothers, but actually the adolescents, during their journey for autonomy, they still need to be backed up by their parents if they have to face difficult health challenges. So that was something new to increase the scope of this keeping together children and their parents. How does this look like? Because this might really look different in different settings. There might be some opportunities that are really straightforward and easy. Some other contexts where it's a little bit more challenging, but I think we had plenty of nice ideas and projects that we have been listening to over the last 2 days. I will mention again, it's not needed, but zero separation. I think it's a great opportunity, as I mentioned before with my question, to pass from a concept that it's very nice, that we all endorse, etc., to concrete action. And this is something that more and more we see it's easy to implement, it's cost-effective, and it can be done at many different levels. You don't need to build a new building, you know, to host, but you can do it from starting tomorrow when you go back to your projects. And this is also an opportunity, the zero separation, to reinforce another key message, I think. We should really see our patients, the people we work with, and the community we work with as partner in care. They cannot be just recipient of the care we provide. And this is an operationalization of the concept of patient-centeredness. They should be seen as partner from the definition of the project at the beginning when we discuss with the community what and how we are supposed to move on, until the very last point, like the bedside of the patient, when we discuss with the mother, and I really think the mother should be considered part of the health team, part of the team along with the doctor and the nurse. She's a care provider, and she's an essential care provider. And we shouldn't forget that also children should be partners whenever feasible, when they are old enough. We should listen to their voices, and we should enhance their participation in advocacy activities. Our humanitarian action cannot be successful if we don't involve patients, people, community. That's a key message. If there is one message that you will bring back to your project, I think it should be this one. Key message number 2. Well-being, physical and mental health, nurturing care, opportunities to thrive are as important as survival, even in a humanitarian crisis, even in unstable settings. We have heard yesterday morning, the very first thing of these pediatric days, how important it is to invest in the first 3 years of life, because this has an important effect on the potential of the person for the rest of his life. So for very long, we have been mainly talking about mortality, and I'm not saying it's not important. Of course, this is the key of our medical activity, but saving life, it's not enough. We need to do more. And honestly, during these 2 days, we heard many voices from the field telling a story on how we can do so, how we can take care of the child in a holistic way. We have very concrete examples. I think you were as touched as me by the testimony this morning of Ahmed from Amman, and how mental health care really had a huge impact on his life. And I was about to cry. I feel I was not alone. Really, to see his healing journey and how we could accompany him was really, I think there is not much more to say. But again, we had other testimonies on the importance of holistic care. We discussed about psychosocial simulation, play therapy, physiotherapy, safeguarding, child protection. So all of us, we are going to go back home with plenty of ideas. Key message number 3. I think we need, no, I don't think. We actually need to think differently and look for innovative solutions. During these 2 days, we have been discussing about several infectious diseases, diphtheria, HIV, TB, polio, measles, and vaccination. And these are topics that are at the core of our actions since maybe forever or decades. And we are still here today discussing about how we can control outbreak, how we can do prevention. And prevention, we are not getting any better. We are still struggling very much to integrate systematically prevention and specifically vaccination in our activities. But the message I take home from these 2 days is that despite still being here discussing our topics, we have again many examples of innovative approaches that can be used in a daily activities to make things better. I think the tactic example, you have been heard about tactics quite a lot. It's a great opportunity to see how we can boost TB treatment, TB diagnostic, TB management in general in our project, especially pediatric project, but along with many other examples. Another example, key message. It might seem obvious, but MSF doesn't work in a vacuum. So there is a humanitarian landscape, including a multitude of actors from MOH, UN agency, other partners, and NGOs. I've been myself in several cluster meetings. It's painful sometimes. So it's hard, but it's essential if we want to fulfill our humanitarian ambition. When we are talking about continuum of care, quality of care, patient-centeredness, sustainability, how are we going to do it alone? It's just not possible. But this is a relationship, and like all other relationships, we need to build it. We need to nourish, we need to cherish it. It's not one, I was about to say nightstand, but probably it's that we maintain the humanitarian space, that we are fast in our reaction, that the negotiation is done before. It has been repeated several times. I guess many of us, many of you, work in clinical practice, so maybe you don't even know what a cluster meeting is. But it doesn't matter, because I'm sure that you all meet the colleague from UNICEF that works in the nearby village, the MOH epidemiologist coming to ask for data, the colleague from another NGO that works in the health center. We all interact with other partners. So keep this in mind, and all of us can build this relationship on a daily basis. So we are at the end of this 6th edition of the Paediatric Days, but I would say this journey doesn't finish today. I would say the journey starts, because in a few days we will all go back to our work, and we will all have new ideas to share, new projects, new perspective that we can bring back to our colleagues. And I'd like to think that all of you will be champions of some of these ideas to start from tomorrow to build up on quality improvement in your project. Start thinking what you can do. Simple, easy. Starting back soon, and the first step is going to be share with your colleagues what you learned today. So, and be the champion of, for example, zero separation. But we also believe that Paediatric Days can contribute to the broader reflection on humanitarian pediatrics within MSF, but also externally. So as we usually did for other editions, in the next few weeks, we will work along with the speakers to wrap up the key messages and share with you and externally to make sure that we capitalize the discussion that we had during these 2 days. I also highlight that this is our event, your event. So in the near future, we will also receive a request to give a feedback, but also to suggest other topics for the future. What do you want to talk at the next Paediatric Days? But I will go even further. How do you want to talk about things? Which is the modality that really talk to you? Because I can tell you, I think I made it already quite clear, if you ask me, for me to listen to the successful experience, successful stories from the field, it's super inspiring. Because again, we all like to talk about patient-centeredness, community engagement, these big topics that are essential, but how do we do it? It's super complicated. And sometimes it feels so abstract that we kind of give up. So we need to hear from others how they did it. So for me, that's the format that probably we should increase a little bit, but we want to hear from you. What do you think? Which is the modality that really you find useful? So I'm at the end. I'd like to thank you all, of course, for making this a very special event, also for contributing to future edition. But I also need to thank some people among you. So first of all, I'd like to thank our amazing Master of Ceremonies, so Nicola and Andesh. Thank you very much for your enthusiasm. Andesh is so enthusiastic that he's also doing kangaroo mother care right now in front of me. So if I can call it a success, this is the picture. I will come later. So on the behalf of the Pediatric Working Group, I also would like to really thank our sponsors, so MSF Sweden and MSF Spain, that believed in the past at the very beginning in the Paediatric Days. They keep believing in the Paediatric Days, and they make this possible, so thank you very much. I also would like to thank Christian, that is the medical director of OCBA. Christian has only one defect. He's not a pediatrician, but he makes up by being a great supporter of pediatric and neonatal within the movement and in the medical director platform. As far as I remember, you've been attending all the edition of the Paediatric Days, at least the ones presenter, so it's not obvious. And he's also a great champion for zero separation. So I don't think what else we can expect from you. And he's not even the focal point, the medical focal point for our working group. So thank you so much. I also would like to thank some people that have been behind. And you might not figure out how much it takes in terms of energy and investment to build up these Paediatric Days. But I would like to thank the members, the other members of the steering committee. So Mia, Tesh, and Nandesh, if you can wave so people can see you. Thank you so much, guys. And last but not least, if we are here today, it's because of three wonderful ladies that have been working massively since many, many months, but especially in the last few weeks. I think the number of hours they slept all together in the last few days is very small. So thank you very much to Nadia, and I ask you to please stand up. Maria and Sheila, the wonderful ladies over there. And thank you all. As usual, it was a great pleasure, a great honor to be here at this 6th edition, and I hope to see you all at the next event. Thank you so much.
All right. So... Thank you, Neil. Before we continue with some more thank yous, I have the pleasure of announcing the winners of the poster voting. So just to disclaimer, there are no prizes. It's just, a tap on the back and a round of applause. So the prize for most colourful and visual goes to poster 59, morbidity patterns and factors associated with mortality in ITFC and ABS Yemen. So well done. Needs a prize, yeah? All right, and the most innovative is a tie, so 2 posters for this one. So poster 82, decrease in diarrheal illness consultations after introduction of portable water treatment system in Mart, South Sudan. This is shared with poster 124, the impact on PTB diagnosis implementing new algorithms in Maiduguri, Nigeria. And in the third category, most likely to change practice, poster 97, translating the MSF play therapy toolkit into practice in the west coast of Yemen. But really well done to everyone who submitted a poster. The standard this year was amazing, and there were so many interesting, innovative things that people are doing. So please do make sure, if you haven't looked at them all, to look on the online app so you can see them all. And then the last logistic announcement from me is a reminder for workshops tomorrow. If you have registered, please make sure you attend. A lot of effort has gone into organising these, and they are set to be amazing experience and learning opportunity as well. So even if it's rainy tomorrow, please make sure you drag yourself out of bed and come and learn some more before we finish. All right, so now on to some more thank yous. So firstly, to the hosts of the event, so to KCB Leadership Centre for this great venue. Also to MSF East Africa, and particularly Roland and his team, thank you so much for all the work and effort you've put into hosting us, as well as the OCBA Nairobi office with Paul. We really do appreciate this. It's been a great location and a great venue, and thank you for all involved in hosting us here. So.
And there were more MSF technical groups engaged in preparation to the Paediatric Days, the Pediatric Working Group, the Vaccination Group, HIV Working Group, the Nutrition Group, Nursing Care Working Group, and the Content Committee, who were involved in organization of the two main sessions, vaccination and HIV, and the Extended Committee for reviewing all the abstracts, and involved in the selections. Thank you very much. And all the speakers and the presenters who have been here with us, thank you. Yeah. And we have trainings being organized tomorrow, and thank you for the organizers of the training as well, and the participants.
Now, a lot of logistical support goes into an event like this, so thank you to Seamless for the streaming and technical support and translation. You certainly lived up to your name, so thank you. To Crowd Comms for the amazing virtual platform. It certainly was really easy to navigate, and hopefully the online participants would second that. To all the volunteers that have been floating around, who we forced to aggressively ring bells to drag you back, to the East Africa office, to IT, procurement, comms, and to the Berlin Knowledge Lab. You may not have noticed what they were doing this week, but certainly the things they were doing will be crucial afterwards. So they were recording poster presentations, doing sound bites for our key messages for the speakers, and videoing the skills station. So they'll all be available afterwards, which will be a great resource moving forward. So thank you to all the logistics team.